intestinal differs with its site of origin, since the excretion of the bile begins after the 11th week and squamous epithelial cells swallowed from the vernix and caseoida are found in the intestine after the 12th week. The presence of these elements in the intestinal distal to the level would indicate that the occlusion occurred sometimes after the 11th or the 12th week of fetal life. More possible explanation is as a consequence of, as mentioned, as a consequence of intrauterine mesenteric valvular vascular accident secondary to the volvulus incarceration in the prenatal umbilical hernia or the intussusception. More proximal the mesenteric vascular compromise, greater the resulting severity of the intestinal atresia. The extent and the severity of the histological features depend upon the time of the development of the obstruction and as well as the site of the involvement. Mucosa and the submucosa are more susceptible to the ischemic injury than the muscularis. Injury to the full thickness of the may result in the perforation, while if it undergoes healing, the mucosa and the submucosal injury, it undergoes healing, it will be healed by scarring, resulting in the formation of a cord or the septum. So which can cause which can be presented as a atresia or the stenosis. The histological features, as we have seen in our case also, there will be flattening of villi, mucosal, submucosal congestions, mononuclear cell infiltrations, and intravascular proliferation. Features like presence of laryngosquams and meconium distal to the atretic segments, it indicates that it happened sometime after the 11th or the 12th week of gestation, which rules out the other etiological factors like failure of recanalization of the intestinal lumen. As also to mention was a study done by Pandey et al., which found that the functional intestinal obstruction is the most common complication post-operative, and which leading to the ineffective peristalsis, which causes a grossly dilated atretic segment. Concluding that the bowel proximal to the atresia is abnormal for the varied length, there might be some defect in the muscularis, which can cause the dilatation of the intestine. There will be no peristalsis, so it can cause a functional obstruction. So in our it has to be resected. The varied length has to be resected at least up to 10 centimeter above the obstruction.
Dr. Amrita, your time is over.
Yeah, I'm finished.
Thank you.
I just have to show my references.
Yeah. You have done in this particular case, antenatally you diagnosed this case.
Yes.
Correct? And you
radiological diagnosis.
Radiological diagnosis. And you operated after 24 hours. Baby delivery.
After one day, yeah, mostly it was after 24 hours it was diagnosed, and maybe after 2 days.
No, you diagnosed it antenatally, no?
So it was Hirschsprung's disease which was diagnosed antelatally,
okay.
And our cases of distal intestinal atresia. In Hirschsprung's, it is a functional obstruction, intestinal obstruction. It is our case is a mechanical obstruction.
Then you have done a ileostomy or colostomy in this patient, or direct end-to-end anastomosis? End-to-end anastomosis. But routinely they do in 2 phases. No, first is a colostomy, and then in the second case, when the diagnosis is confirmed by histopathological, they do a second surgery.
Yes, sir. I don't know about the surgical aspect actually. They might have done, because it was mentioned that they had done end-to-end anastomosis. Sorry. So Hirschsprung's, we have to do anal biopsy. So suction biopsy has to be done through anal route, and which will suck up to muscularis. We have to see whether the ganglionic cells are present in the muscularis proprial layer. So that is the deformity in the Hirschsprung's disease. So that is the diagnostic.
Pertaining to the difference on the histopath, or it is just a mechanical, you thought that it's all mechanical and they just did that
Hirschsprung's, we can find it out in radiologically also, and histopathic is a definitive.
Our radiological diagnosis is Hirschsprung's.
Yes.
Definitely. And our histopathic diagnosis is of course a mechanical.
Yes.
And
so it was antenatal actually. Postnatally the scans was done. The distal microcolon was found.
How you could understand there is a vascular insult into this?
So because we could find this lanigose squamous epitheliums, bile, which secretes around 11 to 12th week of gestation, and it was found distal to the obstruction. So presence of this material distal to the obstruction, it clears that this has happened sometime after that period. So
it's not on histopath. It's on our clinical presentation. It's not on histopath. You didn't find any thrombus or something in the histopath.
So histopathologically, this is the way which we can tell.
Thank you. Good.
Yes.
Okay. Thank you very much. May I call the next presenter, Dr. Prajakta Patil, please.
A warm good morning to honorable judges, respected senior colleagues, and my dear friends. As we know, nasal blockage is one of the common presenting symptom in every one of the clinical practices. And deviated nasal septum are the common causes of the nasal blockages. And septoplasty is a surgery to treat those. Conventionally, we know that rhinoplasty is a surgery done by cosmetic surgeons for cosmetic improvement. But nowadays, what we call as functional rhinoplasty, where we improve the nasal functions, also is being done for few selected group of patients. Functional rhinoplasty is also called as septorhinoplasty in ENT people. So let's begin with. Now, nasal blockage is one of the commonest presenting symptom, as we all know. Causes may be different, like external deviations, deviated septum, hypertrophic turbinates, nasal typtosis, allergic rhinitis, and other mucosal causes along with nasal masses. So septum, as we know, it is made of cartilaginous part and the bony parts of perpendicular plate of ethmoid and vomer. We have to find out that the nasal valve is one of the major cause of nasal obstruction, which is not being given proper importance. We have two nasal walls. This is internal nasal wall and this is the external nasal wall. Can I take a minute? माझा cursor फिरत नाही. Okay, I'll continue till then. So internal nasal wall is located here, where it is lined medially by septum, superiorly and laterally by the lower lateral border of the upper lateral cartilages. The measurement of the valve is measured in degrees. It is about 10 to 15 degrees. External nasal wall is present at the vestibule. It is medially lined by the medial margin of the medial crus. The causes may be varied, like trauma, radiation, congenital weaknesses, aging, and previous surgery, which is called the collapse of these valves. Now, deviated septum. What it causes? As we know that airflow occurs from anterior and inferior part of the nasal cavity like this. Anything which blocks this will give to obstructive symptoms. So nasal blockage can be unilateral if it's septum on one side. If it's a septum, then blockage can be bilateral. It may lead to recurrent rhinitis, sinusitis, epistaxis when the sharp spur is present where the vessels stretch out and lead to epistaxis. Anosmia if the airflow is not going up to the superior olfactory area. And otitis media of recurrent rhinitis occurs. Causes of DNS may be varied, like trauma, maybe sports injury or the assault injuries or bird trauma. Congenital causes like cleft lip and palate. Usually there is growth variations between different components of the face, like septum and bony cartilage and bony part, which lead to septal overgrowth. Types of DNS are very varied, like C-shaped, S-shaped, anterior caudal dislocation, the sharp spur, and septal hematoma may lead to septal thickening. This is the Mladinas classification, which is commonly used. These are few cases where septal deformities can be seen, S-shaped septum and turbinates hypertrophied. Here is one septum where the contralateral side is straight. On the one side, there is a sharp spur with maxillary polyp is seen. Now, nasal valve area being the narrowest part, various static factors and dynamic factors control the airflow. Due to Bernoulli's phenomenon, at the narrowest part, the pressure is decreased due to airflow increase, and there are nasal obstruction symptoms occurring. because of collapse. Now, Cottrell's maneuver is used to diagnose if the patient has nasal wall blockages. The patient is asked to put a few fingers over the cheek area and pull the cheek towards lateral side on the side of obstruction. If improvement is seen, then we say that patient has nasal blockages at the valvular area. This is modified Cottrell's test, where when the external ring curate is placed at the external lower alar cartilages and pulled outside, if improvement in obstruction is seen, it is due to external valve obstructions. When the ring curate is placed on the upper lateral cartilages and they are pushed slightly outwards, if obstruction is improved, it is due to internal nasal wall obstruction. A nasal obstruction and septoplasty efficacy score was asked to be filled by patients prior to surgery and post-surgery after 1 month. Various gradings were done. It was recorded according to the nasal congestion, obstruction, trouble breathing through the nose, trouble sleeping, unable to get enough air through the nose. When the septum, which is deviated, is to be operated, if it causes persistent nasal blockages, if sleep apnea is there, mouth breathing, recurrent epistaxis, olfactory disturbances, sinusitis, and if external deformity is there. Allergic rhinitis patient primary line of treatment is not the surgeries, but it has to be done if gross obstruction to the airflow is present. Methods, it was a study conducted at our home hospital between 2015 and 2020. Inclusion criteria of patients were with external deviations, patient with no improvement or minimal improvements on medicines with high DNSS, internal nasal wall blockages. Our exclusion criteria were present having allergic rhinitis and patients with previous surgeries. Consent was taken. At outpatient, no score was obtained. Physical examination to note external deviation, rhinoscopy to note deviations, and Cottrell test was performed. Open approach septoplasty or septorhinoplasty under GA was done in all of the patients, where inverted columnar incision and marginal incisions were taken. Alar cartilages exposed with the upper lateral and septum was exposed till the nasal bones were exposed. Then we separated the alar cartilages and the mucopericardial flaps on both of the sides were elevated. Upper lateral cartilages were separated. Deviations noted after the septum was dissected from the posterior bony and inferior maxillary crest bony attachments. And after observing the deviations, the dorsal 1.5 centimeter and the caudal 1.5 centimeter of the septum was kept for the stability and structural support, and the rest of the deviation was removed, as in submucosal resections. This is how conventional septoplasty is done. We remove all the bony deviations as well as cartilaginous deviation. Osteotomies, paramedian, transverse, and lateral osteotomies were done. From the removed excised cartilage, we mix Prader grafts, which are put parallelly on each side of the septum between the upper lateral cartilages. As we can see here, we can get improvement in the nasal valve area. Batten graphic if external blockages were found. Suturing was done, nasal packing was done, and plaster casts and sutures were removed after 10 days. After 1 month, the no score was obtained. Because patient with septorhinoplasties tend to have edema, it gets settled by 90% at approximately 1 month. So we took no scores at the end of 1 month. Significant improvement was seen in all 25 cases. Almost 45 to 50 point improvement was seen, which was statistically proven, and it strongly correlates with obstruction and patient satisfaction. Simply put, that as the age-old dictum says, as goes the septum, so goes the nose. If patient has any external deviation, he is most likely to have deviated nasal septums and most probably is having the valvular area obstruction. These are few patients with external deviations which had valvular obstructions. On correction, we could give them good external results along with cure to their obstructive symptoms. To conclude, septorhinoplasty is to be done in patients having high DNS, patients having valvular blockage, and patients having external deviations. Rest of the cases with only posterior deviations or spur can be cured with septoplasties. These are my references. Thank you, everyone.
Thank you. Thank you very much for keeping in time.
Thank you, sir.
One thing I would like, if this is your study, you have studied only, you have done septorhinoplasty.
So in cases...
and not done another subset of group where only septoplasty is done. So, and then there should be comparison between this particular subset and another subset.
Right, sir.
So you have done 25 cases of rhinoplasty.
Yes, sir.
And you have come to the conclusion that that is better than septoplasty, isn't it?
This is well known that we all know that in internal nasal valve blockages, we go on for septorhinoplasties. But conventionally, even we ENTs tend to miss the point and go for septoplasties. So my point of this study was, We really get good improvement by doing septorhinoplasties in such cases of valvular blockages and high deviated nasal cases. So we should go for these cases. The point of my study was to impress upon the fact that there are few cases, there is a subset of septoplasty cases which have to be undergo the septorhinoplasty operation rather than only septoplasty. The point of my study was in only this much, to mark the importance in few cases.
Okay, thank you.
Thank you, Adib.
Okay, thank you. Our next presenter is Dr. Nikhil Gorni. May I call upon Dr. Nikhil Gorni, please?
Hi, नाही व्हिडिओ Good morning, everyone. Good morning, judges and all dear colleagues and seniors. So today, actually, I am presenting a case which we did recently. It was a uniportal thoracoscopic thymectomy. This was a case of myasthenia gravis, which was not responding to medical line of management. And on evaluation, the patient was found to have a well encapsulated thymoma. And we had given the options of thoracoscopic thymectomy as well as sternotomy and removal of the tumor. My anesthesiologists were Dr. Sheetal Desai and Shirish Pawar, and thoracic surgeon, my colleague, Dr. Amit Patil, assisted me in this case. So thymectomy is indicated early, usually in the routine management of generalized myasthenia gravis, as well as with those with pure ocular involvement. So it is routinely not indicated in case of myasthenia crisis. It has to be tackled with first, and then only electively it should be done. Optimum medical control is very important preoperatively, especially immunosuppressive agents which patient is on, as well as if required most of the times we should do plasmapheresis to prevent any post-operative complications. Maximal thymectomy is what is routinely practiced, is not only the thymoma, it should be entire tumor around the entire thymic fat around the tumor should be removed, which induces a good patient clinical improvement as well as remission from myasthenia gravis symptoms. Video assisted thoracoscopic surgeries, they produce equivalent post-operative mortality and complete stable remission rates with superior results in terms of hospital stay, the severity of pain, operative blood loss, and patient satisfaction. So there are different approaches which are done for thymoma, like maximal transcervical approach with maximal neck extension. This open, but it's very difficult to reach below up to the arch of aorta. Classical stance tunnel sternotomy incision, where a patient has to undergo long, prolonged hospital stay, and many complications like pain and bleeding are possible. Extended transtunnel video-assisted thoracoscopic surgery is what routinely practiced. This is multi-port, actually 2 or 3 ports. We have converted now ourselves to 2 ports or single port thoracoscopic surgeries, and nowadays RATS, that is robotic assisted thoracoscopic surgeries. This case was a 40-year-old female diagnosed to have myasthenia gravis, most generalized symptoms, and one episode of crisis which was managed well. And after 2 to 3 weeks of that treatment, patient was referred to us. CT scan was done, which showed well-defined soft tissue lesion noted in the anterior superior mediastinum. It was around 3.3 by 1.8 by 1.6 centimeter and was likely suggestive of thymoma. Perioperative management included steroids, immunosuppressants, and preoperative one setting was done of plasmapheresis, and intraoperative titration of muscle relaxants was done by anesthesiologists. Patient was evaluated preoperatively and was planned for thoracoscopic maximal thymectomy, single port VATS, consented for post-operative respiratory complications, which are very common. Crisis and re-intubation were explained, as well as diaphragmatic palsy, which are technically we see sometimes due to the phrenic nerve injury. Surgical duration was around 60 minutes, selectively kept on a ventilator for 24 hours. Post-op pain control was excellent, no respiratory complications, and no episodes of re-intubation were seen in this patient. And she was discharged on post-operative day 4. Final histopathology report was encapsulated tumor, that is Massaoka stage 1 thymoma. So this is a short video of what we did. This is a CT scan showing the well encapsulated thymic tumor very close to the main pulmonary trunk and the arch of aorta. This was the patient in supine little right left side up position, and mid-axillary incision was taken in the 5th intercostal space, and the dissection was done to enter the intercostal space. We created a mini thoracotomy of around 3 centimeters, and this sleeve was used to keep the incision open and avoided contamination of incision. Single lung ventilation was used. On entering the thoracoscopy, we found this tumor just near the heart. This fat, you can see the pericardiac fat, and the phrenic nerves usually lie just like that. This is the advantage of single port surgery, just mini thoracotomy, and 3-4 instruments can easily go in that, and manipulations, 2 assistants usually, and a surgeon. So I'm sorry, directly video was not taken, it was just shooted on mobile. So this is a thymoma which is getting dissected with the aim of keeping the phrenic nerves on both sides away from the tumor and to safeguard them, because they will the injury to the phrenic nerves will add to the respiratory complications, which are always anticipated in post-operative management of thymoma. So this is the energy devices which we use for dissection. Some blood is seen, it is actually magnified images, so it's very minimal, 5 or 10 ml blood loss maximum. You can see the pulsations of internal mammary artery there near the chest wall. This is the chest wall. This side for the orientation is the root of neck. We are going from the left lateral approach. This is the heart, and lung is collapsed on left side. So this fat around the thymus is being taken. We are not going very close to the tumor. So these are special instruments which are used. As it was encapsulated tumor, it was very difficult to hold. That is why we are holding with the perithymic fat. So underneath will be, the slide will come, there will be the arch of aorta, which will be in very close association below. So this you can see the arch going there, coming out from the heart. So somewhere here in this bunch, there are the phrenic nerves. We did not actually dissect it because there was a lot of fat surrounding. But sometimes if we are not sure, we use the nerve stimulators to see, as we have the advantage of thoracoscopy, and directly we can see the diaphragmatic movements by using the nerve stimulators. By stimulating the phrenic nerve, we can see the diaphragmatic movements. So it was in very close association with the aorta, which is now dissected out.
Sorry to interrupt, Dr. Nikhil. Your time
Just
is
a
up.
minute. It's almost done. It's only half minute. Just specimen delivery and. So this specimen getting delivered out of incision. So this is the final bed with right phrenic nerve, left phrenic nerve, left lung, thymic bed, root of neck, and the arch of aorta down there. So innominate vein and the specimen. So these are the advantages: less trauma, speedy recovery, better cosmesis, reduced length of stay, reduced blood loss, patient satisfaction, and reduced post-operative complications. Thank you.
First of all, congratulations for doing such a wonderful surgery. I think it's a very delicate area, a lot of important structures there.
Yes.
So I would like to know, are there any other applications of this method?
Yes, we have now started doing uniportal thoracoscopic lobectomies for carcinoma of the lung, metastasectomies for limited oligometastatic or single metastasis from the colorectal cancers or breast cancers, where they have a good disease-free survival except for only single metastasis. In those patients also, without opening much of thorax, because by doing major thoracotomy, it takes half an hour to open, half an hour to close, and that actually creates a lot of pain post-operatively. Patients will not breathe well. So this is the best thing. And in this uniportal, which is very important, is only single intercostal space is breached. So the pain as compared to breaching 2 or 3 by using multi-port is less as compared to single.
How about retrocardiac structures and inferior-mediastinum?
Retrocardiac structures is very difficult, but we have done few esophageal duplication cysts by this method, by usually left or right approach.
Can you tackle the esophageal perforation with this method?
Esophageal perforation, if it is contained, then we can do it, or if it is fresh. But if it is, we have spent 2 or 3 days or 4 days more, then it is very difficult. But we can just open, put the wash if you are managing conservatively, and put an intercostal drain and come out, if you are not doing any resection procedures for esophagus.
Okay. Thank you very much. Thank you.
Chylothorax, yes, it can be used. When we do usually routine esophagectomies, we do thoracoscopic esophagectomy. That time, the thoracic duct usually lies between the aorta and azygous vein. That proper structure where we can easily find the tubular structures, that we can easily see if and clip the thoracic duct. That we have done if we have got complications of esophagus as a chyle leak. Then we have just gone in with the thoracoscopy and clipped it.
In the case of a chylothorax, can we utilize this for the examination as well as for the treatment policy?
For the treatment.
And almost the pathology is at the same anatomical site, or it's a variable anatomical sites which can have a chylothorax?
It usually depends whether chylothorax is because of the medical reason, then maybe it is difficult because that medical condition has to be treated. But if it is because of surgical, we can see multiple punctures and then we can do it.
Thank you.
Okay, thank you very much.
Thank you.
May I call next Dr. Aniket Patil, please?
Good morning, everyone. I'm Dr. Aniket. First of all, I would like to thank all the authorities of Kolhapur Medical Association for giving me this opportunity to stand here and present before you. The topic for today's presentation is breaking the myths in ophthalmology. We Indians, myths, beliefs, and superstitions are so deeply engraved in our systems that we seldomly think about it. Whenever we gift money or cash, it is never 500 or 1000 rupees. It is always 501 or 1001 rupees. Whenever we are leaving our home for some important work, we consume a spoon of curd. We hardly give it a thought. It is deeply engraved in our system. Aim of this study is to break a few common myths in my field of ophthalmology. What we did here is we randomly selected 100 patient attendants from our OPD, age between 18 to 60 years with minimum qualification of 12 standard, and we gave them a questionnaire of 15 questions and inquired about different ocular scenarios. We'll go into these scenarios one by one. Firstly, eating carrots will improve our vision. 85% of the patients thought so. Actually, carrot is a source of vitamin A. Deficiency of vitamin A causes dryness. It has no role in reduction or increase of your eyesight. Sitting too close to TV is bad for your child's eyesight. 97% of the people thought so. Let's see what the actual fact is. Near point of accommodation of kids is closer to the eye. They have the ability to see objects held very close to their eye, which adults cannot see. This near point of accommodation recedes as we age. So watching TV closely is not as taxing on a kid's eye as much as it is to an adult eye. At the max, it can cause eye fatigue, but never does it cause any damage to his eyesight. Cataract can be operated only when it is completely ripe. 92% of the people thought so. It was an old school thought that cataract should be completely mature before you operate it. Current general consensus amongst the ophthalmologists is the earlier you operate, the better it is. The rate of complications are much higher in a mature cataract surgery. Also, the post-operative vision is better when it is operated in an immature state. The entire eyeball can be transplanted. 93% of the people thought so. It's a popular belief that if you have loss of vision due to any cause, you just replace the eyeball, do an eye transplantation, and the disease gets cured. In fact, only corneal blindness can be cured. Eye transplantation is actually only corneal transplantation. Looking at the screen for a long time will damage your eyesight. 95% of the people again thought so. Excessive usage of screen causes asthenopic symptoms like eye ache, heaviness, redness, and itching. All these are fatigue related. It will never ever cause permanent damage or reduction in eyesight. Whenever we overuse any part of our body, it becomes sore for some time. Like when you run, you get pain in your legs, but after some time of rest, it will come back to what it was in its initial state. Excessive usage of eyes will wear them out. 90% of the people thought so. We don't lose our sense of smell by excessive use of nose. We don't lose our hearing sense by too much use of our ears. Our eyes are made for seeing. So why would we lose our vision by using our eyes? Kids pick up glasses if they watch too much of TV. 96% of the people again thought so. Kids pick up glasses due to change in the length of the eyeball. Shorter eyes have hyperopia. Longer eyes have myopia. Asymmetric curvature of the cornea leads to astigmatism. That's it. There is no other reason for picking up glasses. No matter how many hours of TV your kid watches, it is not going to initiate the process of getting glasses in him or her. Wearing glasses will help you reduce your glass number. 96% of the people again thought so. Glass number changes due to change in the axial length of the eyeball and change in the curvature of the cornea. Wearing glasses doesn't alter these two natural processes happening in our body. Hence, wearing glasses doesn't help in reducing your glass number. Surgery to get rid of your glasses cannot be done after the age of 40 years. 83% of the people again thought so. No matter what your age is, after the age of 18 years, we can do surgery to rectify your glass number. The type of surgery differs according to your age, your type of refractive error, the amount of refractive error, and your visual demand, but it is possible. We can swim with contact lenses on. 90% of the people thought so. Never ever should anyone swim with contact lenses on. The common thought process says that glasses are a hindrance in swimming, but contact lenses are not. Microorganisms get into the space in between the cornea and the contact lens and cause the dreadful corneal ulcer. Pseudomonas is the most common organism to cause such sort of infection. So a strict no for swimming with contact lenses on. After cataract surgery, one doesn't need glasses. 82% of the people thought so. Contrary to the popular belief, lens that we put in after cataract surgery is a replacement for the cataractus lens. It is not a replacement for glasses. Using routine monofocal IOLs reduces the dependence on glasses for distance vision, but glasses are required for near work. Using premium multifocal IOLs or multifocal toric IOLs, depending upon your eye type of the patient, gives entire freedom from glasses. Slowly, cataract surgery is now becoming a refractive surgery. Vision 6x6 means that your eyes are perfect. 67% of the people thought so. 6x6 measures only the central quantitative vision. People with 6x6 vision can have night blindness, they can have color blindness, they can have visual field defects due to glaucoma or neurological disorders, they can have higher order aberrations. So 6x6 vision doesn't mean that everything else is normal. Colorblind person can see everything as black and white. 96% of the people thought so. Color blindness is anomalous perception of either red, green, or blue color. Partial colorblind has partial blindness for one of these colors, and complete blindness has loss of one of these. A 50-year-old gentleman needed glasses to read, but since past 6 months, he can read without glasses, good or bad. 92% of the people thought that it is good. Presbyopia only progresses. Once you start needing glasses for near vision, your glass prescription for near vision as a rule will increase. This is a classic case of index myopia wherein the cataractus lens makes the eye myopic, that is short-sighted, and hence he can see near objects without glasses. What he misses here is that his distance vision has deteriorated. This phenomenon is called as second sight. Tough to convince these ones for cataract surgery. Cataract can be removed with lasers. 90% of the people thought so. Cataract extraction by phacoemulsification uses ultrasound and not laser. Femtosecond laser used in cataract surgery is used only to make incision. Laser can make cuts. It cannot aspirate or remove cataract from your eyes. Hence, to conclude, majority of the general population has wrong perceptions regarding the eyesight, screen work, usage of glasses, cataract and refractive surgeries. Why this platform? In my practice, I have noticed that these myths are strongly rooted within the minds of our general population. As an ophthalmologist, it's my moral duty to address this issue and help spread awareness and reality. Because we are medicos, these are the common queries that our friends and relatives ask us. I hope that I have burst a few myths in your mind, which you guys will pass on to our society. This is a small attempt to increase the awareness in our society, community rather. Let's brush up. These take-home messages from today's talk would be: eating carrot has nothing to do. I'll wind up this. Eating carrots has nothing to do with our vision. A child can comfortably watch TV from close distance, which an adult cannot. Earlier you operate a cataract, better it is. Eye transplantation is only corneal transplantation. Looking at screen for a long time does not damage your eyesight. Excessive usage of eyes will not wear them out. Watching TV has nothing to do with initiation of glasses. Wearing glasses doesn't help you to reduce your glass number. No matter what your age is, after the age of 18 years, we can do surgery to rectify your glass number. A strict no to swimming with contact lenses. Most people need glasses post-cataract surgery. 6x6 doesn't mean eyes are perfect. Color blindness is not black and white vision. Improvement in near vision is an indicator towards cataract, and cataract cannot be removed by lasers. These are our references. Thank you for patient listening.
Thank you very much. It was really wonderful and very timely finished. This was really an eye-opener by ophthalmologists to all of medical fraternity also, not only for the lay person. How you are taking up this your study further to make awareness among public?
I think of presenting this topic in between ophthalmologists or in a focus meet doesn't make any sense. This is actually basically reserved where it's a non-focus meet where the listeners are people other than ophthalmologists. It might be general lay public or medicals from other fraternity. I just try to tell people as much as possible wherever I get a chance and try to clear these myths and tell them what actually the fact is.
I think congratulations for selecting such a simple but wonderful topic.
Thank you, sir.
Thank God I was not sitting in your OPD. Otherwise, I would have given 13 out of 15 answers. There are a lot of myths. Even though I'm a doctor, a lot of myths in my mind also.
2 मिनिटं फक्त भेटू.
Yeah, it's an eye opener, and I think good presentation.
Thank you.
Thank you very much. We have another two presentations. So may I call Dr. Sagar Kurunkar to present his topic.
व्हिडिओ काय आहे व्हिडिओ काय लागतो म्हणजे ऑडिओ
Good morning, respected seniors and my dear colleagues. I thank Kmacon for giving me this opportunity to share my experience on Whipple's surgery. As we know, a few years back, pancreas was considered as a tiger's country because of excessive vascularity and bleeding, which is encountered during surgery. So it is very critical and complex surgery. And nowadays, people are doing multivisceral resections along with pancreatic resections as well as vascular resections. So straight away, moving towards the interesting case. So he is a 36-year-old gentleman who presented with anemia and generalized weakness and melena for 1 month. On clinical evaluation, other than pallor, there was no significant finding. So he was evaluated initially with ultrasonography, which showed there is a just dilatation of the CBD. His hemoglobin was low. Rest of the lab parameters were normal. And he was nutritionally very well preserved. So as a routine practice, we posted him for upper GI endoscopy. So what we found is there was an ulcerative lesion here in the periampullary region. So we took biopsy of that. So, but the lesion size and the way he was bleeding, it was not fitting into criteria. So we got a colonoscopy. So we found one more tumor in the terminal ileum and cecum. So again, it was an ulceroproliferative lumen-occluding growth in the terminal ileum and cecum. So the biopsy of periampullary region was well differentiated adenocarcinoma, whereas biopsy of the colonic lesion was a poorly differentiated adenocarcinoma. So there were two malignancies, which was suggestive of it is a synchronous tumor in a young patient. So CT scan showed there was a asymmetrical thickening of the cecum as well as ascending colon with multiple nodes in the mesocolon. So you can see this is the thickening here with multiple nodes. It was a very aggressive lesion. So you can see this is the lesion. This is the duodenum here. There was no lesion seen on a CT scan, but on endoscopy, there was a periampullary lesion, which was a biopsy-proven malignancy. So there were two synchronous lesions. So the challenge was to post him for a Whipple's procedure as well as colonic resection. He was a young guy with good nutrition, with good pulmonary function test, and he was posted of colo Whipple's. So let's see what is this Whipple's and what is this colo Whipple's. So intraoperatively, when I opened this patient, there was no peritoneal omental disease. There was a bulky growth in the cecum ascending colon. Pancreas was soft with only 2 millimeter pancreatic duct, and there was a papery thin hepatic duct about 5 millimeter. So reconstruction, what we did, I will show you further. So you can see this is the bulky growth with multiple nodes. This was ascending colon growth and cecal growth with mesocolic nodes. So this was the lesion here. We have reflected the colon here, and this was one more lesion, periampullary lesion. So this is the superior mesenteric vein going as a portal vein after joining the splenic vein. This is the pancreas, the stomach which was lifted. So intraoperatively on a CT scan also, there was an infiltration in the duodenal part. Disease was adherent here also. So you see, initially we reflect the duodenum along with pancreas. This is the posterior part of pancreas. This is the IVC, left renal vein. This is a superior mesenteric artery. Usually in all the cases, this is the head end of the patient. This is the liver. This is the IVC. You can see the pulsations here. This is the aorta. We clear the lymph nodes here initially. In usually all the cases, we routinely loop the superior mesenteric artery, which originates just above the renal vein. So this is very important in a complex pancreatic surgeries where we are planning for vascular resections or assessing the operability. So as a routinely we do, because if we sweat in a peacetime, we will not bleed in a wartime. So accessing the superior mesenteric artery at the initial resection part only is very important. So we have transected the stomach here. This is the tape which showed pancreas has been looped. This is the superior mesenteric vein. The uncinate part we have completed already from the superior mesenteric artery. This is the duodenum. So the same diagrammatic picture after transecting the pancreas, you can see this is the SMV running behind the neck of the pancreas. This is the hepatic artery originating from the aorta. This is the gastroduodenal artery here, which has been ligated. So this was the gastroduodenal artery, which is very important because if it leaks, it bleeds like anything, and within 5 minutes, patient can die. He cannot reach the operating table also. So again, this is the uncinate first approach. Nowadays, people are doing all over the world to reduce the bleeding. When we transect this pancreas, it bleeds very heavily. So if we do all this dissection before, the bleeding will be minimized. So you can see this is the superior mesenteric artery originating from aorta and SMV going as a portal vein. So here we have completed this. The uncinate process has been resected from the superior mesenteric artery. This is the SMV after joining the first jejunal vein. This is the SMA superior mesenteric artery. Multiple clips has been put here. This is the tape, which is looped pancreatic neck, which is, and this is the vessel, that is portal vein going behind the neck of the pancreas. So this is the common hepatic artery giving origin to the gastroduodenal artery, which has been tied and clipped. So after removing the specimen, you can appreciate these are multiple clips over superior mesenteric artery, because it is not only the gastroduodenal artery. Many times inferior pancreaticoduodenal vessels, they bleed in post-operative period if patient develops pancreatic fistula. This is the bulldog clamp which has been put on the common hepatic duct. So this was a very thin pancreatic duct, about 2 millimeters. I could take only 4 sutures. You can see this is the 6-0, and only epidural catheter has been put. It was a bulky, soft pancreas. So we routinely do pancreaticojejunostomy with a duct to mucosa fashion in 4 layers. So this is the pictorial picture which showing how I do anastomosis. So this is the common hepatic duct which has been transected at the root of the liver, just above the origin of cystic duct. So we did hepaticojejunostomy with the 5O PDS sutures. So this is the specimen where we remove in a Whipple's pancreatic head along with uncinate, duodenum, sometimes part of a distal antrum, gallbladder, CBD, along with nodal clearance. So while reconstructing, we anastomose the pancreas with the jejunum. Here, hepatic duct is anastomosed to the jejunum, and the same loop is attached to the stomach in a classical Whipple's procedure. But in this case, along with right hemicolectomy, we did this. So this is the specimen. So patient recovered uneventfully and discharged on post-operative day 10, and he had no complications. So many pancreatic cancers acceptable all over the world with a morbidity of 30 to 40%. And we can achieve this with good surgery and proper hemostasis and selecting good patients. So younger patients with anemia, needs proper evaluation. It's not always nutritional. Thank you.
Wonderful, wonderful. Very good surgery. Did you do colectomy and Whipple's at single
Yes, sir.
setting?
Yes, sir.
It
Single
must have
setting.
been a very lengthy procedure.
Yes, sir. It took around 10 hours.
And the intraoperative, whatever photographs you have taken, they're wonderful.
Yes.
Congratulations.
Yeah. Yes. Usually we don't get, sir, because we are not dissecting over the adventitia. If it is a borderline resectable pancreatic cancer where we give chemotherapy, radiation, and we remove the adventitia, only in those scenarios, there are chances that patients might develop aneurysms. Rather than aneurysms, if it leaks, they bleed up directly.
Okay,
All aneurysms then will require a stenting.
Usually it's better to stent because aneurysms, it develops only when pancreatic anastomosis leaks. And if it leaks, it weakens the wall of SMA. And
so then SMA aneurysms should be taken as a post-operative pancreatic leak.
Yes, usually they are associated with leaks.
And then they do have associated cholangitis.
Usually we have drained the bile duct, so they will not develop. But if it is a metal stent or a plastic stent which has been put before, the chance of patient having cholangitis is more in a post-operative period also.
Thank you. We are running short of time.
Yes.
Sorry to interrupt. We are running short of time actually. We want to start the next session in time.
Yes.
So thank you very much. Rest of the queries you can solve in the personally. Our last speaker is Dr. Preetham Nafa. So may I present Dr. Preetham Nafa, please?
It's quite heartening to see that even on a Sunday, we have more than 56 online viewers. So even though the hall seems a bit empty, we have a lot of audience online.
Good morning to one and all. I would like to thank Kolhapur Medical Association for giving me opportunity to present a small study which has been done in 2 months period. And I would like to thank my teachers who has been with me in this 2 month study, Dr. Ajit Kulkarni sir and Dr. Ajay Kini sir, along with support of microbiologist Dr. Sumit sir. The small study which I have done in this 2 month period is the role of serum galactomannan in acute exacerbation of COPD. Coming to introduction of as a COPD, it is a chronic obstructive pulmonary disease, which is chronic inflammatory lung disease that causes obstruction to airflow. As COPD is a common preventable and treatable disease, it is also progressive with multisystemic implications. It is now the 4th leading cause of death in the world, which is supposed to be second most cause of death in 2025. An acute exacerbation of COPD causes acute worsening of respiratory symptoms, which reduces patients' quality of life and exacerbate airflow limitations. It also causes accelerated decline of pulmonary functioning, leading to death. And most probably, this aging population more than 60 years has led to relative increase in mortality and morbidity across the world. And some of the risk factors for development of airflow limitations usually in COPD patients, and some of the factors that contribute to acute exacerbations are smoking, indoor exposure to biomass, and other factors including family history, alpha-1 antitrypsin deficiency, age, tuberculosis, and other occupational exposures and socioeconomic status. But recently, fungal infections, mainly Aspergillus, contribute to the acute exacerbation of COPD, which is usually ignored. And coming to the main objective of the study is to evaluate the diagnostic role of serum galactomannan antigen index in acute exacerbation of COPD. The material and methods which I have taken for this study is 10 patients I have collected who got admitted in Astraradar Hospital from December to February as indoor patients with acute exacerbation of COPD were underwent serum galactomannan antigen index. In this prospective single center study, serum galactomannan levels were evaluated, and the inclusive criteria and exclusive criteria for this study are inclusive criteria are patients more than 40 years of age and with acute exacerbation of COPD who got admitted into the hospital, and exclusive criteria are the patients who are already on antibiotics such as piperacillin tazobactam and antifungals were excluded from the study. The main reason being false positive results and false negative results which we are getting with serum galactomannan. False positive results can occur due to concomitant administration of antibiotics such as beta-lactam antibiotics and piperacillin tazobactam, and also some other organisms sharing cross-reacting antigens such as fusarium and histoplasma. And false negative results which we are getting from serum galactomannan are encapsulated infections along with the patients who are on antifungal treatment. And that is the detection of serum galactomannan by ELISA method, in which monoclonal antibody from the patient sample is taken, and if galactomannan is present in patient serum sample, that is taken as a detector antibody, and to that chromogen is added, and the optical density of the chromogen in patient sample is compared with the laboratory sample. Usually it is of the galactomannan index is taken as 0.5 and some studies were taken as 0.7. For my study, I have taken it as 0.7, and the result which I got from this study is out of 10 patients, I got 9 patients positive, almost more than 1. As cutoff value taking 0.1, indicating that fungal infections, mainly aspergillosis, contributes to higher incidence in acute exacerbation of COPD. Coming to the discussion of this topic, fungal infections are increasingly prevalent in recent times, mainly causing acute exacerbation of COPD. Increasing incidence is likely multifactorial and related to an ever-growing population of susceptible patients, including immunocompromised individuals along with transplant patients. Frequently, the diagnosis of fungal lung infection specifically, can be delayed because it is not strongly considered in early clinical course. Among fungal infections, aspergillosis are still the most common in Western world and are one of the most common cause of mortality in COPD patients. Some of the factors that are contributing to fungal infections are recent travel or exposure to endemic geographic regions, unresolving pulmonary infiltrates and fever despite on antibiotic treatment, associated skin lesions such as erythema nodosum, erythema multiforme, and ulcerated skin lesions. Significant neutropenia less than 500 microliter for more than 21 days, blood malignancies, transplant patients, and emerging immunocompromising disease states. To tackle this, rapid diagnosis is required for evaluating fungal infections, mainly aspergillosis. The rapid diagnosis is through serum galactomannan levels, and according to few studies, sensitivity of BAL galactomannan is higher than serum galactomannan, whereas specificity of serum galactomannan is higher than BAL galactomannan. And Aspergillus species from airways of COPD patients are frequently considered as a concomitant contaminant and a major concern in recent acute exacerbations. To improve the outcome and more rapid diagnosis of invasive aspergillosis as a cause of acute exacerbation of COPD, Serum levels of galactomannan has been widely used as a complementary diagnostic marker, as galactomannan is released during the growth of aspergillus. And the cutoff value is 0.7 for my study. And the conclusion which I got from this study is serum galactomannan index is useful in early detection of fungal infections, mainly aspergillus in acute exacerbation of COPD. And the references for this study is of this. Thank you.
Good topic, but sample size was a bit small. Now you have to include recruit more patients. Second thing, is it a useful investigation for allergic bronchopulmonary aspergillosis?
No, sir. Only invasive aspergillus.
So ABP is a different syndrome.
Yes.
Okay, thank you very much. Here we conclude our presentation topic is pre-prepare presentation topic is over. Hand over to our MOCs, Dr. Arun Kumar Deshmukh, Neeta Narke, and Deepa Rupali. Thank you.
I would request our jury to please come on the dais. Well, today we were very lucky to have such a jury in the form of Dr. Vinay Wagh sir. He has been an excellent medical teacher right from his early days. And I'm really fortunate to say that I am one of his students in undergraduate days. The other jury is Dr. Amol Kodolikar, who is an eminent anesthesiologist, having a keen interest in academics. And he's always trying out new things. And I must say that I'm still lucky to associate with him many times in the theater as a surgeon. So even the presenters today were really lucky to have such a jury. I request our president, M. Shirke sir, and our honorary secretary, Dr. Mrs. Pillai, to felicit our jury. Thank you, everybody. Here we conclude our morning session, and now we move on to the session 5 of the conference. The results of the paper presentation, they will be declared in the valedictory function in the afternoon today.
We request all the participants to kindly wait till the valedictory function. Now we begin with our session. I request our chairpersons of this session, Dr. Sopan Chaugale, to kindly come onto the dais. He is our executive committee member and a renowned laparoscopic surgeon. And our second chairperson is Dr. Sandeep Sarokhe, who is the past president of Kolhapur Medical Association and is a renowned pathologist.
So today's opening batsman is Dr. Yuvraj Pawar. So he is going to talk on pearls from cardiology. So in short, his biodata, he has done MBBS from D.Y. Patil Medical College, Kolhapur, and DNB medicine from Apple Saraswati Multi-Speciality Hospital, Kolhapur. He has done his DNB cardiology from esteemed Fortis Hospital, Mumbai. And he has experience of working as a cardiology associate in Aditi Hospital, Jain Cath Lab. So please, Yuvraj, go ahead.
Very good morning, everyone. Myself, Dr. Yuvraj Ramesh Pawar. I'm an intervention cardiologist doing freelancing in Kolhapur, based in Kolhapur since last 1.5 years. I have my own clinic at Prankala, being Doctor Clinic, and I have been working in interventional cardiology since last 5 years. So, moving with today's topic of my presentation, it is a primary facilitated and rescue PCI for acute myocardial infarction. By definition, the primary PCI is an emergent percutaneous catheter intervention in the setting of ST elevation MI without previous fibrinolysis. Is the preferred therapy for ST elevation MI these days. Primary PCI versus lysis. For the ST elevation MI, meta-analysis of 23 trials has been studied. With the short-term event, the death, re-MI, total CVA, intracranial hemorrhage have been reduced, shown reduced possibility with the percutaneous intervention in with the lysis. A transfer for PCI is better than lysis in the timely manner. Lysis versus transport for PCI, meta-analysis with the 5 RCTs with the average time frame of 39 minutes has been shown good results with the PCI. So transfer for primary PCI versus lysis, death, re-MI, and primary endpoints were death, re-MI, and stroke. In PRAG, Captive, and Dynamic trial, with PRAG 2 trial also showed a relative risk, almost 40% of relative risk reduction with the primary angioplasty. The Dynamic 2 trial with the primary endpoint of death, re-MI, and CVA, fibrinolysis is showing 14.2% of risk set, with the net number of 18, and PCI is significantly reduction with the primary endpoint, with the average time transfer of 70 minutes near about. The time delay is important factor for primary PCI. The primary facilitated rescue PCI delay due to long transfer time are common. The primary PCI is preferred reperfusion strategy for STEMI if it can be done in a timely manner. Only 5% of Indian hospitals are capable of primary PCI, and 95% of STEMI patients transferred from non-PCI hospital to primary PCI have door to balloon time more than 120 minutes, which is quite long, and it's ideally not acceptable. Relation between door to balloon time and the in-hospital mortality in MI, you can clearly see there is with the increased time frame about 120 minutes, the mortality increases significantly. Treatment delay with the primary PCI, the cardiac survival definitely declines beyond 120 minutes. So first 90 minutes to 120 minutes are very crucial for ST elevation MI patients. The transfer for primary PCI, you can see less than 1 hour, 90 minutes, 1 to 2 hours. We have hardly achieved the number, the standard number. Only 36% of patients subset were reached less than 120 minutes of goal. So door in, door out time for referring hospital, that is DIDO, we say that DIDO is ideally it should be less than 30, and what we are seeing here is 74 minutes has been over the studies, last 20 years of studies, we have shown a significant delay for the transferring patient from referring hospital to the primary hospital where PCI has been done. So this has to be reduced. So intra-hospital delay in transfer door-to-door time, the mortality rate increases significantly beyond 90 minutes. It is almost 12%. your house is on fire, and every second is crucial, and the damage is getting worse. Fire spreads quickly. During transportation, you are watching the firemen loading the burning stuff. And at fire station, there is nothing left inside the heart. There is nothing left as far as muscle is concerned. So time is muscle and life. So time is muscle. Cross-sectional area of left ventricle after experimental coronary occlusion have shown 42 minutes to 3 hours is a crucial time where you need to intervene immediately. Beyond 24 hours, there is no meaning. Already your myocardium is burned out. So coming to rescue PCI, by definition, rescue PCI is a refer to mechanical reopening of the occluded infarct-related artery after failed intravenous thrombolysis. In short, what is a failed intravenous thrombolysis is less than 50% of ST resolution, then hemodynamic instability, cardiac shock, arrhythmogenic potential patient. We should be doing rescue PCI within 12 hours of the frame. So rescue PCI is better than lysis. The REACT trial has shown a death re-MI, severe congestive heart failure, and severe rate at 6 months. There is 86% of reduction with the rescue PCI as compared to the conservative and repeat lysis. So rescue PCI versus conservative treatment in meta-analysis of 3 randomized control trial have significantly showed that death, re-MI, and heart failure is reduced. So coming to facilitated PCI. So what is facilitated PCI? Ideally, angioplasty has been done in a timely manner and timely frame where the transfer delay is quite long, more than 120 minutes. In this situation, you should be giving half of the thrombolysis, half of the fibrinolytic agent, or full fibrinolytic agent, or half fibrinolytic agent plus GP2B 3A inhibitors in the half doses. This has been done deliberately attempt to increase the antegrade flow of infarct-related artery opening and ease during procedure. We need to facilitate this particular domain, but this result in the Ascent 4 trial has shown very quite harmful results. The study had serious flaws, so this study has been stopped immediately. So reperfusion option for the transfer patient with expected delay is a primary PCI no matter how long it is. Lysis in cases of ischemia guided transfer for rescue PCI, and lysis with the transfer for immediate, that is early PCI, what we call as pharmacokinetic strategy. The clear differentiation between pharmacokinetic strategy and facilitator PCI is we give full thrombolysis or full GP2B 3A inhibitors, GP2B inhibitors in cases of pharmacokinetic strategy, and we have to go ahead with the angioplasty within 3 to 24 hours of time frame. There have been 4 studies have been studied: AMICO registry, CARES AMI registry, then transfer AMI, Nordic STEMI have been studied, facilitated versus pharmacokinetic strategy. The early routine versus standard PCI, standard treatment after lysis, the 30 days clinical outcome is quite good with the early PCI. The CARES AMI design, will just skip this particular slide. So coming to rescue versus facilitated, the facilitated PCI, the result is quite good as compared to rescue PCI in a timely manner. The pharmacokinetic versus lysis for high risk STEMI patient, the primary endpoint at 30 days has reduced significantly. You can say it has achieved for more than 40% of relative risk reduction as compared to standard treatment with the lysis. In 2018 guidelines, or you can say ESC 2017 guidelines, as per 17 guidelines, the evidence of lytic failure or infarct-related artery reocclusion is a class 2A, B indication, and patent infarct-related artery 3 to 24 hours after lytic therapy is also class 2A, B indication. System goal should be for the primary PCI should be less than 90 minutes for first medical contact to hospital with the PCI capability is a class 1 indication. If it is less than 120 minutes when present with the hospital without PCI capability is class 1A, level of evidence is B. Coming to the summary, summarizing this primary PCI, facilitated and rescue PCI. Primary PCI is a preferred for ST elevation MI, is class 1A indication. Then primary PCI preferred if transfer time is short, say less than 120 minutes. Pharmacokinetic strategy is preferred for patients where transfer time are long, and early routine PCI after lysis preferred over the rescue strategy, that is particularly in a high risk patient. It should be done in a timely manner from 3 hours to 24 hours. Includes the rescue PCI for failed reperfusion, prevents early reocclusion after successful lysis. Do whatever it takes do whatever it takes to reduce time from the symptom onset to early ER arrival and ER arrival to PCI. There should be a public awareness forum and chest pain centers where excellent lower door to balloon time and excellent outcome. The regional coordination should be there, ambulance ECG telemetry should be there, and ambulance and ER activation should be there. Coming to next topic of my presentation is primary angioplasty and hemodynamic support in cardiogenic shock. Epidemiologically, cardiogenic shock in a ST elevation patient is a quite significant number of the patient. We could see that 4.2, the prevalence rate is 4.2 to 7.2 as per the Gusto trial, and non-STEMI it is 2.9%, but it is quite late presentation, and unstable angina rarely presents after 94 hours. So cumulative mortality rate from the time of onset of shock, half of the group are dead within next 10 hours, 10.2 hours, and overall mortality rate is quite high, that is 86%. By definition, cardiogenic shock is systolic blood pressure less than 90 millimeters of mercury for 30 minutes to 1 hour, that is unresponsive to fluid administration alone and secondary to cardiac dysfunction or a sign of end organ hyperperfusion with a cardiac index less than 2.2 and PCWP more than 15 to 18. The systolic blood pressure increases to more than 90 within 1 hour after the administration of inotropic agent, and death within 1 hour of hypotension, but met other criteria for cardiogenic shock. According to ACC AHA guidelines 1999 and 2000 for PCI in the cardiogenic shock, the class 1 recommendation still remain the same, that is primary PTCA within 36 hours of an acute ST elevation MI with a Q wave or new LBVB who develop cardiogenic shock less than 75 years of age. And reescalation, that is a PCI versus CABG or CABG within 18 hours of the onset of shock is recommended. The predictors of cardiogenic shock after ST elevation MI is a patient's age, most important part, most important point, and then systolic blood pressure, then heart rate, Phillips class during presentation. A shock trial has been randomized, a control trial has been studied with the acute myocardial infarction first 36 hours of shock randomized into emergency reescalation and early medical stabilization with a primary endpoint of 30 days mortality and secondary endpoint of 6 months mortality, which had shown that PCI within 6 hours of MI a 40% of the in-hospital mortality for PCI is 46%, and in-hospital mortality for medical management is 78%. That is quite high. You can say within 6 hours, if you open it, it's 40%, and 12 to 24 hours is 60%. So final TIMI flow grading after PCI in hospital mortality rate of shock registry patient with the pump left or right ventricular failure is quite high with the TIMI 0 to 1 flow, and TIMI 3 flow, if we achieve, it is 33.3%. The angiographic success and in-hospital mortality rate with a shock registry patient with the pump failure, success is defined as a residual stenosis less than 50%, and final TIMI score is at least 2 or 3. And unsuccessful PCI, if we see the mortality rate is 82%, which is quite less with the successful PCI, is 36%. So long-term result after acute myocardial infarction in acute PCI in acute myocardial infarction with a shock, 12 months survival rate is 47% according to shock trial. So GP2B3A inhibitors are beneficial effect of GP2B3A receptor blocker in patient with undergoing primary PCI or stenting in a cardiac shock. The 1 month mortality rate is significantly reduced, and the in-hospital mortality rate is also significantly reduced. Hemodynamic support in cardiac shock, as we all know, IVP in cardiac shock, diastolic inflation, which give the augmentation of the diastolic blood pressure, increases the diastolic coronary flow, then systolic deflation, which is afterload reduction, reduces LV wall stress, decrease microarterial oxygen demand, and increase in the cardiac output. It is contraindicated in severe severe AR. IBP in cardiogenic shock complicating acute myocardial infarction. The IBP as an adjunct treatment to revascularization in GUSTO-1 trial, a trend towards lower 30 days and 1 year mortality rate. The shock trial IBP used in 86%, but surprisingly, it has shown no benefit as far as IBP is concerned. So concluding the session with the prevention is better policy, that is identification of pre-shock state followed by preventing the deterioration in cardiogenic shock, and strategy should be strategy of early revascularization of in PTCA with the PTCA CABG accompanied with the IBP support for more than 75 years of old. Invasive strategy on the case basis should be on the case basis. And TIMI flow after PCI was strongly associated with the in-hospital mortality. At least you should achieve TIMI 2 to TIMI 3 flow in these situations. So coming to my presentation, coming to my first case, that is 56 years old male, diabetic hypertensive, admitted with the inferior MI, thrombolized with the streptokinase, which is obviously presented with a failed thrombolysis to me and cardiogenic shock. Patient is having cardiac shock, shifted to cath lab immediately. So, yeah. So this is the right coronary artery which is occluded, which is quite thrombotic. We have immediately stented it, and this is the end result which we have achieved. Okay, because it is super dominant, that is why patient was in cardiogenic shock. Case number 2 is 55 years female diabetic patient presented with the acute myocardial infarction, thrombolized with streptokinase, persistent chest pain after STK, and recurrent VTs, and has been cardioverted in multiple times. And GP2B have given, and immediately we shifted to cath lab for the intervention. So So you could see there is LED which has been occluded, or still LED, and mid LED is quite tight. So we balloon the proximal lesion, ostial lesion, and mid lesion. We have stented it immediately. And this was the end result. So in this frame, you could see that there is a RCA which is also occluded 100%, but in the setting of cardiac shock, culprit vessel PCI is indicated. So case number 3, this is quite interesting case which has happened recently. Happened to be in the cath lab emergency situation. That is 57 years female, diabetic hypertensive, admitted with the acute coronary syndrome with the TROPI positive. Sage was showing double vessel disease. So electively, we have planned PTCO2, LAD, and L6. So this was the angiogram on the presentation. So the angiogram during presentation, L6. So the angiogram is showing that L6 and LED is quite tight. So our plan is to open the LED first. We have stented LED, and LED is opened quite well with the TME3 flow. And this you could see there is something went wrong. Something you could see. That is an indeflated stent, which is okay. So there was leftment to LCX. We wanted to stent, but this particular shadow, you could make out there is something wrong which has happened, whether it is dissection or something like that. So we couldn't able to make out. But when the balloon is out in deflated stent, we wanted to just pull out the stent and re-balloon it. But this was the scenario which has happened to be in the cath lab. This is the emergency or no caution situation, where a patient can land up into failure or cardiac arrest any point of time. Patient is having chest pain at this point of time, and we have taken the shoot, and this was the stent which is indeflated stent treatment from LCS to left main. So within no time, we wanted to stent LCX. We ballooned it and stented it.
So this patient had a PTH level which was very low. So this is that.
Yeah. So we ballooned it and stented it from proximal to mid LCX immediately. So, but there is something went wrong. So we wanted to do it. So we stented from left main to LCX, one more stent, and we could see. So. Yes. So we could see something is happening in left main to LED. So this is dissection which has happened on the same setting. So we wanted to stent left main to LED, and we have achieved left main to LED TAP technique, bifurcation stenting, and this is final kissing balloon, which we have done. Okay. And after that, pot. And this is end result, which has been achieved. Patient went home. Okay, fine. Thank you.
Thank you, Dr. Yuvraj Pawar, for sharing with us such wonderful pearls in cardiology. Sir, kindly wait on the dais. The floor is now open for the questions. Any questions?
Yes, yes. Yeah. Yeah. Yeah.
Chance for bleeding, or it's rather than thrombolize, can you take for directly PCA or PTCA? There are two options in acute.
Actually, it was thrombolized outside, sir. It was thrombolized outside. Non-PCI capable.
Such patients are risky for PTCI for short period.
Within 3 to 24 hours, we can anytime open the arteries. Even if it is STK, we generally follow the radial route, which is less likely to bleed. So radial route is always preferred route where the thrombolysis has been done already. And in those patients, the bleeding risk is quite less with the radial route per se. But ideally, you should thrombolize with tenecteplase so that we could achieve good result. One thing, and we could we could directly ship to cath lab within 2 hours of time frame. Ideally, that is a drug of choice. But as a cost constraint, we had to thrombolize with the streptokinase.
Fibrinolytic is more important than the thrombolytic.
Yes, sir.
Streptokinase is not preferred as compared to the.
No, streptokinase is out of question. In US, it has already been banned drug, but we still we are using because of cost constraint. It is not a very good fibrinolytic agent.
Any other question? Thank you. I now request our chairpersons to kindly felicitate our speaker, Dr. Yuvraj Pawar. Thank you. We now begin. Thank you so much. Our next speaker for this session is Dr. Avinash Sonone, who is connected with us virtually. He's online with us.
Presentation. Hello. Welcome, sir. Welcome, Dr. Avinash Sonone. Good morning to everybody, and good morning to our distinguished guests from Delhi, Mumbai. He is online because of government's responsibilities and the government of India's protocol. He could not come attend this, but however, we are fortunate to have him on the online. Today's distinguished guest, I think you have seen yesterday's presentation through Padma Shri Dr. Mahadev and the last presentation of opening of PET scan. So medical radiation has come to a full circle almost to our Kolhapur city as such. The radiation has from the old days of the ordinary X-rays to today's this PET scan. So every aspect of this is being strictly regulated and monitored by AABB. All that we know is that the AARB is a supreme authority of sanctioning and monitoring all these various facilities. Not only medical facilities, I think agriculture, food, and various other establishment also requires the radiation on all these things. So I think the sir is a well-known expert in that. Sir is acting head, director of regulatory affairs, ARB, and also currently a secretary to the board. He obtained his PhD from University of Mumbai in radiation protection of patients, diagnostic radiology. He has experience of more than 35 years in safety regulations of ionizing radiation, and he has been empaneled as assessor by National Accreditation for Hospitals and Healthcare Providers for Medical Imaging Services. Dr. Sonone is a recipient of Gold Medal of Indian Nuclear Society for his outstanding contribution in establishing a regulatory framework for ensuring safe usage of radiation sources for social benefits. So we welcome you, sir, on behalf of KMA IMA branch of Kolhapur and KMA organizing committee, and we request you to proceed with your online presentation, sir. Thank you very much.
Okay. Very good morning to all. It's my great pleasure that I got this opportunity to share information on mainly the regulations, safety regulations in application of ionizing radiation in the healthcare sector. I express my sincere thanks to Dr. Shailesh Kore for initially inviting me for this, and it was my strong desire to ensure our personal presence so that there can be more interactions, and even I can meet many our medical radiation professionals as well as paramedical staff there. But as you all know, because of this widespread COVID pandemic, there are restrictions on travel, as well as plus other governmental preventive measures are there. So I could not come. But yes, I definitely look forward for meeting you all at the earliest in appropriate forum. Once again, I thank to the organizing committee of Kolhapur Medical Association, which is indeed, I think, the oldest medical organization of India. That is what I could learn from the brochure. I am proud of KMA and organizing this under Indian Medical Association, this program. So thank you very much to all the dignitaries and delegates for this opportunity. Of course, my aim is to share you or make aware about the safety regulations which are there for the application of ionizing radiation in the healthcare sector. And as I was introduced initially, thank you for that. And yes, there are widespread applications in every, in every area. In our routine life, like food preservation, then nuclear power plants and industry or so on. So there are evolved, that regulatory infrastructure and evolved some sort of, I will say that the regulatory practice for each application is there. So today I will mostly try to emphasize on the healthcare applications. Can I share the screen for this presentation? I would like to share the screen for this presentation.
Yes, you are audible, sir.
Yeah, I want to share the presentation. The screen I want to share.
Hello. It uploaded, Amar, sir?
Yeah, actually the screen is appearing in the name of Mr. Anand because I have some Wi-Fi issues in my PC. Yeah, can you see now? This is the slideshow. Yeah, okay, Anand, yeah. So the title of my presentation is Safety Regulations for Clinical Establishments Using Ionizing Radiation. Of course, you all may be knowing what is the difference between the conventional radiation and ionizing radiation. I will not go details into the physics of this, but what I wanted to just mention. Can you hear me? Yes. So the ionizing radiation, the main difference is that it is highly penetrating radiation and it is of a very high energy. For example, the conventional X-ray, if we take medical X-rays, there the energy is of the order of 80 to 130 kilo electron volt, and in radiotherapy it is a million electron volt. While the energy of other radiation, we call it as a non-energy radiation, like radio waves, microwaves, infrared, visible or ultraviolet rays, which you use in sonography, their energy in terms of electron volt, and this is in kilo electron volt, so it is highly penetrating radiation. And when it penetrates to the human body or through the any matter, it produces the positive and negative ions. And that's why it is called as ionizing radiation. And these positive and negative ions further interact with the biological cell or organ, and then they make some differences in that. So that's why it is called as ionizing radiation. So in my rest of the presentation, I will be using the word radiation, but it is meant for the ionizing radiation. There are different type of sources of ionizing radiation. One is a man-made source of ionizing radiation, like use of radiation in medicine, like X-rays or intervention radiological procedures we carry out. That is X-rays. Similarly, the nuclear medicine, where we use the radiopharmaceuticals like F18, technetium-99m, iodine-131. Then there are industries for inspection of the welding and casting, and that's why it is used in industry also. And I think in Kolhapur also there are many industrial radiography facilities which uses the ionizing radiation in the form of radioactive material. But remember, there is also a natural source of ionizing radiation, because Earth is formed, with the emission, continuous emission of ionizing radiation, like a cosmic radiation we receive from the sun. Then Earth's surface, like rocks or brick, where the uranium and then thorium as well as the radon is there. Then food we eat, like a potassium 40, calcium, building material, everywhere in fact the ionizing radiation is present. We are in the ocean of ionizing radiation, which is a natural ionizing radiation, but we do have a man-made radiation. And man-made radiation, how it is made? One is by electrically generated machines like the X-ray machines or accelerators we use in radiotherapy. Another is like iodine-131, we use it in the Dhruva reactor, that is for the nuclear research reactors, which are operated in Bhabha Atomic Research Center, where we manufacture, we prepare the radioisotopes, radiopharmaceuticals, and radioactive material. So we will be dealing with the man-made sources of ionizing radiation here. So these are the, of course, a very basic slide for the delegates, that treatment of a cancer through radiotherapy. This is again, they use the electron beam or X-ray beam, then medical diagnosis and cardiological procedures using X-rays, then nuclear medicine for diagnosis, PET examinations, and blood irradiation to prevent transfusion associated with graft host transfusion disease as such. Now, I will let me introduce about my organization in a very few minutes. That Atomic Energy Regulatory Board is a regulatory authority with its a very focused mission, that is to ensure that use of ionizing radiation and nuclear energy in India does not cause undue risk to the health of the people and the environment. This is what the focused mission is there, and then is a government organization, and there are the rules and regulations under which, or within this regulatory framework, the ARB performs its functions. ARB regulates the radiation facilities, starting from a very small portable dental X-ray equipment to a very huge nuclear power plant as such, because these are all the sources of ionizing radiation. And how ARB regulates, it stipulates the requirements in the regulatory documents like the safety codes and standards. We have surveillance centers with Mumbai as a headquarter. Then we have a regional center in Delhi, in Calcutta and Chennai, because there are several hundreds of radiation facilities are spread across the country. They are increasing phenomenally in the country, and hence the surveillance provided from the headquarters is not that effective, and hence we have the regional centers with the deputed experts in the radiation protection and then other engineering aspects. So these are the codes, that the specific regulatory requirements of codes and standards. ARB has prepared so far more than 150 regulatory documents issued And codes and standards are mandatory, while guides, manuals, and supporting documents extends us how to implement the requirement of the code. For example, the code in case of a diagnostic X-ray will say that there should be the appropriate shielding for housing the X-ray machine. This is the requirement of the code. While when you refer the guide will say that what sort of a brick thickness wall has to be there, where should be the control room. So guide will provide how to implement the code as such. So we have the code on the medical X-rays, we have the code on radiation therapy, and ARB has a code on the nuclear medicine. And hence, on every such a practices, there are codes prescribed by ARB, which are based on the WHO standard, international standard, regulatory experience, and several other national standards as such. So code is a mandatory document from ARB. How ARB regulates such a thousands and thousands of radiation facilities all over the country. We have the online system that is called electronic licensing system, which is the unique system in the world, because this is here we provide the surveillance to the radiation facility from the cradle to grave. Starting from giving the license for procurement of the machine or procurement of the source to till its decommissioning. So we track the movement of the radiation equipment or medical device or the radiation source. This is the LRS system. Then we have, there should be a radiological safety officer who should be designated. All the cardiologists, radiologists, they are designated as the radiation safety officers, and there should be qualified and certified medical professional staff as well as the paramedical staff. Then we have the annual dose limit to occupational workers. So this annual load limit is called as the accepted annual dose limit, that whenever any medical professionals, for example, the oncologist or the radiologist, works within the stipulated dose limit, then it is considered as an acceptable risk to the society, or it will consider as a safe limit for the occupational worker, and this limit in any case shall not exist. And we have, of course, the regulatory decisions which are independent, transparent, and different type of approvals we give in the for medical X-ray we give registration, for brachytherapy we give authorization, for CT scan and cancer hospitals we give license depending upon the hazard potential of the radiation source. We do have interministerial coordination like Director General of Forestry, Ministry of Commerce and Industries for import of radiation equipment. Like, for suppose the CT scan equipment is to be imported, BMT machine is to be imported, then we have the coordination with the DGFT, then Central Drug Standard Control Organization of Director General of Health Services. We have close interactions with them that manufacture, supply, sell, import of medical equipment. In fact, I happen to be a member of some committees of the Ministry of Health, which are under the CDSCO. Then we have a intermittent coordination with the Quality Council of India like NABL and NABH. NABL accredits the facilities based on the recommendations of NABL, and NABH incorporates the ARB requirements in their standard. Then we have the Ministry of Finance, like the Central Board of Excise Customs for the import of this one, and we do have international coordination in the country like US, then Finland, Canada, Japan or so. Now, this is very important slide for all the delegates. These are the dose limits for the radiation worker, or we call as occupational worker, that is 30 millisievert maximum in a year and 20 millisievert averaged over 5 years. So this is the dose limit for the X-ray technologies, for the nuclear medicine technologies, for the nuclear medicine physician, for radiotherapy. So all the medical professionals who are handling the ionizing radiation sources, this is the dose limit. Of course, this dose limit is also applicable to other occupational staff which are working in the nuclear fuel cycle facilities or in the food processing facilities. While for public it is 1 millisievert in a year. Now, why the dose limit is higher for the occupational workers which are working radiation? Because number one, they get the direct benefit of this use of ionizing radiation. Number two, that they are under constant surveillance, they are getting monitored, they are being given the personal monitoring badge. And number three is that this is based on the international standards, which is considered to be the acceptable dose limit all over. And then for pregnant radiation worker, yes, of course, there is a different limit, that is a 1 millisievert, because which is the limit for the members of the public, because we consider the pregnant woman as a member of the public because she carries as a fetus, as a member of the public for which there is a dose limit as such, and definitely it is not from some sort of a radiation hazard point of view. And if we compare these dose limits in the form of a, let us say, some sort of a pictorial perspective like a Qutub Minar, then you see that the thickness of the eraser is a public dose limit, while the height of the fire hydrant is the occupational dose limit. And if you take a dose limit up to the height of even our conventional vehicle, you won't find any detectable effects as such. But if the height of 7-story building is there, then yes, if this much dose, I mean, it is a perspective, then there can be some detectable as such. So what I wanted to say that the public dose limit as well as the occupational dose limit is considered to be acceptable to the society as a very safe limit, where the risk is 1 in 10,000 in a year for any, that undesirable effects as such. So now I will come to the main topic, that is a diagnostic radiology, where we use a different type of equipment like a general purpose radiography, fluoroscopy, then dedicated fluoroscopy, mammography, and several X-ray equipments are being used. And of course, there are advanced, some sort of a design features and technologies are coming, like CT scan. Earlier it was some just 16 slides machine. Now today it is 320 to even 640 slides computer tomography equipments are coming. And important, this is what I wanted to say, that when during even COVID-19, several patients undergone the X-ray examinations for finding out the status of the lung. And, in this case, so during this process, we must see that the occupational staff, either the technologist or radiologist, should always stand behind the barrier that is called as a lead barrier, so that the scattered radiation, what we see is here, is absorbed in the shield and the occupational work is protected. Now, if you take the intervention radiology, which is considered to be a very lengthy and complex procedure, here the doctors are very close to the patient and close to the X-ray beam, then it takes a lot of long time for the procedure. And intervention radiology is really a concern from the radiation protection point of view all over the world, because here the doses received are very high as compared to even the dose limits. Of course, these are received by the patient, but almost 0.1 to 0.5% doses are received by the cardiologist. And if you see the dose range, this is what you see, the reddening in the skin. It is because it is called because of the high radiation, localized radiation, and we call it as a radiogenic burn or radiogenic tumor, and the dose is of 1 gray to 20 gray. You see, the cardiologist is permitted to receive in a year 20 gray. Gray and sievert is almost the same unit, while in one IR procedure, it may be a TIPS, it may be some sort of a different procedures, which takes a long time, that the dose, annual dose limit is just delivered to the patient in one examination. And even sometimes, even effective dose goes from 10 millisievert to 70 millisievert, which may lead to the skin burn or even the chromosome aberration or even the reduction in the WBC count. So we have to be very careful when you see that the patient is, done for the IR as such. This is the important slide. I will not spend much time into that because of a very limited time, but only I would like to say that whenever a patient undergoes different type of examinations, the dose to the patient is in the middle column. For example, chest X-ray. One chest X-ray costs 0.1 millisievert. It is as good as we are giving him 10 days background radiation to the patient in advance. As I showed in the first slide, the natural background is of the order of 2.4 millisievert in a year. And this background radiation is nothing but again is ionizing radiation. If you take even, let us say, the coronary CT angiography, the patient receives 12 millisievert, means we are giving him 4 years cumulative background radiation to the patient. So we have to be very careful when we choose the patient for examinations. Of course, it's a decision of the medical practitioner. It is required, but we have to keep it in mind that we are irradiating the patient with a very with a high background radiation also as such equivalent. It is the equivalence, like CT head 2 millisievert equivalent to we means exposed to the 8 months background radiation in advance. So if you see the licensed X-ray equipment in India, they are increasing very rapidly. For example, in Maharashtra itself, it is almost about 13,756 total city X-ray equipments are licensed. So ARB has licensed so far 88,000 X-ray equipment in the country as such. And if you see in the Kolhapur, it is one. Yesterday only I saw my colleague Mr. Anand's have seen in the Ellora system 157 X-ray equipments are there itself in the Kolhapur as such. Now coming to the nuclear medicine, it is also one of the very important diagnostic practice using the radiopharmaceuticals. It is a molecular imaging in fact, and is a functional imaging technique. It is a highly organic specific, and here directly the radioactive material is used. It is not radiation generated equipment like X-rays or CT, but here it is a radioactive material which is prepared in the nuclear research reactor like a Dhruva and Apsara in BRC, and then it is supplied to the hospital. And the dose delivered is of the order of 1 to 10 millisievert to the patient as such. There are some examples like a brain scan using the nuclear medicine. Similarly, technetium 99, the main workhorse of nuclear medicine is shown on the right side as such. And these are the different, again, the organs where, the nuclear medicine is very effectively performed for getting a very good image, and the activities of the order of 10 millicurie to 300 millicurie range as such. These are the total facilities in the country. Like PET CT, we have 8 to 85. In Maharashtra, it is almost 49. PET MRI, we do not have so far, but it will be there so very shortly. So this ARB maintains the inventory of such medical devices emitting ionizing radiation. Coming to the next application, radiation therapy. The goal of radiation therapy is to kill the cancer cells with as little risk as possible to normal cells.
Hello.
The current pandemic is all about adapting and innovating. And I think that's what we're doing right now. There is some technical error.
Yes, continue, sir. Sorry for the interruption.
I think we are facing some technical errors, but I think in the history of Kmacon, this is the first time we are having an online session. As I said, adapting and innovating.
Is it audible? He's on the line. Can we take question answer till then? Question and till then we can take question answer. My audio then he is another busy. Is open. Answer problem. Sorry for the there is some technical hitch there, and just have little patience till we sort it out.
We now request our President, Dr. Abba Saheb Shirke, and Honorable Secretary, Dr. Geeta Pillai, to kindly felicitate our chairpersons, Dr. Sopan Saugale and Dr. Sandeep Sahu. I think Dr. Sonane has got disconnected.
Presentation. Where is the presentation? Presentation is there on the home page. This.
Thank you. Now we will be having the Atul Zogrekar or we will now have the Atul Zogrekar oration. Hello. Kmacon 2021.
Can you hear me now?
To build a healthier world.
I can speak now? Okay. Yeah. Hello. So, this is what I wanted to give mainly the information to you about the total number of facilities and all, and almost I have completed my presentation. And what the message I would like to give it that yes, ionizing radiation is really blessings and very important, plays a very vital role in healthcare sector. So we have to give due respect while handling such a sources. And if you handle safely as per the regulations, as per the some sort of say procedures, then radiation sources are going to give the benefits. So this is what my message is there, that you have to see that the staff which is required for storage handling is present all the time, and then the person monitoring badge, TLD badge is over all the time. And then this is what to be kept in mind, and you keep on training your staff who are involved in handling such a sources. So I will definitely plan coming to the Kolhapur, and that time we will have again more discussions on this. And this once again, I special thanks to Dr. Shailesh as well as the organizers for giving this opportunity, and wishing you a very safe stay in COVID. Wishing you a very good safety in handling resources, and all the best. Thank you very much.
Thank you, sir.
Thank you very much, sir. Sorry for the interruption due to technical issues, but nonetheless, we are very much thankful and giving a broad perspective about the radiation. And you have made us well aware about the other things in advanced radiation, interventional radiology, and making us aware about the exposure. Thank you very much, sir. Thank you very much again for keeping it very active and alive through online. Thank you very much. On behalf of KMA IMA, we are extremely thanks for your continuous support to our Flash, our monthly magazine, giving us your documents and your publications and also advertisement to our monthly publication. Thank you very much, sir.
Thank you, sir.
Thank you. Thank you. Welcome.
We will shortly begin with the Atul Zogrekar oration program. Kmacon 2021. Marching together to build a healthier world. After this, we will be having 3 more sessions, and then we will have the valedictory function. So I request everyone to kindly be seated in the hall. The next session will be on sports injuries around the knee and spine surgery amplified. After that, we have how to evaluate shoulder pain. Current advances in knee replacement and what is new regarding it. We also have pitfalls in clinical neurology, recent advances in stroke care, setting up rural cancer care, and weight regain after bariatric surgery, and what are the options for it. So we really have a good array of sessions. I request everyone to kindly remain seated and enjoy these sessions. At present also, we are having around 100 participants who are online. So I think that is another feather in the cap of KMA and the Kmacon committee, because we have really been working hard for it. I think yesterday's day was also very good. We had a good set of lectures yesterday also. Hope you all have enjoyed. Kolhapur Medical Association was formed in 1924, which was around 4 years before Indian Medical Association was formed. So this is one of the history of Kolhapur Medical Association, established before Indian Medical Association. Yeah, and I think, Kolhapur Medical Association is the only association which is known as KMA. Rest are known as IMA, branch, whatever, wherever place. Yes, the name of the city. One more thing, the R.K. Menda Trophy, which was given by IMA for community service, was consecutively given for 5 years to Kolhapur Medical Association. Seeing this finally, IMA gave this trophy permanently to Kolhapur Medical Association. So we have the R.K. Menda Trophy with us for community service.
सर्व श्रोतृ वर्गाला मनःपूर्वक अभिवादन. कालपासून कोल्हापूर मेडिकल असोसिएशनची ही शास्त्रीय सभा प्रत्यक्ष आणखीन दूरसंपर्क माध्यमांच्या द्वारे आपण सगळेजण अवलोकन करत आहात. आज डॉक्टर अतुल जोगळेकर ओरेशन कार्यक्रमामध्ये आपल्या सर्वांचं मनःपूर्वक स्वागत. आणि आजचं एक योगायोगी असं आहे की हा जागतिक शास्त्रीय दिवस, वर्ल्ड सायंटिफिक डे आहे. या औचित्याने कोल्हापूर मेडिकल असोसिएशननी कोल्हापूरच्या वैद्यकीय विश्वासाठी केलेल्या अनेक उपक्रमांच्या पैकी वैद्यकीय व्यावसायिकांना प्रोत्साहित करणारा हा एक वेगळा उपक्रम आपण आज आयोजित करतो आहोत. आणि पुन्हा एकदा आपल्या सर्व अभ्यागतांचं, सर्व श्रोतृवर्गाचं मनःपूर्वक स्वागत. मी कोल्हापूर मेडिकल असोसिएशनचे अध्यक्ष डॉक्टर आबासाहेब शिर्के यांना विनंती करतो की आजचे आपल्या कार्यक्रमाचे खरं तर त्यांना आश्रयदाते म्हटलं पाहिजे डॉक्टर अतुल जोगळेकर, आणि त्याचबरोबर आपण ज्यांची या आजच्या ओरेशन अवॉर्ड असं म्हणतो आपण, पण माझी मगाशी डॉक्टर अतुल जोगळेकरांशी आबासाहेब शिर्केंच्या माध्यमातून जी चर्चा झाली की याला आपण निव्वळ ओरेशन अवॉर्ड असं न म्हणता कोल्हापूरच्या वैद्यकीय क्षेत्रामध्ये काही वेगळ्या प्रकारचं काम करणाऱ्या माणसाचा जीवनगौरव पुरस्काराने सन्मान करतो आहोत. असे आजचे पुरस्कार प्राप्त डॉक्टर अशोक भूपाळी या उभयतांना आपण घेऊन व्यासपीठावर यावं अशी मी आपल्याला विनंती करतो. कोल्हापूर मेडिकल असोसिएशनच्या कार्यवाह डॉक्टर गीता पिल्ले यांनी व्यासपीठावर स्थान ग्रहण करावं. त्याचबरोबर गेले काही महिने अथक परिश्रम करून ही शास्त्रीय सभा, म्हणजे आपण Kmacon म्हणू त्याला, की ज्यांच्या मार्गदर्शनाखाली आणि ज्यांच्या सहकार्याने पूर्ण होतीये, ते कोल्हापूर मेडिकल असोसिएशनचे Kmaconचे चेअरमन डॉक्टर साई प्रसाद यांनीही व्यासपीठावर यावं. त्याचबरोबर सहअध्यक्ष डॉक्टर AB पाटील यांनी व्यासपीठावर यावं आणि Kmaconचे कार्यकारी सचिव म्हणजे ऑर्गनायझिंग सेक्रेटरी डॉक्टर शैलेश कोरे यांनीही व्यासपीठावर यावं. आणि या सर्व गोष्टींचा खर्च ज्यांनी सही केल्याशिवाय मिळणार नाही ते कोल्हापूर मेडिकल असोसिएशनचे खजिनदार स्वतःच्या खिशामधल्या पेनसह त्यांनी व्यासपीठावर यावं अशी मी त्यांना विनंती करतो. आजच्या कार्यक्रमाचे की ज्यांच्या संकल्पनेमधून आजचा कार्यक्रम आपण साकार करतो आहोत ते डॉक्टर अतुल जोगळेकर यांचं स्वागत कोल्हापूर मेडिकल असोसिएशनचे अध्यक्ष डॉक्टर आबासाहेब शिर्केंनी करावं अशी मी त्यांना विनंती करतो. त्याचबरोबर आजच्या गौरवमूर्ती डॉक्टर अशोक निळकंठ भोपाळी यांचंही स्वागत आपले अध्यक्ष डॉक्टर आबासाहेब शिर्के आणि त्यांच्याबरोबर कार्यवाह डॉक्टर गीता पिल्ले यांनी करावं अशी मी उभयतांना विनंती करतो. शतकाच्या उंबरठ्यावर उभी असणारी कोल्हापूर मेडिकल असोसिएशन 1924 साली आपली शताब्दी साजरी करतेय आणि या शताब्दीच्या निमित्ताने अनेक कार्यक्रमांची जी आखणी करतो आहोत त्यात डॉक्टर अतुल जोगळेकर जीवन गौरव पुरस्काराची आपण पुनर्मांडणी करणार आहोत. याच्याविषयी यथावकाश अध्यक्ष डॉक्टर आबासाहेब शिर्के सांगतीलच. मी त्यांना विनंती करतो की आजच्या या कार्यक्रम प्रसंगी आपण उभयतांचं सर्वांचं स्वागत करावं आणि प्रास्ताविक करावं ही आपल्याला विनंती आहे.
आजच्या या डॉक्टर अतुल जोगळेकर वरिष्ठांसाठी उपस्थित असलेले व्यासपीठावरील मान्यवर सन्मान्य डॉक्टर अतुल जोगळेकर आणि सभागृहात उपस्थित असलेले जोगळेकर परिवार, सन्मानप्राप्त प्रख्यात हृदयरोग तज्ञ ॲपल हॉस्पिटल अँड रिसर्च सेंटरचे सर्वेसर्वा डॉक्टर अशोक भोपाळी सर, सर्व उपस्थित या सर्वांचा मी कोल्हापूर मेडिकल असोसिएशनतर्फे मनापासून हार्दिक स्वागत करतो. हे तसं तिसरं वर्ष डॉक्टर अतुल जोगळेकर वरिष्ठांचं. 4 वर्षापूर्वी ज्यावेळी KMAE फायनान्शियल क्रायसिस मध्ये होती त्यावेळी डॉक्टर जोगळेकर परिवाराने दाखवलेल्या औदार्यामुळं कोल्हापूर मेडिकल असोसिएशन ही आर्थिक विवंचनेतून बाहेर पडण्यासाठी जे औदार्य दाखवलं त्यासाठी KMA त्यांचे सदैव ऋणी राहीलच. हा जो ओरेशनचा कार्यक्रम आहे तसंच हा ओरेशनच्यासाठी त्यांनी जे काही सांगितलेले आहे की ही निवड करताना त्या व्यक्तीची KMA मेंबर असावी शक्यतो म्हणजे मस्ट. आणखी त्याची कोल्हापूर मेडिकल असोसिएशन त्यांचं या असोसिएशन मध्ये जडणघडणीत त्या व्यक्तीची वैद्यकीय व्यवसायाची मोलाचा वाटा असावा याचा आम्ही प्रकर्षाने काळजी घेऊ. यावर्षी कोविडच्या कार्यक्रमामध्ये शासन स्तरावर भाग घेताना प्रकर्षानं जाणवलं की शासनाच्या महाराष्ट्र शासन असू दे किंवा भारत गव्हर्नमेंट असू दे त्यामध्ये फक्त IMA हीच संघटना मान्यता प्राप्त आहे. त्यामुळं सर्वांनी मी काल सुद्धा आवाहन केलंय की या संघटनेमध्ये ज्येष्ठांचे ज्येष्ठ आपले वैद्यकीय व्यावसायिक तसंच तरुण डॉक्टरने सुद्धा या संघटनेत जरूर पुढे यावं आणि KMA ही आणि IMA ही स्ट्रॉंग करावी असं मी आवाहन करतो. ह्या पुरस्कार प्राप्त डॉक्टर भोपाळी सर आणखी ह्या पुरस्काराचे जनक डॉक्टर जोगळेकर सर यांच्याबरोबर माझ्या सुदैवानं 83 पासून मी 89 पर्यंत मी त्यांच्याबरोबर मेडिकल ऑफिसर म्हणून काम करण्याची मला संधी मिळाली. यांच्याबरोबर कोल्हापूर महापालिकेच्या सावित्रीबाई फुले हॉस्पिटल आणि पंचगंगा हॉस्पिटलमध्ये. एवढं बोलून मी ह्या प्रास्ताविक थोडक्यात आटपतो. धन्यवाद.
धन्यवाद शिर्के सर. कोल्हापूरच्या वैद्यकीय क्षेत्रामध्ये गेल्या अनेक दशकांमध्ये योगदान देणाऱ्या आणि अजूनही देणाऱ्या एखाद्या व्यक्तीस, वैद्यकीय व्यावसायिकास डॉक्टर अतुल जोगळेकर ओरेशन ही मूळ संकल्पना होती. त्याचं स्वरूप आमूलाग्र आपण बदलत आहोत आणि कोल्हापूर मेडिकल असोसिएशनचा सदस्य असणारा, कोल्हापूरच्या वैद्यकीय विश्वामध्ये आमूलाग्र बदल घडवणारा आणि अजूनही बदल घडवण्याची इच्छा असताना कार्यरत असणाऱ्या व्यक्तीस इथून पुढे डॉक्टर अतुल जोगळेकर जीवन गौरव पुरस्कार दिला जाईल. हे याच्या स्वरूपात जो बदल झालेला आहे हे डॉक्टर आबाजी शिर्के आणि जोगळेकर सरांशी जी चर्चा झाली त्या चर्चेवरून आम्ही घोषित करतो आहोत. आणि याचा विशेष कार्यक्रम प्रतिवर्षीपासून आपण वेगळ्या पद्धतीने आयोजित करणार आहोत. आज काही वेगवेगळ्या घटना जगामध्ये घडतायत आणि तुम्हा सगळ्यांचं त्याबद्दल अभिनंदन करायला हवं की आज सकाळी किती लोकांनी आंतरराष्ट्रीय बातम्या वाचल्या याची मला कल्पना नाहीये. पण जागतिक शास्त्रीय दिनाच्या निमित्ताने WHO ने आज एक घोषणा केलेली आहे की आतुरस्य व्याधी परिमोक्षः स्वस्थस्य स्वास्थ्य रक्षणंच. ही जी भारतीय पारंपरिक शास्त्रामधली आयुर्वेदामधली जी मूळ घोषणा आहे की माणसाला आजारी पडू देऊ नका आणि चुकून आजारी पडलाच तर मग त्याला उपचार करा, ही वर्ल्ड हेल्थ ऑर्गनायझेशनने अधिकृत घोषणा म्हणून आजच स्वीकारलेली आहे. याच्याबद्दल आपल्या सगळ्यांचं मनपूर्वक अभिनंदन. आजच ती घोषणा उद्या परवा वृत्तपत्रांच्या मध्ये येईलच, पण हा सगळ्यांच्या दृष्टिकोनातून अत्यंत गौरवाचा भाग आहे. आणखी फेब्रुवारी महिन्यामध्ये ही कॉन्फरन्स साई तुमचं नशीबच दिसतंय, कारण भारतामधल्या पहिल्या ओपन हार्ट सर्जरीला फेब्रुवारीमध्ये सुरुवात झाली. आणखी त्याची 60वी जयंती आजच साजरी होतीये. या सगळ्या काही वेगवेगळ्या घटना आपल्या इकडे घडतायत. कोल्हापूर मेडिकल असोसिएशन सर्व स्तरांच्यावर कार्यरत असते आणि 100च्या उंबरठ्यावर असताना सर्वांना एकत्रित करून सर्वसमावेशक अशा प्रकारे हे संघटन निर्माण व्हावं याच्यासाठी ज्या स्तरांवरती कार्यरत असते. मी कार्यवाह डॉक्टर गीता पिल यांना विनंती करतो की KMAची जी वाटचाल सुरू आहे याच्याविषयी आपलं मनोगत आपण व्यक्त करावं.
धन्यवाद अमर अडके सर. सुप्रभात. आजच्या अतुल जोगळेकर ओरेशन मध्ये KMA तर्फे आपल्या सर्वांचे स्वागत. आज आपण शतकाच्या उंबरठीवरती, शतक महोत्सवीच्या उंबरठ्यावरती उभे आहोत. अनेक शैक्षणिक, सामाजिक व सांस्कृतिक कार्यक्रम करत आम्ही शतकी महोत्सवाकडे वाटचाल करत आहोत. दर महिन्याला आम्ही शैक्षणिक पात्रतेचे भान ठेवून दर महिन्याला आम्ही एक CME घेतो. दरवर्षी Kmacon सारखी परिषद घेतो. सामाजिक बांधिलकी जोपासण्यामध्ये पण KMA मागे नाही. विविध मोफत आरोग्य तपासणी शिबिर व रक्तदान शिबिर दरवर्षी आयोजित करतो. 62 वर्षांपासून लहान मुलांसाठी OPD आम्ही अथकपणे कार्यरत ठेवलेली आहे. मागील 2 वर्षांपासून आम्ही वयोवृद्धांसाठी पण OPD सुरू केलेली आहे आणि ही OPD आम्ही जेरिएट्रिक सोसायटी कोल्हापूर ब्रांच यांच्या बरोबर चालवत आहोत. अशीच मजल दरमजल करत KMA IMA राज्यस्तरावरती 3 वेळा बेस्ट सिटी ब्रांच म्हणून RK मेंढे ट्रॉफीचे मान मिळालेला आहे आणि हा मान 3 वेळा मिळाल्यावर आपल्याला ही ट्रॉफी कायमचीच दिलेली आहे. तसंच आम्ही नॅशनल लेवलवर पण कमी पडलेलो नाही. 2005 साली भारतामधील बेस्ट ब्रांच मिळाल्याचा मानही आपल्याला मिळाला आहे. अशी अनेक तुरे आम्ही शेरपेचात घेऊन वाटचाल करत आहोत. सांस्कृतिक कार्यक्रमामध्ये पण आपण काही मागे नाही आहोत. आपण कोल्हापुरातल्या डॉक्टरांच्या जे कलागुण आहेत ह्यांना वाव देण्यासाठी, त्यांना आणि त्यांच्या फॅमिली मेंबर्सना वाव देण्यासाठी आपण एक सांस्कृतिक कार्यक्रम 1 जुलै डॉक्टर्स डेला घेतो. आणि ह्या दिवशी अनेक कलागुणांना त्याला आम्ही प्राधान्य देतो. तसंच मागच्या वर्षी आम्ही घेतला, त्यात लॉकडाऊन पिरियडमध्ये लोकांनी केलेले ड्रॉइंग्स, त्यांचे पेंटिंग, बरेच त्यांचे आर्ट्स कला प्रदर्शनाला आपण वाव दिला आणि एक आर्ट एक्झिबिशन आपण घेतलं होतं, ज्याच्या ओपनिंगसाठी आपले कलेक्टर दौलत देसाई, कमिशनर डॉक्टर कलशेट्टी हे सगळे उपस्थित होते. त्याच दिवशी आपण ब्लड डोनेशनचा कॅम्पही घेतला होता. जसं हे वावगुणाला आपण वाव देतो, तसंच KMA कट्टा ही पण संकल्पना आपल्याकडे आहे, जी दर महिन्याच्या 3ऱ्या गुरुवारी आपण एकत्रित येऊन एक वेगळ्या अशा संबंधित चर्चासत्र असतं. जसं आपण पहिली चर्चासत्र वेबिनार थ्रू लॉकडाऊनच्या पिरियड काळात सुरू केली. त्याच्यात डॉक्टर अमर अडके सरांनी किल्ल्यांच्या बद्दल माहिती दिली. परत नर्मदा परिक्रमावरती एक जण आपल्या डॉक्टर बोकेल येऊन बोलले होते. अशा बऱ्याच गोष्टी आहेत की आपण KMA कट्टा थ्रू केलेल्या आहेत. हँडिकॅप डे साजरा केलेला आहे. आणि असंच हे सांगण्याचा उद्देश एवढाच आहे की शतकी महोत्सवाच्या उंबरठ्यावर आपण आहोत. विविध कार्यक्रम करून KMAला एक वेगळा स्थान मिळवून देण्याचे आपलं मानस आहे. तरीही तुमच्या सर्वांचे मार्गदर्शनाची आम्ही अपेक्षा करतो. अजून बरेच डॉक्टर्स या अपेक्स बॉडीचे मेंबर्स व्हावे व या ऑर्गनायझेशनला एक ताकद अजून वाढवून द्यावी, अशी एक महत्वाची गोष्ट सांगू इच्छिते. आणखीन एक अशी गोष्ट आहे की आपण 20 मार्चला डॉक्टर ज्ञानेश्वर मुळे यांना इथे आमंत्रित करत आहोत. आणि मानांकित कोल्हापुरातले मान्यवर आहेत, आपले कलेक्टर दौलत देसाई, कमिशनर डॉक्टर बलकवडे मॅडम, SP मिस्टर बलकवडे, आपले CEO आपले कोल्हापूर कॉर्पोरेशनचे, ह्यांच्या प्रेझेन्समध्ये आपण कोविड वॉरियरांचा सन्मान पण करणार आहोत. प्लस एक एंडोस्कोपी कॉन्फरन्स, एंडोस्कोपीची एक छोटीशी चर्चासत्र पण आपण पुढच्या महिन्यात आयोजित करू. असेच दर बदल आपण वाटचाल करत पुढे जाणार आहोत. जास्त वेळ न दवडता मी आपल्या पुढचं सूत्रसंचालन डॉक्टर अमर अडके सरांच्याकडे देते. थँक्यू व्हेरी मच.
ज्या मुख्य कार्यक्रमासाठी आपण एवढ्या मोठ्या संख्येने जमलेलो आहोत, तो डॉक्टर अतुल जोगळेकर गौरव पुरस्कार प्रदानाचा कार्यक्रम आपल्या समोर सादर करताना आम्हाला अत्यंत आनंद होतोय. यावर्षीचा हा अतुल जोगळेकर ओरेशन आणि जीवन गौरव पुरस्कार आपण डॉक्टर अशोक निळकंठ भूपाळींना देतो आहोत. हा पुरस्कार देत असताना त्यांची ओळख अवघ्या कोल्हापूरला आहे आणि त्यांच्या स्वतःच्या कृतज्ञतेच्या मनोगतामधून ते स्वतःची ओळख त्यांना जी वाटतेय ते सांगतीलच. त्यामुळे लिहून दिलेली ओळख सांगणार नाही मी. पण हा पुरस्कार किंवा ओरेशन पुरस्कार देत असताना ज्या पद्धतीने डॉक्टर आबासाहेब शिर्केंच्या टीमनी ही घोषणा केली, त्याच्यामध्ये एक महत्वाची गोष्ट अशी होती की गेल्या 3 दशकांचा हृदयरोगाच्या चिकित्सेचा आणि निदानाचा प्रवास जो इथपर्यंत येऊन पोहोचला, त्यातले महत्वाचे शिलेदार डॉक्टर अशोक भूपाळी आहेत. म्हणजे एक काळ असा होता की ब्लड प्रेशर वाढलं तरी मिरजेला पळावं लागत होतं, ते आता लोक मिरजेहून पळून इथपर्यंत येतात. हे जे काही सर्कल पूर्ण झालेलं आहे त्याचे महत्वाचे साक्षीदार डॉक्टर अशोक भूपाळी आहेत. हा जो हृदयरोगाच्या संपूर्ण उपचारांचा इतिहास, त्याच्या घडामोडी, त्याचा संघर्ष, या सर्व गोष्टींचा विचार करून या जीवन गौरव पुरस्कारासाठी भूपाळी सर आपली निवड केलेली आहे. आणि हा सगळा संघर्षाचा प्रवास आपण आपल्या मनोगतातून मांडावा अशी इच्छा आहे. माझ्याकडे खरं तर हा प्रचंड मोठा हे परिचय पत्र दिलेलं आहे ते प्रत्येकाच्या मनामनामध्ये आहे. पण एक 2-3 गोष्टी मला सातत्याने त्याच्यातल्या भावल्या की 1972 साली MBBS सेट GS मेडिकल कॉलेजमधून केल्यानंतर त्याच महाविद्यालयाशी संलग्न राहून एक उत्तम हृदयरोग तज्ज्ञ म्हणून आपण बाहेर पडलात. एखाद्या संस्थेमध्ये इतका काळ राहून त्या संस्थेशी एकरूप झाल्यानंतर मुंबई न धावता आपण कोल्हापूरला आलात आणि म्हणून आज आमच्यापर्यंत आपण पोहोचला आहात. त्याच्याबद्दल आपलं मनःपूर्वक अभिनंदन. त्यात एक गोष्ट मला जाणवते ती अशी की त्या बायोडाटामध्ये एक गोष्ट आपण आवर्जून लिहिलीत की गवत मंडईमध्ये प्राथमिक शिक्षक बँकेच्या वर पाठीमागच्या बाजूने जिना चढून वर जाणाऱ्या त्या रुग्णालयापासून आज 200 बेडचं हॉस्पिटल आणि त्यामध्ये 80 ICU हा जो मधला प्रवास आहे हा कदाचित 2 मैलांचा भौगोलिक दृष्ट्या असेल, पण तो गेल्या 3 दशकांचा किंवा जवळजवळ 3 तपांचा तो प्रवास आहे. आणि ह्या सगळ्यांच्या मध्ये एक गोष्ट आम्हाला जाणवली ती अशी, एक मार्टिन ल्युथर किंग नावाचा एक समाज सुधारक होता. तो नेहमी म्हणायचा की तुम्ही कुठपर्यंत पोहोचलात हे बघू नका, कुठपासून आलात हे पहा. ते कुठपासून तुम्ही आलात याच्यासाठी तो पुरस्कार आहे, कुठपर्यंत पोहोचलात याच्यासाठी तो नाहीये. आज 2 गोष्टी अत्यंत महत्वाच्या आहेत की ज्या आपल्या साक्षीने सांगू शकतो की आम्हाला नेहमी असं वाटतं की जगामधली पहिली हृदयरोगाची शस्त्रक्रिया 1893 साली झाली, आणखीन ती अपघाताने झाली की हृदयामध्ये सुराख उपसल्यानंतर तो माणूस आला. आणि 1893च्या जुलैमध्ये ती झाली. डॉक्टर डॅनियल हेल विल्यम्स नावाच्या माणसाने शस्त्रक्रिया केली आणि तो माणूस वाचला. आणखीन तेव्हा लक्षात आलं की हृदयाची शस्त्रक्रिया सुरू होते, पण ती हृदयाची शस्त्रक्रिया भारतात पोहोचेपर्यंत 1961 साल उजाडलं आणि बायपास शस्त्रक्रियेचं 1975 साल उजाडलं. ते डॉक्टर केन दस्तूर नेहमी असं म्हणतात की मी माणसाचं हृदय पाहत नसतो, त्या हृदयामधला माणसाचा जिवंतपणा पाहत असतो, तो मला टिकवायचा असतो, तो जो टिकवतो तो खरा हृदयरोग तज्ञ असतो. असं पहिली शस्त्रक्रिया ज्यांनी केली डॉक्टर केन दस्तूर नायर रुग्णालयामध्ये. ते म्हणाले की हृदय काय मी बंद करू शकतो, पण माणसाला मी बंद करू शकत नाही. तर अशा हृदयाशी आपण सम्मिलित आहात आणि त्याच्यासाठी हा पुरस्कार भूपाळ सर या सर्वांच्या साक्षीने आम्हाला देत आहोत. त्याच्या मानपत्राचं वाचन मी आपल्या सर्वांच्या साक्षीने करतो. आणि मी महोदय, कोल्हापूर मेडिकल असोसिएशन तर्फे आपणास हे सन्मानपत्र प्रदान करण्यात येत आहे. कोल्हापूर मेडिकल असोसिएशन ही शतकाच्या उंबरठ्यावर उभी असणारी वैद्यकीय व्यावसायिकांच्या भारतातील सर्वात जुन्या संघटनांपैकी एक आहे. कोल्हापूर आणि परिसरातील सर्व वैद्यकीय व्यावसायिकांची ती अग्रणी संस्था आहे. आपण 4 दशकांहूनही अधिक काळ हृदयरोग तज्ज्ञ या नात्याने सर्वदूर रुग्णांच्या सेवेत कार्यरत आहात. किंबहुना कोल्हापूर आणि परिसरातील हृदयरोग चिकित्सा उपचारांच्या आरंभ शिलेदारांपैकी एक आहात. कोल्हापूरचा हृदयरोग उपचारांचा इतिहास आपण केलेल्या सेवेची दखल घेतल्याशिवाय पूर्ण होऊ शकत नाही असा आमचा दृढ विश्वास आहे. आपल्या वैद्यकीय सेवा काळात आपण आपल्या रुग्णालयामार्फत हजारो रुग्णांवर उपचार केलेत आणि करतही आहात आणि त्यांना नवजीवन देत आहात. ही कृतज्ञ रुग्णसेवा निश्चितच गौरवास पात्र आहे. गेल्या 4 दशकांहून अधिक काळच्या कोल्हापूरच्या वैद्यकीय सेवेच्या प्रगतीचे आपण आधारस्तंभ आहात. म्हणूनच कोल्हापूर मेडिकल असोसिएशन मार्फत सर्व वैद्यकीय व्यावसायिकांच्या वतीने आपल्या वैद्यकीय सेवा गौरवार्थ हे सन्मानपत्र प्रदान करण्यात आम्हा सर्व वैद्यकीय व्यावसायिकांना निश्चितच आनंद होत आहे. मी डॉक्टर आबासाहेब शिर्के, डॉक्टर अतुल जोगळेकर, डॉक्टर साई प्रसाद, डॉक्टर AB पाटील, डॉक्टर शीतल देसाई, डॉक्टर गीता पिल्लाई, डॉक्टर शैलेश कोरे आणि तुम्हा सर्वांचे मानसिक हात मी विनंती करतो की आपण हा पुरस्कार आपल्या अमृत हस्ते डॉक्टर अशोक भूपाळींना प्रदान करावा. धन्यवाद. सर्व अभ्यागतांनी पुन्हा स्थानापन्न व्हावं. आणि सत्काराची कृतज्ञता म्हणजे केएमएची सुपारी सरांनी घेतलेली आहे. म्हणजे ती आधीच होती, पण आज पुन्हा नव्याने ती सुपारी दिलेली आहे. कारण मध्यंतर थोडी सुपारी आम्ही आणायला जायचं तर धाडस करत नव्हतो. आता उद्याला करतो. या कार्यक्रमाचा जो एक हृदय भाग आहे की वक्ता दशसहस्रेषु दाता भवती वानवा, आमच्या अध्यक्षांनी परमनंट अध्यक्षांनी मला सूचना केलेली आहे. पूर्वी शामराव होते, आता आनंद आहे. म्हणजे तो सांगेल तसं अध्यक्षांनी वागायचं. आणि तो हळूच सांगून गेला मला की भूपाळी मॅडम रागावतलेलं बरं का, त्यांना बोला रे म्हटलं इथं लिहिलेलं आहे मी. आणि तसंच शेजारी जोगळकर मॅडम बसलेले आहेत. त्यामुळे आनंदा मान्य. पैसे तर मिळतातच, पण ते पैसे देण्याची मनोवृत्ती जी आहे, म्हणून या पुरस्काराचं नाव डॉक्टर अतुल जोगळेकर आहे. की छोट्याशा त्या लोड बेरिंगच्या बांधणीच्या कोल्हापूर मेडिकल असोसिएशनच्या कार्यालयातून आज एवढं प्रचंड मोठं 38 लाखाचं नाही का, PM चौगुले सर कुठेच, त्या छपरापर्यंत आपण जे पोहोचलो, हे सगळं आपण केएमए प्रती जी एक कृतज्ञ भूमिका व्यक्त करत आहात त्याच्यासाठी आहे. आणि शतकांची ही संस्था आपली अत्यंत ऋणी आहे. आम्ही हे आमचं कर्तव्य समजतो की डॉक्टर अतुल जोगळेकरांचा कृतज्ञ सत्कार डॉक्टर आबाजी शिर्के आपल्या आणि डॉक्टर गीता पेल यांच्या हस्ते व्हावा. हो बरोबर. आपला हेतू लक्षात आला. नारळ दिलेलं नाही, या सुपारीवर आहे. वारंवार सूचना येते, पण इथे लिहिलेलं आहे की ग्रहस्वामिनी शिवाय आपल्याला पूर्तता येत नसते. पण म्हटलं केव्हा नेमकं बोलवायचं, तुमच्या दोघांच्या गळ्यात शाल पडल्याशिवाय त्यांना वर बोलवणं योग्य नाही. त्यामुळे डॉक्टर प्रतिभा भूपाळी ज्या आमच्या माजी अध्यक्ष आहेत आणि डॉक्टर जोगळेकर मॅडम, आपण दोघींनी वर यावं अशी आम्ही आपल्याला विनंती करतो. आणि त्यांना नारळ सुपारी दिलेली आहे, पण तुम्हाला मी रोपटं देणार आहोत, कारण अशीच विधायक भूमिका त्यांच्या मनामध्ये आपण फुलवत राहात. आपण उभे आपण दोघींनी यावं. तोपर्यंत आपण बसायचं नाहीये, बसू शकत नाही. आता सुपारी कन्फर्म झाली. तिकडे मॅडम तिकडे रोप द्यायचा, रोप द्यायचा. हा प्रल्हाद शाल घातली पाहिजे ना. धन्यवाद. कोणत्याही कार्यक्रमाच्या औपचारिकतेच्या पलीकडे भावना असतात, त्या भावना या निमित्ताने आपल्या समोर आल्या. एक कोल्हापूर असोसिएशनचे माजी अध्यक्ष मेडिकल असोसिएशनचे डॉक्टर मोहन जोशी, हा एक असा अज्ञात दाता आहे की आपला फ्लॅशचा अंक प्रति महिन्याला निघत असतो आणि खूप चांगले चांगले शास्त्रीय आणखीन इतर लेख त्याच्यामध्ये असतात. या देणाऱ्यांच्याकडे आपण फारशी आजपर्यंत दखल घेत नव्हतो, कारण फ्लॅश भरवणं हाच आपला एक भाग होता. पण गेली काही दिवस स्वतःच्या पत्नीच्या नावाने कोल्हापूर मेडिकल असोसिएशनकडे काही ठराविक रक्कम देऊन त्याच्यामधून 2 लेखांच्यासाठी प्रतिवर्षी पारितोषिक द्यावीत असं त्याने आम्हाला आवर्जून सांगितलं. आणि या भावनिक कार्यक्रमाला ते प्रतिवर्षी हजर असतात. आम्ही आमचं कर्तव्य समजतो की आपला एक रोप देऊन सत्कार आम्ही या ठिकाणी करू इच्छितो. आपण कृपया व्यासपीठावर यावं. डॉक्टर आबासाहेब शिर्के आणखी डॉक्टर गीता पिल्लाई या दोघांना मी विनंती करतो की रोप देऊन डॉक्टर जोशींचा सत्कार करा. हो. आणि त्याचबरोबर संजय आणि हलकर्णीकर हे तयार आहेत का नावं तुमची? म्हणजे हा दिलेत ना? मी कोल्हापूर मेडिकल असोसिएशनचे अध्यक्ष डॉक्टर आबासाहेब शिर्केंना विनंती करतो की ज्या 2 पुरस्कार, हे सुपारी आत्ता घेतली आहे पण त्याची बिदागी नंतर मिळणार आहे बरं का. म्हणजे ह्या लेखांचं जे काही पारितोषिक आहे, हलकर्णीकर मी म्हणतो ते बरोबर आहे ना, आत्ता फक्त आपण जाहीर करायचंय. काय बक्षीस द्यायचं ते आपण मिळून ठरवू. हा, आणि ते बक्षीस नंतर दिलं जाईल. कॉर्लेस की
कोविड, हॅलो, कोविडच्या पार्श्वभूमीवर फर्स्ट लॉकडाऊन उठल्यानंतर आमची ऍक्टिव्हिटी चालू झाली आणि 11 महिन्यापूर्वी 10 अंक आमचे न चुकता पहिल्या 15 तारखेच्या आताच ह्यावेळी एडिटर बोर्ड डॉक्टर संजय घोटणे आणि प्रसाद हलकर्णीकडनं प्रसिद्ध केले. आणि ह्यावेळी अकॅडमिक आणि नॉन अकॅडमिक हे बरेच आर्टिकल आले. आणि रेखा मोहन जोशी अवॉर्डचे जनक डॉक्टर मोहन जोशी यांनी आम्हाला रिक्वेस्ट केली, अकॅडमिक तर सगळे डॉक्टर लिहितात पण तुम्ही यावर्षीपासून नॉन अकॅडमिकला पण एक द्या. तर ह्या 10 अंकातून आम्ही 2 पुरस्कार निवडलेले आहेत एडिटर बोर्डाने. अकॅडमिकसाठी डॉक्टर विनय वाघ, फॉरगॉटन आर्ट ऑफ मेडिकल प्रॅक्टिस. नॉन अकॅडमिकसाठी डॉक्टर राज होळकर,
आणि मी शिकार सोडली.
वाघ सरांची की सुपारी घ्यायची. दोन्ही पुरस्कार प्राप्त विजेत्यांचं मनपूर्वक अभिनंदन. ज्या संघर्षाच्या प्रवासासाठी जीवन गौरव पुरस्कार प्राप्त झाला त्या डॉक्टर अशोक भोपाळी सरांना मी विनंती करतो की आपली कृतज्ञता आणि आपलं मनोगत आपण सर्वांच्या समोर व्यक्त करावं. धन्यवाद.
Good morning, everyone. Dr. Shirke sir, President of KMA, my friend Dr. Sai Prasad, Geeta Pillai Madam, Dr. Adke sir, and most importantly, Jogolkar sir, who is the initiator of all this. All my dear colleagues who are present here and who are online. I am told that more than 300 people are logged in. In fact, काल काहीतरी मी बघत होतो ऑनलाईनच, त्यावेळी काही लोक बनियनमध्ये फिरत असताना दिसले मला. So the conferences are good because people can enjoy the conference truly at their home. Firstly, I would like to thank the Kolhapur Medical Association for this great honor which has been bestowed upon me. And I sincerely believe that I do not deserve it. But with all the humility and humbleness, I accept it. About this humility, ही ह्युमिलिटी मी इथे आलो त्यावेळी खूप ॲरोगंट होतो. म्हणजे बरेच सिनियर माझ्यावरचे दे विल ॲग्री विथ मी. आय वॉज अ हॉट हेडेड अँड व्हेरी कॉन्फिडंट यंग मॅन with no practice. And then I saw Jogolkar sir. I heard about Jogolkar sir. I'd not seen him for a couple of years. आणि जे त्यांच्याबद्दल जे ऐकायचो मी, सगळेजण मला सांगायचे काय तू करतोय प्रॅक्टिस, हे सगळं शिकून आलाय, सरांकडे बघ. आणि त्यानंतर मी एकदा सरांकडे गेलो होतो काहीतरी नंबर काढायला. त्यावेळी ते इतक्या हळू आवाजात बोलले काहीतरी 2-2 थेंब दोन्ही डोळ्यामध्ये दर 2-2 तासाने घाला. मला काही नीट ऐकू आलं नाही. त्यानंतर मी ENT सर्जन सोलापूरकरांकडे जाऊन की माझा कानाचा पण प्रॉब्लेम असतो. KMA is a great organization and I truly respect it because it is almost nearing 100 years. I am a part of that centenary committee and very proud to be a member of that. The 100 years is not a small period. That period is more than what the IMA is spent. And in all this, over the years, for last 40 years, I've been seeing the great leaders who are leading the organization and the great work which it is producing. The variety of work which it is producing, I do not think any branch in IMA can come anywhere closer to it. And because of this, very rightfully, at a national level, we will stand out as #1 branch. Congratulations to it, and my salute to KMA. Coming to the topic which I have been told, I was very hesitant when I said की काय एखाद्या माणसाची हिस्ट्री आणि हे सांगणं म्हणजे थोडंसं ऐकायचं पण कंटाळवाणं होते. मी हे केलं, मी ते केलं, अमुक केलं, तमुक केलं. तर काही जे मी काय बोलतो त्याच्यामध्ये इट मे अपियर दॅट आय एम डुईंग ब्रॅगिंग. बट प्लीज अंडरस्टँड की ह्या जो काय मी जो जर्नी सांगतोय याचा मेन उद्देश असा आहे की जे ज्युनियर डॉक्टर्स आहेत त्यांनी त्याच्यापासून काही प्रेरणा घ्यावी. अँड दे शुड चार्ट देअर लाईफ. अँड I will begin with the slides. कुठे आहे ते? इथे ठेवलं. हे ग्रीन का झाले? This is my peer group for last 40 years. Joglekar sir is here, and the green color has been given because सगळे आम्ही green आहोत. I am the youngest in the group, and I just completed 70 years 2 days back, and all this group has been giving me energy, and we are troubling all the wives. प्रत्येकाच्या घरी जाऊन आम्ही त्रास देतो दर महिन्याला. But we have been learning from each other, and this journey has been कलरचं काय बदला की किती दिवस ग्रीन ठेवणार? हा येस. हे ऍक्च्युली ते काही कोरोना युद्धामध्ये काय सत्कार एका डिनरला झाला त्यावेळी काही जणांना झाला होता त्यामुळे. सो दिस इज द ग्रुप. मी नेहमी सरस्वती देवतेचा भक्त होतो राईट फ्रॉम बिगिनिंग, आणि इतका भक्त होतो की मी 13 वर्ष GS मेडिकल मध्येच काढली, आणि इतका भक्त होतो त्याचं फळ म्हणून मला महालक्ष्मी मातेने कोल्हापूरला बोलवलं. This has been my punchline. This is my philosophy of life, that I have never worked alone. I have never done individual practice. All practice is along with the colleagues. All the colleagues who have been there with me have developed to a very great extent, and that is how we hope that we will remain at the top because of this. तुम्ही कधी जेव्हा सुरुवात करताना आपण MBBS MD MS झाल्यानंतर त्या ग्रॅज्युएटला विजन नसते. यू डोंट नो, यू जस्ट फॉलो. वडिलांची प्रॅक्टिस आहे तिकडे जाऊन चालू करा. कुठे मी इथे सोलापूरला आहे, कोल्हापूरला आहे, तिथे जाऊन एक दवाखाना चालू करा. तर मेडिकल प्रॅक्टिस म्हणजे काय, त्याच्यातून पुढे काय करायचंय, तुमच्या ॲबिलिटीज काय, तुम्हाला काय पुढे जायचंय ह्याचं विजन डेव्हलप करणे. ह्याच्यासाठी तुम्ही मित्र आणि टीचर्स कडून घेऊन यू मस्ट डेव्हलप क्लिअर विजन, अँड देन यू शुड टेक द डिसिजन्स. दिस इज गेटवे ऑफ इंडिया. दिस इज वेअर आय वॉज देअर फॉर 26 years. मी कोल्हापूरला कधीही नव्हतो, एकही दिवस नव्हतो. आणि या दरम्यान मी त्याच्या अगोदर ॲज अ स्कूलिंग आय वॉज डन इन अबाउट 8 schools इन व्हेरियस डिस्ट्रिक्ट्स इन महाराष्ट्र. म्हणजे जे 12 गावचं पाणी प्यायला अशी जी म्हण आहे ही काही अर्थी माझ्याबरोबर खरी आहे. आणि मग 9th onwards मात्र मी मुंबईत होतो. त्यानंतर आय वॉज अ mediocre स्टुडंट, पण आय कुड जस्ट क्लिअर द हर्डल. सो आय एंटर्ड GS मेडिकल कॉलेज, आणि तिथे खूप वर्ष मी 12 वर्ष मी तिथे काढली. इनफॅक्ट एवढे लॉंग स्टुडंट त्यावेळी DM आणि MCH नसल्यामुळे बहुतेक जण 6-8 वर्षात, 7 वर्षात, 8 वर्षात जायचे बाहेर. But I was there in the institute, GS Medical College, which instilled a lot of the principles of life in that institute. It is a great institute, and all my teachers who are there are largely responsible for change in my mindset of liking medicine. I was a backbencher. Backbencher म्हणजे मागे बसायचं, बाण मारायचे, फारसं अभ्यासाकडे लक्ष नाही. कसं पास व्हायचं.
करमत नाही मामा.
MBA झाल्यावर सगळेजण आमच्या वेळचे ECFMG म्हणजे एक्झाम होती ती प्रॉम्प्टली सगळे झाले. एक्झामिनेशन रिझल्ट 100% असायचे, 99% असायचे आणि वी आर नॉट बॅड, सो वी पास्ट. आणि त्यानंतर इमिग्रेशन व्हिसा घेतला होता मी. सो आय हॅड अ थर्ड प्रेफरन्स इमिग्रेशन. आणि तिथे अमेरिकेतला जे इंटर्नशिपची जे जॉब होता तो मिळालेला होता. आणि त्यावेळी मग माझे फॅमिली प्रेशर चालू झाली आणि फॅमिली म्हणाली की बाबा तूही जर अमेरिकेत गेलास तर मग इथे कोणी आम्हाला राहणार नाही. अँड दॅट चेंज माय डिसिजन ऑफ स्टेईंग इन इंडिया. Once that decision of staying in India was there were opportunities for me to start in Mumbai. कारण आमच्या मुंबई युनिव्हर्सिटी, आमच्या म्हणण्यापेक्षा मुंबई युनिव्हर्सिटीच्या पहिले जे 6 DM होते त्यामध्ये मी होतो. त्याच्या अगोदर कोणी DM आणि MCH करायला लोक कितूर सर आहेत तिथे त्यावेळीच केलेले. त्यावेळी असे लोक जायचे, एकतर त्यांच्या घरी प्रॉब्लेम आहेत काहीतरी, म्हणजे घरी जाऊन काय राहता येत नाही, आपलं कुठेतरी KM मध्येच राहायचंय, JJ ला राहायचंय, हॉस्टेल मिळत नाही, राहायला हॉस्टेल नाही, म्हणून मग DM ला रजिस्ट्रेशन घ्यायचं. माझं साधारणपणे तसंच झालं. DM मी काय माझ्या आवडीने घेतलं नाही, पण माय वाईफ वॉज डुईंग MD गायनॅक आणि त्या म्हणाल्या की इफ यू आर गोइंग फ्रॉम टू कोल्हापूर देन आय विल ऑल्सो हॅव टू गो लिव्ह दिस. सो आय DM कार्डिओलॉजी अँड दॅट इज माय ऍक्सिडेंटल कार्डिओलॉजिस्ट. The KM scene was very different. आम्ही तिथे कॅथलॅब मध्ये रोज सकाळी उठून कॅथलॅब मध्ये जायचो. तिथे कार्डियक सर्जरीज व्हायच्या, तिथे इन्व्हेसिव्ह ब्लड प्रेशर असायचं, व्हेंटिलेटर्स असायचे, ABG टेबल टॉप मॉडेल त्यावेळी ICU. आय एम टॉकिंग 1979, 1980. अँड देर आर लार्ज नंबर ऑफ रेसिडेंट्स. आणि तिथनं मी जेव्हा कोल्हापूरला यायचं एकदा बघून गेलो, कन्सलिंग रूम चालू करायची. That time I realized that there is a huge step down. सर ते टायमिंग मला जरा सांगा. पण तरी तुम्ही असा हात वर करा, मी थांबणार. कारण काय माहितीये का, हे SCCM ला सेम ओरेशन एकदा काही वर्षापूर्वी दिलं होतं मी. त्यावेळी म्हणाले यार किती सांगणार आहेस तू, तुझे एवढे इतकी वर्ष झाली, त्यानंतर आणि काही वर्ष ऍड झाली. सो कोल्हापूर सीन वॉज व्हेरी डिफरंट. मी इथे आल्याबरोबर आय वॉज शॉक्ड. हॉस्पिटल नहीं है इधर, ICU किधर है, और वो हॉस्पिटल में डॉक्टर नहीं है, फिर इन्फेक्ट रखेगा कैसा, नर्सेस नहीं है. नर्सेस बद्दल एक फनी स्टोरी इथे सांगितली जाते. हाऊ टू क्रिएट ए नर्स इन अ हॉस्पिटल, ह्याच्याबद्दल एक फनी स्टोरी मी जी ऐकायचो की टेक ए मिडल एज लेडी, तिला पांढरं पातळ गुंडाळायचं आणि तिला ड्युटीला चालू करायचं. अशा रीतीने इथे नर्सेस तयार होतात. सो एनिवे इट वॉज म्हणजे मला आठवतंय की मी प्रतिभाला घेऊन तिथल्या एका गार्डन मध्ये जाऊन पहिल्या महिन्यामध्ये आल्यानंतर मी अश्रू डाळले होते, रडलो होतो की आपण परत जाऊयात, आता इथे नाही काय करणार, काय करायचं, काय खिशात पैसे नाहीत. आय केम हिअर विथ सम 3000 रुपीज टोटल आमचं दोघांचं रेसिडेन्सी मधलं सेव्हिंग. फादर इज रिटायर्ड, करायचं काय. फायनली मग एक नॉर्मली हा पॅटर्न असतो की पोस्ट ग्रॅज्युएट झाल्यानंतर एक तर आपण काय करतो, नॉर्मल ट्रॅक, पैसे असले तर यू विल स्टार्ट सम नर्सिंग होम किंवा वडिलांचं असलं तर, किंवा मुंबईमध्ये वगैरे पुण्याला रुबीला जॉईन करा, यू विल जॉईन अ हॉस्पिटल. Third option, in towns like this, you start a consulting practice, later on small nursing home, you increase that nursing home size after some time. ह्याच्यामुळे पर्सनल नीड्स आर मेट. गाडी येते, घोडा येतो, सगळ्या मुलांच्या शिक्षणाची होते, मेंटली सगळी शांतता होते. आणि त्यामुळे अशा रीतीने बहुतेक 90% लोक ह्या ट्रॅकने जातात. प्रॉब्लेम माझा असा झाला ह्या ट्रॅकने जाण्याचा की मी कार्डिओलॉजी केलेलं आहे, त्याला कॅथलॅब लागते, त्याला नुसतं नर्सिंग होम नाही चालत, त्याला इमेजिंग लागतं, त्याला CT स्कॅन, MRI लागतात, त्याला कार्डियक सर्जन लागतो, त्याला GI एंडोस्कोपीज लागतो, त्याला नेफ्रोलॉजिस्ट लागतो, त्याशिवाय मी नाही ठेवू शकत काही. हे जेव्हा झालं त्यावेळी माझ्या मनामध्ये लख प्रकाश पडला की आय हॅव टू डू समथिंग डिफरंट. And this why people tell me why I did this. सगळ्यांचा प्रश्न. प्रॉबेबली दिस रिझन फॉर दिस फार महत्वाचा भाग नाही. बट मी कॅथलॅब करणार कधी? मी तिथे शिकलेलो आहे ते कधी कधी आणणार? ओपीडी चालू केली, त्या ओपीडी मध्ये बसायचं, त्यावेळी जरा बरा दिसायचो मी. आता केस वगैरे होते. ते आझाद चौकात काही लोकांना माहिती असेल, सिनियर लोकांना. हास्य माझं तसंच होतं त्यावेळी. माझ्याकडे मेडिकल इक्विपमेंट म्हणजे हे एक होतं बघा, त्याला 10,000 किंमत होती. ती बँक ऑफ इंडियाचं लोन घेतलं होतं, कारण माझ्याकडे 1,000 रुपये देऊन ते लोन घेतलं. प्रॉब्लेम ओपीडी चालू केल्यावर हा झाला. मी ज्या काही डॉक्टरांना भेटायला जायचो की अरे मी मला पेशंट पाठवावं, ते म्हणायचे काय तुमचं कुठे पाठवायचे? ते म्हणाले की नाही असंच हार्ट अटॅक, ब्लड प्रेशर, अमुक तमुक पाठवा. ते तर आम्ही जे फिजिशियन आहे त्यांच्याकडे पाठवतो, तुमच्याकडे काय पाठवायचं? मग तुमच्याकडे आम्ही काय पाठवू शकत? आणि लोकांना वाटलं मी डीएम केलंय म्हणजे डिप्लोमा इन मेडिसिन केलंय, त्यामुळे तो एक मोठा वांदा झाला. PPR मध्ये मेडिकल ऑफिसरला अप्लाय केलं, सावित्रीबाईला अप्लाय केलं. गव्हर्नमेंट मध्ये सांगितलं की यू आर ओव्हर क्वालिफाईड, मेडिकल ऑफिसर जॉब नाही मिळायचा. अशा रीतीने काही मला म्हणजे माझं पहिल्या 6 महिन्यातलं अर्निंग 600 रुपये असायचं आणि त्या ECG मशीनचा हप्ता 400 रुपये होता. अशा रीतीने ते प्रॉब्लेम झाला. त्या दरम्यान काही नंतर कार्डिओलॉजी म्हणून माहिती झाल्यावर काही एक्सपिरियन्सेस आले, काही ऍडमिशन्स मी करायचो. गंगा हॉस्पिटल म्हणून होतं, तिथे आहे ते अजूनही, आणि दुसरं लक्ष्मीपुरीत खराळ्याला, जिथे NY जोशी सर पण ऍडमिट करायचे. आणि तिथे मी एकदा पल्मोनी एम्बॉलिझम ऍडमिट केला होता. आणि तिथल्या आता सांगितलेल्या आयाबाईने फोन केला मला मोबाईलवर, काय नाडी काय लागत नाही सर, जाऊन पहिलं तो पेशंटवर द्यायचं. दुसरा एक एओटिक रिगरचा यंग मुलगा होता, 22 वर्षाचा. रंगपंचमीचा दिवस होता, रंगपंचमी मी तिथे घरात खेळत होतो. फोन आला की तो कोलॅप्स झालाय तिथे त्या खराळ्याला. हॉस्पिटलमध्ये मला जाताच आला नाही, कारण तिथे सगळा क्राऊड असतो, सगळा बाजार असतो. बाय द टाइम आय रीच द फेलो वॉज डेड. इथले एक मोठे प्रतिष्ठित शिंदे सरकार म्हणून जे होते त्यांना इन्फिरियर इन्फॅक्ट झाला. म्हणलं इथेच आहे, ICU ऍडमिट करूयात. त्या ICU सांगण्यात आलं की आम्ही सिरियस पेशंट घेत नाही. म्हणलं सिरियस पेशंट घेत नाही, मग काय घेता? ते म्हणाले ज्यांना ICU लागत नाही त्यांना घेतो आम्ही. त्यांना घेऊन मी आयसोप्रिनची बाटली हातात धरून ऍम्ब्युलन्स मधनं वानलेसला पोहोचलो. केळकर सर होते त्यावेळी तिथे. 81 ला नव्हतंच मला वाटतं, यू केम लेटर. तर तिथे पोहोचल्यानंतर 5 मिनिटं सी थॉमस सर होते. त्यांना ही अडे कार्डियक अरेस्ट, बट ही सर्वाइव्ड. मी विचार केला तर 5 मिनिटापूर्वी ॲम्ब्युलन्स झालं होतं तर ही वॉज डेड अँड यू आर ट्रूली अ मल्टीमिलियनर पर्सन. सो दिस गेव मी ऑल द क्लैरिटी ऑफ विजन कि इधर तो कुछ करना ही चाहिए, कुछ ऑप्शन नहीं है. एंड देन आई स्टार्टेड. दिस इज महालक्ष्मी हॉस्पिटल गव्हर्नमेंट. ते ऍक्च्युली इथे सुद्धा भाड्याने म्हणजे मी स्वतः घेण्याची शक्यता नव्हती, 0% होती. तर सरांनी मी म्हणून आम्ही चालू करणार होतो, पण ही बॅकड आउट आणि मग ते म्हणाले तू चालू कर. मग मी इथे चालू केलं आणि इथे आल्यानंतर साधारणपणे प्रायव्हेट लोन घ्यायला लागलं, कारण बँका लोन द्यायच्या नाहीत. प्रॉब्लेम हा असायचा. आणि आपण महाराष्ट्रीयन लोक आपण लोन घेत नाही सुद्धा लवकर. आणि त्यावेळी 4,000 रेंट होतं. त्यावेळी 4,000 रेंट म्हणजे सगळ्या आमच्या डॉक्टर्स लोकांनी हे केलं की भोपाळे मरणार, त्या लोन मध्येच मरून जाणार. कारण काय की साधारणपणे हॉस्पिटलची बिलं 400 रुपये 500 रुपये मॅक्सिमम असायचं. अजून म्हणजे लोक म्हणतात की क्रेडिट मला देतात की पहिलं 1,000चं बिल केलेला माणूस म्हणजे मी. पहिलं 1 लाखाचं बिल केलेला माणूस मी नाही, तर लोक आहेत. हे लेक्चर असंच असणार. माझ्या इनिशियल बोर्डवरची नावं मी सगळ्यांना आवर्जून सांगतो की इफ यू पुट युअर अशोक भोपाळियाज नेम or Dr. Patila's name, then you will not develop, no one else will come to you. So my initial board consisted of Dilip Kulkarni, Anant Kulkarni and Ashok Bhopal. So you must give credit to your colleagues more than what you take yourself. आता मला तो शिर्के सरांनी जी मी सांगितलं की ह्या खोलीत मी राहत होतो 17 वर्ष. 17 वर्ष राहत होतो. I did not take a holiday. I attended all the calls. मिरजचे सगळे MD झालेले लोक माझ्याकडे ड्युटीज करायला म्हणून यायचे. त्यांची लिस्ट मी दाखवतो. which has exceeded, number has exceeded 30 or 40 physicians now. आणि त्यांना खूप एक्सपिरियन्स मिळायचा. माझ्याकडे ऍडमिशन दर 4 तासाला एक इन्फाक्ट यायचं. मला रात्री जागरण करायला लागायचं आणि मी टेक्नॉलॉजी अशी एक डेव्हलप केली होती की मी बूट घालून बेडवर झोपायचं, चटकन जाता यायचं. त्यामुळे माझा जो कन्सल्टिंग रूम मधला फोटो आहे हा नाईट ड्रेस मधला फोटो आहे. मी नेहमी सगळं अटेंड करायचो नाईट ड्रेस मध्येच, संध्याकाळी 7 नंतर नाईट ड्रेस. म्हणजे तुम्हाला काय बदलायला लागत नाही, काय करायला लागत. हा कोल्हापूर मधला पहिला व्हेंटिलेटर. आणि असे लोक आहेतच, शिर्के सर आहेतच. मेडिसिन्स म्हणून इथे डेमो झालं मग आम्ही वापरायला लागलो. त्याने काही व्हायचं नाही, फक्त तो फुफ्फुसामध्ये हवा द्यायचा आणि काढायचा. तुम्ही फक्त फ्लो ऍडजस्ट करू शकायचा. बाकी त्याला प्रेशर किती आहे काय हे समजायचं नाही, पण अंदाजाने चेस्ट किती मूव होते याच्यावर मी ऍडजस्ट करायचो. बट इट कुड सेव्ह पेशंट्स. द प्रॉब्लेम इन महालक्ष्मी हॉस्पिटल, आता डायग्नोस्टिक सेंटर कशाला चालू केलं? लोक म्हणतात साला कार्डिओलॉजी तू CT और MR क्यों कर रहा है? त्याचं कारण असं आहे की संध्याकाळी 4 नंतर ब्लड शुगर व्हायची नाही कोल्हापूर. लॅब बंद, एक्सरे मशीन बंद. डायबिटिक किटोसिस मॅनेज कसं करायचं? लाईट सगळी जायची, जनरेटर नव्हता. माझ्याकडे पहिला UPS म्हणजे काय माहिती नव्हतं, पण पहिला UPS आमच्याकडे होता. त्या महालक्ष्मी हाऊसमध्ये डेली डेथ असायचा. सकाळी डेथ झाला की ती डेड बॉडी नेऊन आम्ही खाली ग्राउंड फ्लोअरला ठेवायचो. ते तिथे सेकंड लिफ्ट होतं कोल्हापूर मधलं. पहिलं लिफ्ट होतं ते कोल्हापूर शुगर मिलला, सेकंड होतं ते महालक्ष्मी हॉस्पिटल, दुसरं इथे सरस्वतीला होतं आणि तिसरं आमच्याकडे. ते बँकेचे जे लोक होते फर्स्ट फ्लोअरला ते सकाळी 10ला यायचे आणि ते डेड बॉडी खाली असायची. तर काही मेंबरने विचारलं, वर तुम्ही डॉक्टरांना ठेवलाय का? फार भारी डॉक्टर दिसतात म्हणाले, रोज येतो, काहीतरी असतेच इकडे. तुम्ही एक काम करा म्हणाले, यांना भिंत पाडून त्यांना बाजूला साईडचं एक गेट करून द्या. म्हणून हे साईडचं गेट केलं. मग तिकडे नेऊन ठेवायला लागलो. व्हेरी फनी इट वॉज. बट आय टेल यू, आय सर्वाइव्ड बिकॉज ऑफ मेनी एक्झॉटिक डायग्नोसिस. एक विक्रम हायस्कूलचे प्रिन्सिपल होते. काही थोडी नावं सांगतोय, कधी ऑड वाटेल, म्हणजे इंटेन्शन इज त्याला काहीतरी सजीव व्हावं. अनलेस आय टेल नेम इट विल नॉट, द इंटेन्शन इज नॉट. तर ते वडिलांचे मित्र होते. ते म्हणाले त्यांच्या मिसेस खूप आजारी आहेत, घरी उठतच नाहीयेत, 2 महिने झाले. तर अशोक आलाय तर येऊन बघेल का? मी गेलो तिथे, ते शिवाजी पार्क मध्ये सुरुवातीला आहे, आणि मी बघितलं आणि ते नाही फेस बघितल्यानंतर म्हणलं मिक्स इडिमा कोमा. ते त्यावेळेस आमचं डायग्नोस पद्धत होती, दिस इज दिस. थायरॉइड व्हायचं नाही हो गावात. थायरॉइड करून मग ते आल्यानंतर मग स्टिरॉइड आणि अल्ट्रासाउंड चालू केलं. आफ्टर 4 days शी बिकेम ऑल राईट. You can understand that he was a residency club member. He said, क्या अशोक है यार, साला 3 महीना सोया था वो चालू हो गया. संतोष प्रभू सरांचे वडील केपी प्रभू CPR हॉस्पिटलमध्ये सर्जन होते. एक दिवस माझ्याकडे आझाद चौकात दाखवायला आले. थोडस जरा हे वाटतंय रे, जरा ऍसिडिटी वाटते. ECG काढला, नॉर्मल आहे. मग मी डबल मास्टर्स टेस्ट केली. ती एक टेस्ट आता कोणाला माहिती नाही, पण त्यावेळी होती. म्हणजे असं नुसतं पायरी इकडनं तिकडे तिकडनं इकडे, आणि ECG काढला, त्याच्यामध्ये ट्रिपल वेसल डिसीज होता. दिस इयर इज 1981. 81 मध्ये बायपास सर्जरी इंडियात व्हायची नाही. तर मी त्यांना सांगितलं, पण मी डेंटन कुलीचं लेक्चर मुंबईला ऐकलं होतं. हिज 10 years एक्सपिरियन्स. ते म्हटलं, सर तुम्ही जर ह्युस्टनला गेलात तर यू विल बी ऑल राईट, यू आर हॅव्हिंग ट्रिपल वेसल डिसीज. He went there, underwent bypass, came back. When he came back, he was the president of surgical society here. And तिथे आल्यानंतर त्यांनी जे भाषण दिलं, that established me as a cardiologist. ते म्हणाले की I am saved because of a young man and his knowledge. And that is how. सावित्रीबाई फुलेमध्ये मॅडम तिथे आमच्या सुप्रिटेंडेंट होत्या. खूप स्ट्रिक्ट होते ते. मी घाबरायचो फार. सरांचं काय होतील मला समजू शकतो. कुठलेही पेशंट दाखवायचे मला. एक बेबी दाखवलं, कोल्ड क्लायमिंग होतं. मला शॉक मध्ये डोपामिन लावा. डोपामिन काय असते? नॉट अवेलेबल. मग मी मुंबईच्या व्हायला होत्या. मी ते साई तू भी मालूम नहीं है सब तेरे को, सुना है? एक डोपामिन भेज दिया, वो चालू किया, वो चाइल्ड वार्म हो गया. इट वॉज ए मायोकार्डाइटिस. आणि द चाइल्ड बिकेम ऑल राईट. डायरिया बिरिया हे झालं, सेप्सिस कंट्रोल झाला. तर त्यावेळी शिर्के सर होते मला वाटतं त्यावेळी. तर शिर्के सर कुठे? हा सॉरी. तर त्यानंतर मी सावित्रीबाईला आम्ही मीटिंग चालू केलं, क्लिनिकल मीटिंग चालू केलं. अरे डिस्कशन होना चाहिए, एज्युकेशन होना चाहिए. सो ऐसा होता था. हे 81ला चालू केलं, 83ला ते हे चालू केलं. 90ला मला वानलेसला बोलवलं, कन्सल्टंट कार्डिओलॉजिस्ट. एको आहे, होल्टर होता, डॉपलर होता. तिथे हिअर ॲट दिस स्टेज यू आर देअर. केळकर सर होते आणि सुबोध वॉज माय रेसिडेंट, सुबोध धनवडे. तर ते 50 केसेसचं लिस्ट घेऊन असायचे आणि सगळ्या केसेस मी बघायचं, असं हे त्याचं ते सर्जिकल आहे काय नाही, क्लिअर सर्जरी, एको करा, अमुक करा सर्जरी. त्यानंतर अँजिओग्राफीला एक माझे मित्र यायचे मुंबईवर, शनिवार ते करायचे, शुक्रवारी जायचे. सो देअर I was established as a cardiologist because everybody thought if Wanless Hospital can approve this man, man must be knowing some cardiology at least. त्यानंतर प्रॅक्टिस मध्ये मला मागे बघायला लागलं. इट वॉज देअर. इट इज लाईक प्रॉबेबली लाईक जोगळेकर सर किंवा देअर मेनी पीपल यु नो, त्यांना मागे बघायला लागलं नाही कधी. नेव्हर हॅव टू बॉदर वॉट इट इज बिकॉज इट वॉज एस्टॅब्लिश. आणि त्यावेळी काय होतं, सी देर वॉज नो कार्डिओलॉजिस्ट in Bangalore. So all Belgaum, this कोकण, इकडे विजापूर, एव्हरी आणि हिअर अप टू पुणे. म्हणजे मला हे इन्फॅक्ट झालाय म्हणून कोकणाचा फोन यायचा. त्यावेळी मोबाईल आणि हे फोन नव्हता. त्यावेळी मी जायचो कोकणात बघायला, मी बेळगावला जाऊन बघायचो. सो दॅट इज हाऊ आय थिंक माय इनिंग्स ऑफ कार्डिओलॉजी स्टार्टेड. दॅट इज अ पॉइंट. ह्या जे डायग्नोस्टिकचे जे प्रॉब्लेम्स होते त्यामुळे म्हणलं आता डायग्नोस्टिक काहीतरी चालू करायला पाहिजे. इथं NY जोशी सर माझे मित्र, दर आम्ही सावित्रीबाईला भेटायचो आणि चहा प्यायला जायचो. एक दिवस मला ही केम लाईक ए रनिंग लाईक ए चाइल्ड. ही सेड, अरे ते युनायटेड म्हणून कंपनी आहे, ती सिटी घालेल आपल्या शहरात. बोललं सर ठीक आहे. तर मग तो मी अल्टरनेटिव्ह मिरजला जातो, इतर दिवशी तू बघशील का तो आला तर. मग तो एक दिवस आला मॅनेजर. मग त्याला 3 दिवस मी हॅपी ठेवलं. रोज संध्याकाळी दुपारी परला घेऊन जायचो. तो सारखा बिअर प्यायचा दुपारी. मॅडम विल अंडरस्टँड माय व्हॉट आय डिड. सो आई ब्राइब्ड हिम. अरे साला कोल्हापुर है यार, क्या है तुम कितना मांगता है तुमको सिटी. तो म्हणाला 100 सिटी होना चाहिए. मैंने हाँ ठीक है दे देंगे. त्याआधी मी खिशातून काढून देणार होतो. मग त्या रीतीने युनायटेड डायग्नोस्टिसचं पहिलं सेंटर शिवाजी पार्कला आलं. तिथला जो रेडिओलॉजिस्ट जो आहे तो मी दिलेला आहे. कर्नाट सर त्यांना मी ट्रेनिंगला पाठवलं आणि नंतर आलं. पण द फर्स्ट सिटी स्कॅन इज क्रेडिटेड ब्रिंगिंग हिअर इज क्रेडिटेड टू जोशी सर अँड मी. त्यानंतर 89ला आम्ही सगळे जो आमचा ग्रुप झाला होता 8 जणांनी म्हणून आम्ही सी हिअर दिस इज द फर्स्ट टाइम आय लर्न द पॉवर ऑफ कमिंग टुगेदर. सो 8 पीपल केम टुगेदर. टॉप पीपल आर देअर त्याच्यामध्ये. आणि आम्ही मिळून हे घातलं आणि फर्स्ट प्रॉपर होल बॉडी सिटी स्कॅन वॉज इन्स्टॉल्ड in Shaupuri and we did a tremendous work. The cost of that scanner was 1 crore that time. You can understand in 89 1 crore गोळा करायचे आणि लोन म्हणजे वी हॅड टू टेक अ लोन फ्रॉम सीकॉम. आणि त्यानंतर मी 94ला असं लक्षात आलं की मला ग्रोथ आला मला करायची. म्हणून मी 94ला एक वेगळी ऍपल डायग्नोस्टिक म्हणून कंपनी काढली. इट्स कॉल्ड ॲज अ बर्थ ऑफ द ऍपल हॉस्पिटल्स. दिस इज इन 1994. ह्यावेळी मला लक्षात आलं की डॉक्टर्स वॉन्ट इट. तर म्हणून मी 50 डॉक्टर्सना भेटलो. स्वतः गेलो. भिक्षा मागायला गेल्यासारखं गेलो. म्हणलं सर पार्टिसिपेट करा. आय विल बी क्रिएटिंग समथिंग गुड. आपण इथे आणूयात अशा गोष्टी की ज्या इथे नाही आहेत. हे करण्या अगोदर मी सगळ्या कॉर्पोरेटना भेटलो होतो. शुगर मिलला भेटलो होतो. पण नोबडी वॉज. पण सगळ्या डॉक्टर्सनी 25,000 ते 50,000 1 लाख असे दिले. इनिशियल आयडिया वॉज डायग्नोस्टिक सेंटर आणि हाय टेक इक्विपमेंट वॉज द मेन थिंग. दिस वॉज द इनिशियल ऍपल इन बाउसिंगची रोड हे सगळं तुम्ही बघितलेलं आहे. अँड दिस वॉज द इनॉग्रेशन ऑफ दॅट. हिअर डॉक्टर कॅन सी द अवर ग्रेट मॅन अँड माय ग्रेट फ्रेंड. हा कोण आहे? हा मला दर 2-3 वर्ष झाले की अंगामध्ये एक मराठी भाषेत सांगतात तो किडा येतो. आता काहीतरी अभी बस हो गया ना यार, छोड़ ना, चल आगे. सो ऍक्च्युली नॉर्मली एक कन्सल्टंट वुड हॅव बीन हॅपी विथ महालक्ष्मी हॉस्पिटल. आहे 20-25 बेडचं हॉस्पिटल कशाला पाहिजे, काय चाललंय व्यवस्थित, सगळं तसंच करतात. म्हणलं नाही. त्यावेळी जाधव साहेब GM जाधव सर म्हणाले अरे तू माझं घेतोस का, तुझं आहे तुला उपयोग होईल. म्हणलं सर मी विचार करतो. आणि वी टूक दॅट. तर 98. आणि ह्या दरम्यान काय झालं, मी आय लर्न की मला पर्सनल काम करायला नको. खूप फिजिशियन माझ्याकडे येत होते, सगळेजण कामं करायची. आणि तिथे मी ठरवलं की फर्स्ट टाइम इन माय लाईफ इन 2004 आय विल हॅव कार्डियक कॅथ लॅब वेअर अँजिओग्राफी विल बी पॉसिबल इन दिस टाउन. हे त्या दरम्यान आपल्या मंत्री महोदयाने खानविलकर साहेबांनी CPR मध्ये चालू केलं. त्यानंतर विदिन 6 months वी स्टार्टेड दिस कॅथ लॅब देअर. आणि त्याच वेळी आम्ही कार्डियक सर्जरीची 2004ला स्टार्ट केलं. तर ह्या दरम्यान काय झालं, 2 संस्था झाल्या क्रिएट. एक ऍपल ही जी कंपनी आहे आणि दुसरा डॉक्टर भूपाळीची संस्था म्हणजे सरस्वती हॉस्पिटल. तर त्यामुळे त्याच्यातले जे मेनली हे जे आहेत तर ते कॉन्फ्लिक्ट कसे सोडवले ते मी सांगेन तुम्हाला. सो दिस वॉज अ सरस्वती हॉस्पिटल. आम्ही मग फर्स्ट फ्लोअरला नंतर कॅथ लॅब आणि कार्डियक सर्जरी हे तुम्ही सगळ्यांनी बघितले. आय डोंट वॉन्ट टू स्पेंड टू मच. सही प्रतिका मॅडम इज देअर, आहेत ना मॅडम? हां. सो ऑल दीज पीपल एनरिच माय लाईफ. ह्यूज नंबर ऑफ पीपल, व्हेरी ग्रेट पीपल. At least I am proud of them. I don't know whether they are proud of me, but it doesn't matter. असं आमचं ICU होतं, सेंट्रल हे होतं, पण प्रॉपर होतं, सगळं होतं, व्हेंटिलेटर होते. सो अशा रीतीने प्रॉपर ICU वॉज क्रिएटेड हिअर इन सरस्वती हॉस्पिटल. मला परत सल्लागार भेटत गेले, अरे भोपाली क्या कर रहा है, DNP ले लेना. मग अप्लाय केलं. मग पहिला DNP मेडिसिन कार्डिओलॉजी. डीएनबी कार्डिओलॉजी कुठेच नाही. डीएनबी आमचं कार्डियक सर्जरी आणि हे वर्क बघून डीएनबी कार्डिओलॉजीला जो इन्स्पेक्टर आला, ही वॉज मिलिटरीचा AFMCचा होता चीफ. अरे इतना छोटा जगह में आप इतना सर्जरी इतना कैटलैब कर रहे हैं. त्याने त्याच्या त्या सगळ्या सार्जंट लोकांना बोलवलं. अरे देख इधर के डॉक्टर साहब को देख, इतना छोटा इसमें इतना कर रहा है, तुम लोग क्या ये नहीं है वो नहीं करके मेरे को 10 कारण बोलताय. डॉक्टर मला त्यावेळी माहिती की नाव आय एम प्रूव्ह. आणि मग मला ते कार्डिओलॉजी मिळालं त्यावेळी. आपल्या इथला निषाद चिटणीस इज पास डीएनबी फ्रॉम अस. डीएनबी पिडियाट्रिकची स्टोरी मी नंतर सांगतो. अशा रीतीने एज्युकेशनल इन्स्टिट्यूट होत गेली. आज सुद्धा आय एम प्राऊड की एवढं एज्युकेशन ही सगळी लिगसी कंटिन्यू करणार. तर या सगळ्या डीएनबी सांगितलं. त्यानंतर IDCC फेलोशिप आहेत. साई सर इज फॅकल्टी ऑफ दॅट. आय कीप ऑन टेकिंग हेल्प ऑफ एव्हरीबडी इन द टॉम, whether they are with me or whether they are in other organizations. That has been my hallmark of my practice. And then we have MUHS च्या फेलोशिप्स आहेत 8 ब्रांचेस मध्ये. त्यापैकी सर्वात महत्वाची फेलोशिप म्हणजे कार्डियक एनेस्थेशिया. सो यू कॅन डू आफ्टर MD कार्डियक एनेस्थेशिया फेलोशिप. त्यानंतर DCH आहे, DMRE आहे. ही एक प्रेस्टिजियस फेलोशिप आहे NNF, नॅशनल निओनॅटॉलॉजी फोरम म्हणून. तर ही जवळजवळ कुठेही नसते. हे निओनॅटॉलॉजी मध्ये सर्वात इम्पॉर्टंट फेलोशिप इन द कंट्री इट इज. We have a nursing college. Our passing percentage was very high, and in CPR hospital, chairman of the ethical committee for last 15-20 years. This is some of the people who are there. Ha Nilesh ha pass झाला आता हे आलेला medical oncologist. She is a neurologist. His wife. कोण आहे? ही कुठे आहे? आई विराश्री. She is our first DNB. ही कोराणेसर's वाईफ. सो अशा रीतीने इथल्या कोल्हापूरच्या लोकांना याचा खूप उपयोग झाला ह्या डिग्रीचा आणि याचा. आणि याचा इम्पॉर्टन्स असा आहे की ऑल ओव्हर द कंट्री पीपल न्यू व्हॉट इज ॲपल हॉस्पिटल. दॅट वॉज अ नॅशनल मॅप मध्ये आपलं गेलं. कारण एनी स्टुडंट हु इज अप्लाइंग फॉर PG विल सर्च ऑल द इन्स्टिट्यूट वेअर इट इज अँड देन दे विल टेक ए इन्फॉर्मेशन ऑन दिस. हे डायग्नोस्टिकची जी वाटचाल आहे ती पण इंडिपेंडेंटली आणि खूप पॉवरफुल होत गेली. हा सिंगल स्लाइस CT हा आम्ही टाकला तो इतर ठिकाणी होता त्यावेळी, पण हा 1.5T जो टाकला तो इट वॉज युनिक. इट वॉज नॉट देअर इन गोवा, इट वॉज नॉट देअर इन KLE हॉस्पिटल अँड इट वॉज नॉट देअर इन पुणे. ग्रॅज्युअली सगळीकडे आले, आता सगळीकडे आहेत हा प्रश्न. पण त्या पहिल्या 2 वर्षामध्ये आम्ही जवळजवळ 1000-1200 MRI पर मंथ करायचो. रोज 30-35 MRI व्हायचे. त्यांना 2-2 दिवस त्यांना MRI साठी थांबायला लागायचं. त्याचप्रमाणे कॅथलॅबद्दल मी सांगितलं. द सेम थिंग स्टोरीज ऑफ 64 स्लाइस CT. हा इतर CT आणि 64 स्लाइस CT मधला फरक आहे की याच्यामध्ये CT अँजिओग्राफी होते. CT अँजिओग्राफी झाल्याने ब्रेन अँजिओ इज देअर. स्ट्रोक मध्ये, ऍब्डोमेन मध्ये जर तुम्हाला मेजेंट्रिक आर्टरी काही असलं तर त्याचं डायग्नोसिस होतं. So addition of 64 slice markedly changed the diagnostic skills for all faculties, surgeons especially. And हे जे 48 channel MRI आज मी बोलत नाही पण इट इज वन ऑफ द हायेस्ट एंड MRIs. त्यापैकी बरीचशी मशीन अशी आहेत ही त्या काळामध्ये कोणीही विकत घेऊ शकत नव्हतं. बिकॉज दे आर व्हेरी एक्सपेन्सिव्ह. ऑल टेक्नॉलॉजी वी बॉट. I will tell you why I bought those costly equipments. So this is our department's this thing. J.K. Patil hai. He was for a long time, 17 years he was there with us. And our present team. हा मुदलगी तिथे सांगलीला मोठं सेंटर आहे त्याचं. बाकी धनंजय गोंगडे पण आहे त्याच्यात नाही. प्रल्हाद yes JK this is Dhananjay. I am proud of all these photographs. I keep on seeing them. This is our 3T magnet. There are खूप स्पेशालिटीज आहेत त्याच्या, पण टुडे इज नॉट द डे टू टेल दॅट. हे रिडू केलेलं ॲपल हॉस्पिटल्स. This is a important slide for people. बहुतेक जे माणसं असतात की एका ग्रोथला गेले, बस झालं क्या करणे काय, रोज 2 सर्जरी करताय, रोज हे करताय, आयसीयू फुल होत आहे. दे स्टॉप बिकॉज पर्सनली एनर्जी लेवल पण स्टॉप होते. आणि मी ठरवलं की आय डोंट वॉन्ट टू फॉलो ऑन टिल दिस ग्राफ. द ग्राफ शुड कीप ऑन गोइंग अप अँड अप. This is a message for young people. Don't stop. ठीक आहे, तुमची BMW आली, मर्सिडीज आली, डोंट स्टॉप देअर. 2008 उघडलं, 81 चालू झालेलं. अभी काय करणे काय हो, तिथल्या सरस्वती मधल्या ह्यातल्या आम्हाला गोष्टी समजल्या. इथे काय करणार आता, आपल्याला न्यूरोनॅटॉलॉजी काढायचे, हे काढायचे. कालच जाधव सर भेटले होते मला, पिडियाट्रिक सर्जन तिथले, तिथे आपल्या संध्याकाळच्या मीटिंगला. अँड तसं संतोष पाटील म्हणून जो आपल्या इथला पिडियाट्रिक, तुला माहिती आहे की संतोष, तर त्याने तो म्हणाला सर न्यूरोनॉलॉजी काढूयात आपण. मी म्हणलं माणसं पहिला तर शोधतो, नंतर काढतो. मग त्याने ती माणसं आमच्याकडे जी दिली, दॅट वी स्टार्टेड दिस. आणि पहिल्यांदा आम्ही म्हटलं अशी जागा घेऊ की परत मला जागा बदलायला लागणार नाही. 5.5 एकर जागा घेतली आणि मी माझी प्रॅक्टिस बंद केली. माय एंटिटी ॲज ए अशोक भोपाली इज ओव्हर. आय एम ओनली शेअर होल्डर ऑफ ॲपल हॉस्पिटल अँड मॅनेजिंग डायरेक्टर अँड मर्ज माय हॉस्पिटल. 2017ला कॅन्सर चालू केलं. कॅन्सर का चालू केलं, एक I never started anything to compete with anybody because there was no need to compete. And I don't believe in there is anything like competition. Everyone goes up because of his own, or if he doesn't do well, it is because of his own, not because of others. तर कॅन्सरचं मला असं लक्षात आलं. आय वॉज व्हेरी क्लोज टू टाटा मेमोरियल हॉस्पिटल. आणि तिथले बरेच लोक, म्हणजे आता श्रीखंडे सर वगैरे माझे पर्सनल फ्रेंड आहेत. त्यांचे परवा एक रिलेटिव्हला आपलं चांदेलकर आहे ना, हा, त्याची एक कॉमन त्याची रिलेटिव्ह होती, ती आपल्याकडे कोविडने ऍडमिट पण होती. सो ऑल दिस पीपल, बडवे सर, आय वॉज व्हेरी क्लोज टू दिस कॅन्सर. आणि मला एक असं वाटायचं कॅन्सरचं हॉस्पिटल असायला पाहिजे. कॅन्सरची रेडिओलॉजी पाहिजे, कॅन्सरची पॅथॉलॉजी पाहिजे, ऑन्को हे पाहिजे तुम्हाला, म्हणजे पेट पाहिजे तुम्हाला, आयसीयू पाहिजेत मेनली, तुम्हाला फिजिशियन्स पाहिजेत, तुम्हाला मल्टिपल सर्जन्स पाहिजेत, तुम्हाला तुमच्याकडे मल्टिपल लिनॅक्स पाहिजेत. दॅट इज व्हॉट इज कॅन्सर हॉस्पिटल. सो दॅट इज हाऊ वी स्टार्टेड दिस. Same thing is about NICU. We started NICU, which is largest, one of the largest in Maharashtra and most technically advanced NICU. 700 grams जर बेबी वाचवायचं असलं तर there is only one place. The same thing is about next level of cardiology. Our cardiology, Dikshit sir has joined. Amrut is also a senior surgeon. कॅथ लॅब आहे. IOS-FFR सगळीकडे त्यावेळी नवीन होता, आता आहे सगळीकडे. माझ्या वाढदिवसाला 26 तारखेला, आज 28 आहे, बर्थडे 2 वर्ष झालीत, वळवायला लागलाय. लोकांनी आमच्या Azurion cath lab बुक केली. It's the world's most advanced cath lab.
Yeah. His father was judge, na?
It's so costly that no one can buy it, and no one should buy it.
Very famous. Brother is also. Brother presently is live.
If you want to buy it,
he was quite well.
Money.
वो बंगलो उधर है ना रहता है.
When you buy it through Beam STX,
क्या आ गई है ना सामने.
Please unmute your mobiles.
Which costs?
Please unmute.
Mute.
18 crores. That man is not concerned with the money. He is not looking at the income because he can do the same thing in 6 and 7 crores. So that has been my guiding principle. Cardiac OT. This is another technology which is not there here. And COVID times was utilized. He is a extracorporeal membrane oxygenator. When both the lungs are fired and cardiac surgery, pediatrics, neonatology, all these COVID, or both lungs are there. Before doing a lung transplant, you will require an ECMO. We treated one of the largest number of COVID patients during the pandemic. In private hospitals, that is probably number one. Only yesterday, I got a permission for heart transplantation. We hope that we will be doing a heart transplant and liver transplant this year. स्लाइड दाखवतो त्यावेळी लोक विचारतात हेलिकॉप्टरही घेतलं का म्हणलं अजून घेतलं नाही ज्यावेळी परत एकदा तो वळवळेल त्यावेळी बघतो. This is one of the partial teams of this my physicians. I am all proud of them. अंबडेकर, वागळे, आनंद कुलकर्णी, केळकर, बडवे, राठोड, परितेकर मॅडम, लाटकर, एस डी माने वगैरे वगैरे खूप लोक आहेत. राजेश पाटील, कपाले मॅडम, दिवसे मॅडम. These are our team now. हा व्यंकटेश आणि these are हे. ह्या अमोल DCH होता, तुला माहिती. मी म्हटलं तुला डीएनबी करायलाच पाहिजे. तो म्हणाला डीएनबी कुठे करणार, आता मी नाही जाऊन करणार. मी म्हटलं आपण डीएनबी घेऊ, म्हणून डीएनबी घेतलं त्याच्यासाठी. अँड ही इज अ स्टुडंट, अँड ही इज अ फॅकल्टी. सो विल बी अपिअरिंग नाव. रुपाली पाटील इज अवर nephrologist. Rohit. We have done a 28 kidney transplant, but the first modern transplant was done by us. And all these 28 were done in MJPJY Yojana. No patient is a paid patient. So all these things have been, we are the largest users of NJPJY, barring the CPR and medical college in the entire Maharashtra. This is our first pediatric kidney transplant. त्या डॉक्टरांचा मुलगा होता, शिंदे डॉक्टरांचा. मुख्यमंत्री म्हणाले येतो इथे. मला आश्चर्य वाटलं, का कसे येतील, कारण त्यांच्याकडे नागपूरला ट्रूबीम STX आहे. ते म्हणाले मला माहिती आहे काय ते मशीन, येतो. Cancer. This is that machine. It has got a CT scan, cone beam CT inbuilt in it. आता सगळे घेतील काय, हे नाही, त्यावेळेचा तो प्रश्न आहे. असं काही म्हणजे कुठली टेक्नॉलॉजी नंतर घेऊ शकत नाही अशातला भाग नाही. What this does, why this cost? This is a boy who had school going and he had a ruptured cerebral AV malformation. It cannot be dealt by surgery. It cannot be dealt by intervention radiology. And it can be cured only by stereotactic radiosurgery SRS, which is possible on this machine. So अशा तऱ्हेच्या केसेस महिन्यातून 3-4 येतात, पण त्यांच्यासाठी दुसरा कुठलाही ऑप्शन नसतो. त्यावेळी हा ऑप्शन तुम्हाला वापरायला लागतो. ते एक ब्रह्मास्त्र आहे, ब्रह्मास्त्र. इट इज टेक्नॉलॉजी, ऑल टेक्नॉलॉजी वी शुड यूज. आता इथे सरांनी रोबोटिक आणलेलं आहे. इट इज समथिंग आता नाही आहे, काले आपलं मायदेव सर बोलले. सो आय थिंक ऑल दिस टेक्नॉलॉजी वी विल हॅव टू एम्ब्रेस. असं नाही की आम्ही ते तसंच करत होतो, आम्ही 50 वर्ष, ते गेले दिवस. साई छोड़ के कोई डायग्नोसिस बोलेगा क्या है, साई और संदीप क्या किया है? This is it's called TAVR, percutaneous. The aortic valve is replaced. Normally aortic valve surgery is required. The patient is above 70. So nowadays through femoral route, you can go and put a valve, inflate it, and that is the end of the story. The cost of the valve today is 15 lakh rupees, 15 lakh. पण ठीक आहे, it is there, but that is heavy. म्हणजे मोठी ऑन्कॉलॉजी टीम आहे. can see this this lady. She's our latest. She has joined Yashashvi. She's our surgical oncologist. She's a chief onco surgeon today. So I liked that ladies are taking so much pathology. All our pathology is ladies. Shreya is here, I think. I saw her. Shreya? Girish आहे काय? कुठे? जरा असा ताट बस उभा हात. Girish is a very senior fellow. He's with me for a neurologist आहेत, physician आहेत, Agarwal, Kanire. ही आमची क्रिटिकल केअर टीम कंटिन्यूड. हे तिघ जण आहेत. So what we did, we're coming to end. First renal transplant, largest NICU. Exit procedure. तुला माहिती असेल exit procedure. So I will not detail, but it is one of the most exotic procedures done only some only 8 cases have been done in the country. 7 are there. Later on I will tell you. ECMO only with us. We do more than 60 open heart surgeries a month. 2 surgeons. This is larger than KLE hospital and larger than any hospital in Pune. Planning heart and lung transplant. MJPJ, I told you. Oncosurgeries, SRS, TAVI. TAVR म्हणजे ते जे केलं ते aortic valve ला aneurysm असला तर you can put a covered stent there. So that we did one. परत 2-3 वर्ष गेली. So we restarted this Medicity hospital. हे एक another 70 bedded hospital आहे. This was inaugurated by Dixit sir. I had lot of medical legal experience. मध्ये मी मला वाटतं KMAच हे घेतलं होतं, लेक्चर घेतलं होतं. I don't want to go into the details of that, but except that एकदा जे एक पेशंट हार्ट फेल्युअरचा जो मेला आणि त्यांनी क्रिमिनल केस केली आणि ती क्रिमिनल केस केल्यानंतर ते सगळं सेटलमेंट वगैरे हे होतं. म्हटलं बाबा मला काही करायचं नाहीये आणि काय असेल ते कर, कारण हार्ट फेल्युअरचे पेशंट माझ्याकडे मरणार तर मरणारच ना, दुसरं काय, म्हणजे त्यात चूक काहीच नाहीये, काय करणार. सो 3 years आय फेस्ड ए क्रिमिनल प्रोसिडिंग्स. आय यूज टू गो एव्हरी 2 weeks. आणि या क्रिमिनल केसमुळे माझ्यावरचा आनंद कुलकर्णी गाव सोडून प्रॅक्टिस सोडून पुण्याला गेला नाही. बट आय डिड नॉट लूज माय करेज टू प्रॅक्टिस. हे जे बाजूला जे चित्र आहे हे असंच एका व्हायलन्सचं काचा फोडल्याचं चित्र आहे. पण सगळेजण याच्यातून जातो, आपण सगळ्यांनी काळजी घ्यायची याच्यात. सो यू मस्ट कॉन्स्टंटली अपग्रेड. नॉलेज मस्ट बी अपग्रेडेड. तुम्ही एखादी गोष्ट पूर्वी करत होता त्याच्यात चेंज ती करायला पाहिजे. अँड आय टोल्ड यू पर्सनल प्रॅक्टिस वर्सेस असोसिएट्स. आय हॅव नो ओनरशिप कन्सेप्ट. आय डोंट थिंक दॅट आय ओन एनिथिंग. हे जे म्हणतात ना, ज्याला एक डिटॅचमेंट म्हणतात, ती प्रोग्रेस व्हायला तुम्हाला डिटॅच असायला लागते. हे माझं हॉस्पिटल असं मला कधीच वाटत नाही. हे मला असं वाटतं की हॉस्पिटल हे जनतेसाठी केलेलं हॉस्पिटल आहे. याचा जनतेला उपयोग आहे. मला काहीच उपयोग नाही आता त्याच्या इन्कमचा मला काही उपयोग नाही. इट इज जनरेटिंग ह्यूज अमाऊंट ऑफ मनी, बट इट इज ओनली ऑल द मनी यूज फॉर ओनली टेकिंग द टेक्नॉलॉजी फॉरवर्ड. डोंट बॉदर अबाउट ROI. ROI म्हणून सगळे लोक रिटर्न ऑन इन्वेस्टमेंट. 1 crore डाला तो कितना मिलेगा. मैं बोलता 1 crore डाले तो कुछ नहीं मिलेगा, तुम टैवी कर सकेगा. And respect Saraswati and Lakshmi will follow. And you must remain focused like Ronaldo. And see that the ball goes in the net. And you must jump higher than others. Height should be more. संपत आलाय की 2 ते फिलॉसॉफी स्लाइड्स. जब भी आया था तभी मैं अकेला ही चला था यार, मगर लोग साथ आते गए और कारवा बनता गया. And if you want to go far, there has to be a fire beneath. Without fire, you cannot go up. So develop that fire. त्याच्याबद्दल जोक पण आहे, तो मी सांगत नाही, पण फायर इज अ मस्ट. हा एक फार महत्वाचा ह्याच्यात मेसेज आहे ह्या सगळ्या डॉक्टरसाठी. अरे त्याच्यापेक्षा माझे पेशंट जास्त, माझ्यापेक्षा त्याचे जास्त, मला हे करायला पाहिजे, तो हे करतोय, तो हे करतो. तर प्रॅक्टिस जे आहे ना इज लाईक तलावातलं पाणी आहे. तुम्हाला फक्त एक ओंजळवर पाहिजे, तेवढंच घ्या, तुम्ही सॅटिस्फाईड राहा त्याच्यामुळे. आणि प्रत्येकाला इनफ पाणी आहे अवेलेबल. डोंट वरी अबाउट इट. डोंट बी ग्रीडी. सही. I don't want to talk anything on this slide. This is a train which is going, which is an institution. People come inside at every station, and people who have completed their journey get down. This is one of the old photographs. My current hospital staff strength is touching 1,000. 3 hospitals. Thank you. हे घेऊन आहे.
हो, हे आणि तुम्हाला हेच दिलेलं आहे.
हेच दिलेलं आहे.
यानंतर कोणाचंही शब्द आपण मनामध्ये ठेवून जायचे नाहीयेत. त्यामुळे फक्त 2च शब्दांमध्ये भोपाळी सरांचे जोगळेकर सरांचे आभार आपल्या कारवाने मानावेत, मी ही त्यांना विनंती करतो. भोपाळी सरांचे शब्द घेऊनच आपण या सभागृहातून बाहेर पडायचं.
हे आभार प्रदर्शन करण्याचं काम माझ्याजवळ सरांनी दिलंय, पण आता सरांचं ऐकून बोलायला शब्दच राहिलेले नाहीये. तरी हे काम मला कर्तव्य करायलाच पाहिजे. मी आज हा जो सरांचा प्रवास आपल्या सगळ्यांना अनुभवायला मिळाला, एक स्फूर्ती जी मिळाली सरांचं, तर मी आभार मानते की आम्हाला हे त्यांनी 4 शब्द त्यांच्या आयुष्याचे सांगितल्यामुळे आम्हालाही एक प्रेरणा मिळाली की आम्ही पुढे आयुष्यात असंच त्यांच्या सारखं होणार नाही, पण एक प्रयत्न तरी आम्ही जरूर करू आयुष्यात. आणि आज हे ऐकण्याची एक संधी मिळाली आम्हाला. ह्याचं क्रेडिट डॉक्टर अतुल जोगळेकर सरांना पण जातं. मी त्यांचे पण आभार मानते. मी माझ्या प्रेसिडेंट त्यांचे आभार मानते, माझ्या KMA एक्झिक्युटिव्ह सगळ्यांचा आभार मानते की आज इतक्या सुंदर ओरेशनच्या मध्ये आभार मानण्याचं मला आज एक शब्द नाही आहेत माझ्याजवळ. थँक्यू व्हेरी मच. थँक्यू.
Thank you, ma'am.
We are starting the next session immediately. Till the stage gets ready, just 2 minutes. As to Remax company again is going to just give you a 2 minute words of 2 minutes word of advice.
Before the lecture gets started, let me have a small announcement. On a parallel track, there will be poster presentation taking place downstairs. So the participants of the poster presentations are requested to make themselves available immediately. Our juries, Dr. Vasant Deshmukh and Dr. Kirokar sir is waiting downstairs.
One more thing, I will like everyone to know that we have around 250 online registrations, 300 physical registrations, and the link is open on YouTube, Facebook Live. We have around 5,000 visitors online digitally, which are out of which 4,500 are from India, and we have visitors from UK, USA as well. So that's a great achievement for Kolhapur Medical Association.
नमस्कार, मी स्मिता पाटील, डायरेक्टर ऑफ रिमॅक्स SSPL. आज इथे माझ्या कंपनीच्या वतीने WTC हा प्रोजेक्ट शोकेस करण्यासाठी आली आहे. रिमॅक्स 118 देशामध्ये आम्ही कार्यरत आहोत. रिअल इस्टेटच्या संबंधित कुठल्याही गोष्टी कन्सल्टिंगच्या असतील तिथे आम्ही कार्यरत आहोत. 118 देशांमध्ये आम्ही आमच्या सर्व्हिसेस प्रोव्हाइड करतो आणि WTC सोबत इथे भारतात आम्ही त्यांचे पार्टनर आहोत. इथे आम्ही त्यांचे काही प्रोडक्ट शोकेस करण्यासाठी आलेलो आहोत. आम्हाला जी इथे चान्स देण्यात आलेला आहे कोल्हापूर मेडिकल असोसिएशननी, त्यासाठी मी त्यांची शतशः आभारी आहे. आज तुमच्या सर्वांचे इथे मी आभार मानते की तुम्ही आम्हाला ही अपॉर्च्युनिटी दिली. तुमचं समाजकार्य आणि तुमच्या सगळ्या जीवनशैली पाहता, तुमचे समाजकार्य पाहता शतशः तुम्हाला नमन. तुम्ही कोविडच्या काळामध्ये पण ज्या प्रकारे सगळ्यांसाठी उभे राहिलात, सगळ्या डॉक्टर्सला शतशः नमन करते आणि तुमचे आभार मानते. बाहेर इथे इव्हेंटच्या बाहेर आमचे स्टॉल आहे. तुमच्या रिअल इस्टेट संबंधित कुठल्याही रिक्वायरमेंट असतील, WTC मध्ये तुम्हाला जर इन्व्हेस्टमेंटची अपॉर्च्युनिटी या इन कॅश करायची असेल, तुम्ही आम्हाला येऊन भेटू शकता. थँक्यू.
Yes, we'll be starting with our next session without wasting much of the time. Today's session will be on orthopedic lectures. The chairperson for the session will be Dr. Ravindra Shinde. May I invite Dr. Ravindra Shinde to be on the dais. He is an advisory member KMA, past president KMA, renowned senior pathologist. Requesting. Yes, you can sit here, sir. Yes.
आता काय तोडायचं? आता काय द्यायचं?
Okay. Till the stage gets arranged. Yes, it is arranged. I would like to request Dr. Suryakant Maskar, sir, to make himself available. He is a senior dentist. He has more emphasis on facial trauma and oral surgeon. 33 years of dental practice. Past president of IDA. next lecture, our lecture will be on how to evaluate shoulder pain, current advances in knee replacement. What is new? This lecture will be neither physical nor virtual. It will be a recorded lecture. We have the privilege of Sir to deliver his lecture today. I'm sure we'll have valuable pearls from his lecture. We'll wait for a short period of time before the lecture because we'll wait for the delegates to come in the hall. डिक्लेअर करू का मग ऑनलाईन आहे जाणार आहे जाणार आहे हो ठीक आहे
So we should have a proper clinical examination, and that is very important to have.
Dr. John T. John will be available for us virtually. He'll be online soon. I would like to request Dr. John T. John to be online. We'll be starting our lecture soon.
I'm already online.
After a short break.
I'm already
Requesting
online.
the delegates to be assembled in the hall at earliest so that we can have lunch in time.
Hello, I'm online. I'm there only. Yeah. Okay.
Poster presentation is started downstairs. We'll be starting the session soon. The stage arrangement is done. Requesting the chairperson to kindly be on the dais. I would like Dr. Ravindra Shinde and Dr. Suryakant Maskar to chair the session. I would like the chairperson to kindly introduce our speaker, Dr. John T. John. Requesting the delegates to kindly get assembled at earliest.
Hello. Good morning, everyone. I request all the delegates to please be seated, get inside the hall. We're starting the next session. It's my privilege to introduce orthopedic surgeon John T. John. He'll be talking on two subjects: how to evaluate shoulder pain and current advances in knee replacement, what is new. A brief introduction of the eminent speaker. He's done MBBS from Government Medical College, Kottayam. He has done his MS Ortho from Armed Forces Medical College, Pune. He has done MCH Ortho from University of Dundee, UK. His MRCS and FRCS from Royal College of Physicians and Surgeons of Glasgow, UK. He's consultant and head of the department at Lourdes Hospital, Kochi, Kerala from 2007. So I present to you Dr. John T. John. Sir, please.
We'll look at how to evaluate his shoulder pain. So shoulder pain is again a very common thing which comes to everyone, from physicians to general practitioners to rheumatologists to orthopedic surgeons to pediatricians to anyone. So let us see how we can go about it. Shoulder pain is one of the commonest complaints in clinical practice, and the unique anatomy of the shoulder and the range of motion gives it a diagnostic challenge. And proper clinical evaluation is key to diagnosis. So we should have a proper clinical examination, and that is very important to have a diagnosis. The shoulder joint, if you look at it, it consists of four joints. That is the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic articulation. The causes of shoulder pain can be inflammatory, can be due to instability, can be due to degenerative problems, or due to trauma, or it can be due to infections, neurogenic, referred pains from neck or from any other part, or from tumors which form a very small group. So you have to have a proper clinical history to be taken to rule out whether the shoulder pain is coming due to instability, or it is leading to stiffness. You have to probably ask whether it gives some locking history or a catching. The locking and catching is different. Locking means that the shoulder get locked in a particular moment. Catching means you get hold in between, but it can be further movements. Then whether there is a swelling. The red flag indicators are history of symptoms and signs which concerns are of mass or a swelling or a tumor. If the skin is red, if there is a fever, then think about infection. Loss of rotation and normal shape, that means unreduced dislocation, especially after a trauma or a mild, we have got a disabling acute pain in the neck, that is acute rotator cuff tear, a sensory or motor deficit tendency, neurological lesion. The complete physical examination is required: inspection, palpation, range of motion, strength, and you have to do all the provocative shoulder tests. These are the different tests you have to do. So a lot of tests are written because the shoulder is one joint which is surrounded by muscles. So you have to test all the muscles, and each muscle has got one or two tests. So you have to do each one of them to rule out if there is a problem. Then comes to the radiological thing. Radiological evaluation, you have to do an epiaxial and a lateral. Axial is to rule out whether there is any dislocations. Then you think about an ultrasound. Ultrasound is really good if you have a experienced ultrasoundologist, a musculoskeletal radiologist with you. If it is a dynamic investigation, you can have a dynamic study of your shoulder, and it is cheaper also, and you get immediately your result. So it is good for rotator cuff tears, tendinitis, bursitis to identify impingement, and for capsulitis, or generally we call it a frozen shoulder. The MRI is the gold standard for shoulder investigations. They are good for even for identifying the intra-articular part, which the ultrasound is deficient. So this is good for rotator cuff muscles, for the bones, the cartilage, acromioclavicular arch, the synovium, the labral pathology, and the soft tissue, especially the biceps tendon inside. So if you look at the acute shoulder pain, it can be mostly traumatic. It can be a clavicular fracture or a acromion fracture or a coracoid fracture, or most common is a proximal inverse fracture and a clavicular fracture. So these are the different things. And you have to look at the acromioclavicular joint and the sternoclavicular joint for any dislocations or separations. The glenohumeral dislocations can be the anterior, which is the most common, and the inferior and the posterior. Posterior dislocation, you should be especially think when you have got a seizure patient or somebody gets an electric shock. Here, the external rotation will be restricted. So you have to take an X-ray and you can do a close reduction under sedation, or you have to take it to this for a surgical reduction. Acromioclavicular joint sprain can be of 6 grades. It can come as a swelling, prominent SC joint. You have to take an AP X-ray and basically the diagnosis. So here, the 1 and 2 is definitely conservative. 3, you can think about conservative or a surgery depending upon the displacement. And 4 and 5 also definitely surgery. This is a small video which will show how to here you can see this is a piano sign where you are flexing. You can see the acromioclavicular joint moving. It is prominent. We do arthroscopic fixation of the acromioclavicular joint. We have got the patient in V-chair position, the shoulder arthroscopy being done, and this is the you are going underneath the coracoid, where you go in, clear the area, then you put a button there. So this is the continuation. Let me offer. This is the button which we are passing. Here we have got both the CM and the arthroscopic. The CM, that is the button. Here you can see that the button going in and another button. So you tighten it. So this is a thread which is leading. It is known as a tight rope, which is used. So we have got the button coming in. That will get locked underneath the coracoid and another one on the clavicle. So that's the button. You can see this button and it will get pulled down. See, that's the button getting locked underneath. So then you tighten from the top. And you can do, these are the small incisions for fixing an acromioclavicular joint. And you see under the CM and confirm you are properly reduced. The sternoclavicular joint sprain and separation, you can mostly it can be done by conservative, rarely requires surgery, and you have to take a 40-degree cathode tube to see that. You go and reduce it and give a stamp. Chronic shoulder pain, most commonly is inflammatory. It will be biceps tendonitis, that is the inflammation of the long end of the biceps. There will be pain and tenderness of the biceps. It can be associated with malignant and rotator cuff tear. Most of them can be managed with conservative management with analgesics, and also you have to have a methodological evaluation to find out any other cause of inflammation. If they are not responding to conservative pain, we can think about a doctor's steroid injection. Then also, if they are not responding, then we think about a surgical way by doing a tenotomy of the long bit of biceps, or you can do suturing of the biceps tendon like this, tenodesis. Impingement syndrome also can be again can be due to a curved or a hooked acromion or a spur on the joint or a thickened coracoacromial ligament. It can be primary or secondary, and most of them can be managed conservatively. Sometimes, if they are not responding to steroid injection or a subacromial decompression and arthroscopic surgery can be relieved. Coming to adhesive capsulitis or a frozen shoulder, this is thickening and contraction of the capsule. Then again, same thing, it can to be managed initially conservatively by physiotherapy and analgesics. If they are not responding, then you have to think about a surgical arthroscopic capsular release. Should be instability. The recurrent shoulder dislocation, you have to do your range test. Classical treatment is a contact repair. The inferior, this is a glenoid labrum. The inferior, anteroinferior glenoid labrum tear is known as a contact lesion, and that is repaired. So here basically what in shoulder surgeries we use is an angle. This is an old video. We are using a metal angle now. We don't use metal angles, mostly we use a biabsorpal angle or a all switcher angle. The thread is only there. To put this angle, then stitch the labrum back. Degenerative causes, what is it, more than, usually seen in more than 40 years. You can see is pain, if you think is calcific tendonitis or a superior migration of the infrared is seen. You can do an ultrasound MRI to confirm your diagnosis. This is, you can see the rotator cuff which is torn. This is a faster lesion, a small lesion. That is the footprint, that is a greater tuberosity. Here again, this is an all switcher anchor we are going to put. Here there is no metal end. So here we are drilling, then the anchor is put, the newer anchor. So it doesn't have any metal, you can see. This is the anchor goes in, and that is the thread. So this is a newer type of anchor where the metal is not like this today. But and we have got this kind of special instruments which is passed to do the cuff repair, and the rotator cuff is passed on the other side and it is tied. So that is how it is done. This is another video where you can see this is the subscapularis muscle, that is the posterior labrum. It's got a larger tear. You have got not like a smaller tear. Here the subacromial space, you are clearing the greater tuberosity. That is a bigger tear. You can see that is a rotator cuff which is torn. Both the supraspinatus and the infraspinatus is torn here. It's a large tear. You can see the rotator cuff lying on the other side. Here you are not like glenohumeral, you are subacromial. You clear all the subacromial tissue. And this is again an all switcher anchor which is put on the medial side. And this is the rotator cuff. You can see that's a larger thing. You are passing the threads. What special devices for passing these threads? You are passing the threads. You usually pass 8 threads on the side, and then see that is passing. Then you see this is the 8 threads. Then you tie the threads, and the rotator cuff is pulled, and it is covering the cuff. Then you put one more anchor on the lateral aspects of the GT to make it a double row repair. Glenohumeral arthritis of the humeral head and the glenoid is again very common. It leads to passive loss of motion and stiffness. And initially, definitely, it is a conservative treatment. And if they are not responding, if you have got different, this is a shoulder resurfacing. This is when you are putting a cap over the head which is damaged. Here, this surgery is done only when the rotator cuff muscles are intact. Hemiarthroplasty is another when there is a total shoulder, when there is a more damage of the glenoid also is done, and you have got the rotator cuff is intact. And if you have got a rotator cuff also gone, then you have to think about a removed shoulder replacement. I think I'm really happy to take any questions regarding both of my talks. And I once again thank the Indian Medical Association for that good chapter for inviting me. Thank you.
Thank you, sir. Thank you for making yourself available for the live lecture.
Thank you.
And highlighting on common problems facing many of us. Now, so we can't felicitate you physically, but by heart we would like to felicitate. Oh, any questions? Yeah. Any questions from the floor? Okay. Thank you. Thank you. Yeah. So we'll move on. Thank you, sir.
Thank you.
Yeah. We'll move on to the next lecture by Dr. Deepak Joshi. He'll be speaking on sport injuries around the knee and spine surgery simplified.
I think he is going to continue on his next topic, current advances in knee replacement and what is new. Yes, sir. Please, you may carry on your next topic.
Yeah. Can you please play that also? Is there?
We can't hear you, sir. Just some technical issues.
Please load the other presentation also.
Yeah.
Can you load the other presentation also? Yeah. Can you load the other presentation also? I think.
They're doing it, sir.
Yes.
Now we'll look at how to evaluate his shoulder pain. So shoulder pain is again a very common thing which comes to everyone, from physicians to look at
second topic है दीपक second topic है
Yes.
Good afternoon, everyone. I'm Dr. John from Cochin. First of all, I would like to thank Kolhapur Medical Association and my good friend Dr. Deepak Joshi for inviting me for this wonderful conference. So my topic first is newer advances in total knee replacement. As most of you know, total knee arthroplasty is one of the biggest success stories of modern day surgery. And most common indication is osteoarthritis of the knee. Other causes can be multifactorial. Another one thing we commonly notice is those who are really obese or overweight, they are more prone for knee pain, arthritis, and knee replacement. Nowadays, if you look at, especially like in Kerala, during our pre-independence time, the life expectancy was for a male was 47 years, and for a female was 54. That in Kerala it has increased to 84 for a female and for a male 73. So people are living longer, and so they are coming with all these all aging problems. And one thing what we notice is that even though this total knee replacement is a high success story, but the expectation of many patients are very high. Even if they are 75 or 80, they want to be like an 18-year-old. That is not possible. You have to be realistic. Otherwise, what the literature says is that the patient expectation and surgeon expectations are different. And the PRM scores for knee replacement is only up to 80%. So nearly those who are happy after a knee replacement is only 80% of the people. So we have to give a good pre-operative counseling to the patient, make them understand about the surgery and the post-operative programs and how they will do after the surgery. Then the expectation of the patient will be realistic. And another thing is that from the time has changed, and the people who are in the 6th and the 7th and the 8th decade even wants to have a normal lifestyle. Most of their children are abroad and are not living with them. So they have to do all their activities by themselves. So they have to be up and about and has to get things done by themselves. So that is one reason of increasing number of knee replacement at this stage in our country. So if you look at the pathophysiology of arthritis, we know that it's the arthritis which to start with, it's a dynamic and metabolically active disease. First, it affects the soft tissue, the component, the synovium, then the bone, then the cartilage, then the bone and the joint, and the muscles and the ligament. So the key feature what we see is in the cartilage. And slowly, but the cartilage gets damaged, it will get later, get transferred into the bone, and you can see subchondral system and stuff like this. This is the cartilage damage. You can see the first picture. You can see this is the normal cartilage. You can see some kind of fibrillation like in this one. So slowly this cartilage gets damaged more. And here you can see the cartilage is worn out and the bone is exposed. And you can see all the meniscal tears, degenerative tears coming. So once the bone is exposed, you have to think about some kind of an intervention there. So in osteoarthritis, the WAOS, that's American Academy for Orthopedic Surgery, they recommend that if you go through the treatment, you can see that NSAIDs have got a good role. Weight loss has got moderate response. The exercise and physical therapy definitely shows a strong evidence that it will respond. Bracing is equivocal. Bracing is another very common trend which comes coming in. Then comes corticosteroids, it's inconclusive. Viscoelastic injections is not recommended. Arthroscopic debridement is strongly against it, because if you don't have a mechanical alignment to be corrected, it is better to avoid arthroscopic surgery because it is only short-lived. Then comes correction of alignment by high-degree osteotomy, or when there is a unique compartment knee replacement or a rotor joint arthroplasty at the end stage when you are not responding to any of this. So if you look at the conventional knee replacement, the survival is around 95% at 10 years and 83% at 20 years. So most of the surgeons nowadays, when patient asks you about the survival is, they say about 20 years. But 20 years, you understand that the literature says only 70% of them goes for a revision, and 83% of them survives. So if you look at the conventional knee replacement, the surgeon makes his precise cut with the help of cutting blocks, remove the diseased cartilage, and the cap is replaced by a prosthesis. And the conventional knee replacement in the hands of a good surgeon is a responsible, a reproducible and consistent. So it is, if the surgeon is trained well, he has been doing surgeries frequently, the results are consistent. So like that's about the conventional replacement. So what is knee replacement? Knee replacement basically you are it is just taking out the worn out cartilage and the damaged bone area, and it is basically a femoral component which is a metal thing and a tibial component, and in between you put a plastic tibial insert that is made of polyurethane. That is a knee replacement. So what is new in this particular thing, the knee replacement? One is what we understand, the people are more worried about the pain. That is, they are worried about the pain after the surgery because of all this newer pain management thing. Then another thing, earlier the problem was a lot of blood loss was there because you are cutting the bone, then you are, has fixed the knee replacement rate very constant. You cannot charge anything different for any of these models. And whether you are doing a PSC, that is where the cruciate ligaments and even posterior cruciate ligaments have been removed, or where the posterior cruciate ligament has been retained, or a gender specific or poly, whatever it is, the difference. And gold-plated knees are only actually indicated for those who are allergic to metal. Like some people complain of some allergy while they are wearing the stainless steel. The newer thing, another thing is a patient-specific cutting cloths. You take a CT scan of the knee, send it to the company, and they will make specific changes. One advantage is that this in rural setups where they cannot ship all the instrumentation, and then another thing is that autoclaving issues of putting bigger boxes is there. You can have this gender specific, this patient specific implants. It helps to reduce the overtime requirements. That's if you look at the literature. Otherwise, it's actually expensive, around 20-25. Otherwise, it is not recommended. Uncemented knee replacement, which is not available in India, it is coming up. An incision less than 10 centimeter, you call it as a minimally replacement. There is no arthroscopic or a keyhole type of knee replacement available. You should have otherwise a 4-fold upperland like kind of an implant. So you put a switch and it should blow out. There is no implant like that. So in knee replacement, I would say that you should have an adequate incision for that patient. You think about a 130 kilo patient with a huge thing, and you're trying to do a surgery with minimally invasive or a normal incision. So incision doesn't matter. All poly knee replacement, which is there in the market, it is cost-wise it is less. Again, it should be done for knees with good bone stock. Otherwise, metal back will be any part of the surgery, but they assist in positioning the surgery with instruments. The jigs are positioned with the help of navigation. So that gives you to give a dynamic assessment of the deformity compared to the conventional ones. And flexion extension gap can be properly balanced. And we can have an accurate analysis of the mechanical axis. The blood loss is less. Different robot, you have got a robotic arm that will help to do the, they do the milling and surgery. But if you generally look at all the conventional and this one, so disadvantages of all these newer things is prolonged operating time. It definitely requires a learning curve, is there significant cost implication for purchase and maintenance of the system. So if you are planning for a robotic system, you have to invest around 6 lakhs to 6 crores to 12 crores. And the disposable there, that is for the maintenance of the system for each surgery is around 30,000 to 40,000. You cannot do it if you are doing it correctly. And there is lack of adequate evidence of long-term benefits of computer-assisted surgeries over conventional implants in terms of compliance, survivorship, or patient benefit. So, and it is again dependent on how you are marketing. It's again surgery. So if you look at the Journal of Arthroplasty, this is the latest one. If we can say, robotics in hip and knee arthroplasty a real invention, or is it a marketing thing? So the final judgment you say is that these are not required for high volume surgeons, and it is basically required for long volume surgeons. The problem what they have written is wonderfully and beautifully they have written. Here they say paradoxically, those high volume surgeons can afford it. Those who high volume only can afford these robots because it's very costly. They don't need it. They are good with it, and that gives a good result. The low volume surgeons actually need it. Those who are doing less than 5 months a month, they need this kind of gadgets, but they cannot afford it. If you think, if you are a well-trained surgeon and has shown the test of time, that gives 83% success in 20 years. That is only 17% has got a problem in 20 years. That's a very good result. And a lot of newer and fancy techniques and implants have been developed. None of these different kinds of newer implants which have come, the processes, none of them have shown any major advantage. Some people say this high flexion, CR, mold water, all this stuff, rotating, non-rotating, all this stuff. There is no much difference. So all this gives a similar result. Robotic are exciting new field, and a lot of studies and research are yet to happen before they should be widely accepted. Especially in a country like ours, where a lot of things are dependent upon patients are paying from their pocket. You should, whenever you are doing a surgery, should think about the cost factor and its implication onto the patient and patient benefit. So at present, if you look at it, it is horrendously expensive. The robotics are on the developmental stage. This, I will say, it is still in the Mark 1 stage of an ambassador car. You have to have till the Mark 4 to come, and then it to vanish and to have newer things to come. So robotics are actually on coming up something which is newer thing that is evolved, that is not. So if you want to trust somebody who is doing good number of needs and he is paid very well, his hands is better than computer or robotics. Thank you.
Thank you, sir. Thank you, sir. Thank you very much for your nice lecture. In upper body, you have covered shoulder joint. Lower body, you have covered knee joint. You have truly nailed the troubleshooting joints of a body. Due to the time constraint, we will not be having the question answer session, sir. We'll go to the next lecture. Thank you very much, sir, for being with us online. May I request a chairperson to introduce our next lecture speaker, Dr. Deepak Joshi.
Hello. Next speaker is Dr. Deepak Joshi. He has done DORT after his DNB. After that, he has done fellowship from Tel Aviv University, Israel, and fellowship in endoscopic spine surgery from Bordeaux, France. He is currently the Chief Managing Director of North Super Specialty Hospital, Kolhapur, North Star Hospital. His topic is spine surgery simplified. Deepak, please.
Good afternoon. We are already running behind time, so I will start immediately. Today's topic is spine surgery simplified. Actually, we all know that since long time, general public as well as we consultants are afraid of spine surgery because spine ची सर्जरी केली की माणूस बाद होते. हे एक सगळ्यांच्या डोक्यात घट्ट बसलेला आहे. And that spine surgery is complicated. So most of the times we try to avoid spine surgeries, and there is a technique which is evolving nowadays, that is minimally spine surgery technique or MIS surgery. And with this technique, I feel that more and more people are coming up with the spine surgery because they feel that now the spine surgery is tolerable. So let's go with this topic. So traditionally, the spine surgery is done as an open surgery in which there are long incisions, around 5 to 6 inches long incisions. And with these long incisions, you have to retract the muscles, and with retraction, you will be able to see the spinous processes and the lamina, etc. And then you remove the diseased part by doing the laminectomy and retracting a lot of muscles. And major drawbacks for open surgery is there is a lot of retraction and pulling of the muscles that can damage both muscles as well as surrounding soft tissue, which is normal. And then there is a muscle injury due to which pain occurs severe after the surgery. There is a lengthier recovery period. Blood loss is more because of lot of dissection and lot of retraction. And because of increased blood loss and hematoma occurring, infection rate is higher with the spine surgery, open spine surgery. You all know the surgical strike in which you go directly to the enemy's house and take him off. So similarly, and this is a carpet bombing. That means you bomb the whole area to destroy the specific target. However, this is, we can call it as an open spine surgery, and a precision bombing is like a endoscopic spine surgery or minimal invasive spine surgery, in which you pinpoint the exact pathology and go there. It is possible because of better understanding of anatomy, advances in imaging technique like digital X-rays, C-arm intensifiers, navigation technique, as well as CTs and MRI. There are better equipments available nowadays, including microscopes, then camera, illumination, all are advanced. And of course, anesthesia is quite good, and anesthesia machines, ventilators are available. So patients can be ventilated safely and treated safely. So most important here is the precise pinpoint diagnosis. If you know where the culprit is, all you have to do is use good instruments, cameras and all, and attack that area rather than going for all the retraction. So minimal spine surgery, invasive spine surgery has a less injury to the muscles and less injury to the normal structures. Usually this is a big incision in normal spine and you have to remove all the spinous process, then interspinous ligament and laminae. This all can be avoided with spine short incisions, and you can see only the exact location where the problem exists. So the incisions are small, bleeding is less, there are shorter stays in the hospital. Because bleeding is less, dissection is less, infection chances are very less. And even sometimes a major procedures like fusion surgeries can be avoided in some high-risk groups. And in these cases, you can use the MIS surgery. So the key to MIS is the smaller incisions, muscle splitting rather than muscle cutting, and most importantly, fluoroscoping guided navigation. This is very important because you are just attacking the area, so you should know where you are going. Otherwise, you may miss the level and the surgery can go wrong. The scope of this talk today is microlumbar discectomy, spinal canal stenosis, percutaneous screw fixations, vertebroplasty, and nerve root injections. Let's go one by one. And these are the different tools that can be used for minimally spine surgery, mainly starting from the needle, laser, percutaneous through the arthroscope, a small diameter arthroscope, endoscopes with cameras, tubular retractors like this, expandable tubes, and even mini open surgery with the help of microscope. So this is the whole scope of the minimally invasive spine surgery. Let's go for the microlumbar discectomy, which is the most commonest procedure that is performed. So indications is either a single level disc herniation or even a double level disc herniation, which are adjacent. Most common anesthesia that is preferred is GA, but nowadays with this COVID times, we have started giving the spinal anesthesia for spine surgeries, so that the patient is safe and general anesthesia risks are not there. So in microlumbar discectomy, what we do is we go through the interspinal posterior approach, interspinous interlaminar space, remove some lamina here, remove some lamina here, and then you open the ligamentum flavum and you directly reach to the nerve roots and dura. So that is the posterior approach, which is most commonly used. And for this, most important is illumination, good light, and good magnification. And that is achieved with endoscopes, microscopes or a loop. So this is a retractable tube and this is a Dustando type of endoscope. I will show you some small video here in which this is the L5S1 disc which is protruded on the left side. This is the patient position, prone, and approach is posterior. You can use microscope or tubular retractor. These are the special instruments. You have to exactly locate the position with the help of C-arm image intensifier. Mark the incision. The incision will be somewhere around 1 inch at the max. The 20 mm is the maximum tube retractor you can put in. These are the various dilators available. You fix the dilator on the exact spot where the pathology is and just keep on dilating the muscles over the tubes. So there is no cutting of the muscle, only splitting of the muscle is there. And once it is done, then you fix the largest tube possible or required, that is around 20 mm. And then you can use a microscope. Here you can see that this is the lamina, this is ligamentum flavum, this is head end and this is leg end, and this is medial and this is lateral. So this is the lamina. You cut the lamina with the help of burr. Then you can see here is a ligamentum flavum. You take off the ligamentum flavum with the Carrison punch. Now here what you see is a dura here and nerve root here. You retract the nerve root with the hook, and just below the nerve root, you can find that there is a disc which is compressing this nerve root here. You need a good suction, good light, illumination, and then you tease out the disc here and remove this disc fragment with the help of disc forceps. This is a procedure done with the tubular retractor and the loop microscopes. You can do the similar procedure with tubular endoscope, with the endoscopic assisted surgery. So this is endoscope, this is the retractor, and this is the disc which is coming out. The root is here. So that's the disc you can take off. This is the incision. So this is the disc. You can find some other fragments also along with the major fragment. So there is another fragment which you can remove through this scope. So that is how the endoscopic discectomy can be done. Now you see that this is a nerve root which is quite free. The discectomy has been done and the nerve root is totally free now. This is the incision around 1 inches, and this is the amount of disc material you can take off from the surgery. What else can we do with these retractors? You can use, put some screws, pedicular screws, as well as you can fuse the spine. And in spinal canal stenosis, from the same approach, single level approach, you can go to the opposite side and decompress the spine bilaterally. So this is possible with endoscope. So microlumbar discectomy advantages is same day mobilization and discharge within 24 to 72 hours. There is another way of doing this type of surgery, which is a day procedure, and in which percutaneous endoscopic discectomy it is called. Small diameter scope is placed, and through this scope, you tease out the disc material and take off the disc. So this is a procedure which can even be done under local anesthesia. However, the patients that come to us don't come so early. We get the patients with a lot of big disc bulge and all. So this is the smallest incision and patient can go home the same day. Next, percutaneous pedicle screw fixations can be done through MIS approach, and indications are unstable fractures without neurodeficit. For example, a male patient with normal neurology, hemodynamically is stable. This is a L2 fracture, CT scan, MRI scan. So again, dilator tubes are used, and through in conventional spine, we would have incised so much and then retracted the muscle and they found the pedicle and then fix it. But with this, 4 holes are made and percutaneously guide wires are placed through the pedicles by C-arm image intensifier. And this is how the picture looks like. And then you fix the screw percutaneously. These are the long screws. You fix the screw percutaneously over the guide wire. and then you cut these screws from the base down. There is a system here, and then you pass the rod percutaneously from the skin down into the spine here, and you can fix the spine without opening the whole thing. So these are the 4 incisions, small incisions through which you can do this procedure. That's the post-op image. These are the scars 4 months post-operatively. So newer techniques for minimally invasive spine surgery continue to evolve still. And today we are using it for discectomies, canal stenosis, spinal fusions, fixations for fractures, infection, as well as tumor and biopsies. Another procedure which is commonly done in osteoporotic fractures is vertebroplasty or kyphoplasty, in which a 63-year-old male with a fracture here, and he was painful for last 3 months after fall. And so this was done with percutaneous needle, followed by injecting a cement here. And by injecting the cement, the pain was gone and patient was totally pain-free. Another procedures what you can do for unfit patients or those who don't want surgeries or who are not willing for surgeries is the facet joint injections or nerve root injections. They can be done again through the C-arm image intensifier navigation, and you can place the small needle at the nerve root on the nerve root, and you can inject steroid here or some anesthetic agent can be injected here, including the facet joint. What are the complications? Of course, there are complications. The way open surgery has complications, same complications do occur in minimally invasive spine. There is a steep learning curve. This is very important. You have to learn it well. Otherwise, at that time, the complication rate is higher. So the complications are infection, bleeding, pain, recurrent symptoms, pseudoarthrosis, and nerve damage. But they are very rare once you know how to do it well. Recovery for the minimally invasive spine surgery, the hospital stay is shorter, maybe 1 or 3 days. Post-operative pain is lesser as compared to traditional open surgeries. And to regain the strength and speedy recovery, physical therapy is very important. To conclude, in recent year, there is a lot of interest towards minimally invasive spine surgical procedures from patient's point of view as well as surgeon's point of view. And there are significant advancements in imaging, navigation, as well as equipments and implants. And MISS is very feasible surgery, which is very effective, safe, and value added as compared to the traditional approach as demonstrated by current literature. So in future, we anticipate continued innovation of technology and developing new surgical techniques to expand the indications of the MISS. More and more surgeons will keep on doing MISS in future, and that will benefit the patient because the risk of surgery or risk of open spine surgery will be less. Thank you very much.
Thank you, sir.
I think you have a second topic also, that is sports injuries around the knee.
Yes. This it's चालू. Okay. This you must have seen during Rio Olympics. This is India's Vinesh Phogat. And look at her injury here. She is in pain. She could not fight anymore. She lost her medal. Look at the knee, crushed. This is a very common example in kushtis and football, soccer, rugby. And Phogat was disqualified after that. And again, she got operated. And next Commonwealth Games, she again went in and she had won the medal. So knee is the largest joint in the human body, and most common injuries occurring in knee are fractures, dislocations, then followed by sprains and tears of the soft tissue. These are the ligaments. This is anterior cruciate, posteriorly is the posterior cruciate, then lateral collateral and medial collateral. They are the main structures therefore composing the stability of the knee joint. However, in sports, most of the injuries are soft tissue injuries, and 41% of the knee injuries are ACL injuries, followed by meniscal tears, then posterior cruciate ligament, articular cartilage damage, and lastly, avulsion of the ligaments. Can we prevent the knee injuries? Yes, there is a study from Holland which shows that doing proper sport-specific conditioning, proper warm-up program can prevent knee injuries, especially ACL injuries, in 65% of the patients. So this is huge. They have conducted that study, and FIFA has accepted that, and FIFA has started this 11 plus program for all the football players, and in which they have found the injury risk is reduced. So you have to use appropriate sports gear. You have to do a proper cooling down as well as recovery period should be there. You should maintain proper hydration and nutrition and proper state of mind. However, in spite of all this, because of this competitiveness of the sports, the knee is vulnerable to injury. It could be sprain, tear of the ligament, or it could be overuse injuries, or it could be a horrendous injury like this, which can cause head injury or anything like that. So the outline in my talk is, I will start with the fracture, then dislocation, and then soft tissue injuries. And if time permits, I will talk about others. Fractures. See here. See here again. Look at his leg. Fracture. These are not very common injuries, especially this fracture is not very common, but they do occur. And most common injury fracture is the patella fracture, then followed by intra-articular fractures like this, and you have to fix it with the plates, screws, or wires, whatever way you can. This is a high energy trauma, again during sports. Dislocations are also not so common, but they do occur as a high energy trauma, history of fall, motor vehicle accidents, and high contact sports like soccer or rugby. Dislocation also can occur. These are the dislocation of the knee. This is not normal. So this is the dislocated and multi-ligament injury. All the ligaments are injured in this. And sometimes even patella gets displaced because of abnormality in the patellofemoral groove. Look at this injury. Look at here. The knee has totally displaced. Just watch. This is a high energy trauma. Here. See, this is the total dislocation of the knee. And it is a very high energy trauma. It can cause anterior cruciate, posterior cruciate, and all the ligament tears. Let's come to the anterior cruciate ligament, which is the most commonly torn. And this occurs because of lot of jumping, pivoting, and sudden stops and turning around can cause this type of injury. Female athletes are more prone to injury because of their physical structure as well as their physiology. And ACL injury, what happens if ACL injury occurs? Well, after ACL injury, you can develop degenerative changes in future, early degenerative changes in future. So ACL injury has to be treated. It is said that ACL injury is the beginning of the end of the knee. So you have to treat it. This is a classical ACL injury during football. This. So what are the symptoms? Well, pain, stiffness, hemarthrosis, swelling, loss of motion, and feeling of instability while walking, and knee gives away. So that is classical of anterior cruciate ligament. Physical examination mostly can diagnose this. However, MRI confirms the diagnosis of the ACL tear. And once it is diagnosed, then it could be partial or complete. In case of incomplete tear, you can conserve it. In case of complete tear, you have to go and reconstruct the ACL. I will show a small clip of a reconstruction. This is a small incision taken through the hamstrings, and hamstring tendons are taken for as a graft to prepare the ACL ligament. New ACL ligament is prepared with this hamstring tendon. Hence, hamstring tendons can be taken from the same knee, so you don't have to go anywhere else. Then the torn ACL is debrided with the help of shaver. Once the ligament is debrided, meanwhile, the ACL is prepared at the back table here with the help of these grafts. These portals are taken for the femoral drilling. This is the insertion point of the ACL on the femoral side. So you prepare it well, make a tunnel. Then make a tunnel on the tibial side for the origin of the ACL. So that is the origin of ACL. It starts from here. So make a tunnel here. And this upper tunnel and lower tunnel, both the tunnels, the ACL is taken from the tibia, from this tunnel, passed from the here to the femoral tunnel, and then fixed together. This is how, that's the thread. This is endo button which can be fixed on the femoral side. And this is a ACL graft which is coming up from the tibia above into the femur. So the graft is coming up, and now this is the new ACL which is formed. And this is fixed with the help of screws and button on the tibia as well as femur. So this is a new ACL. That is the screw which is bioabsorbable, which you can use. Now let's come to the posterior cruciate ligament. Look at this injury. Again, posterior cruciate is not as common. See, hyperextension, bulk. So PCL tear is not as common as ACL. However, sudden blow or fall on the bent knee can cause this PCL tear. PCL is the posterior one. PCL tear usually is not that dramatic, and one can miss the PCL injuries because most of the times these PCL injuries are subtle, and patient may complain of some limp or difficulty in walking. There could be some swelling, and this is a typical sign of posterior drawer positive. This is the PCL tear. Unlike ACL tear, mostly this can be conserved. However, in case of severe instability or with multi-ligament injury, you have to fix the PCL ligament or reconstruct the PCL ligament with the help of, again, the same graft that I had shown. You can arthroscopically fix it along with the other ligaments. Then medial collateral and lateral collateral ligaments, they can be completely torn or partially torn. Again, partially torn, the treatment is conservative, and completely torn ligaments should be repaired. Meniscal tears, they are again very frequent because of twisting and turning and changing the direction of the football. Meniscus is acts as a shock absorber between the tibia and femur, and knee injury can cause osteoarthritis in the knee if you don't treat the meniscal tears. The symptoms of the meniscal tear is popping sensation, or there could be clicking sensation, and knee can get locked in extension. These are the various types of tears that can occur into the meniscus. If the tear is very small, you can conserve and allow the tear to heal. But if it is a big tear, you have to suture it. Nowadays, we suture these tears. So in case of degenerative tear, usually these tears are only debrided, and it is called an arthroscopic partial meniscectomy. That means only the detached or torn portion of the meniscus is removed with the help of shaver and this basket forceps. And once the ligament, the meniscus is debrided, that's all that is required. However, in major tear, where this is a bucket dental tear in young patients, this is a tear which has come into the intercondylar notch, and the tear is from here, periphery. This tear nowadays are suturable, and it is advised to suture this tear so that this is called as a meniscus preserving surgery. And that will, by preserving the meniscus, we are preserving the patient's knee joint for future. So it is better to suture the meniscus rather than to do this meniscectomy. But by doing meniscectomy, you are removing the shock absorber. So suturing technique can be all inside like this, which I am showing. This is the anchor, specialized instrument, which has a thread and anchor. You fix this, or there are other methods possible that are inside out technique or outside in technique. And this is all inside technique. So these three techniques are available to repair the meniscus. So this is suture number 1. Similarly, another suture is passed, another suture is passed here. And with these 3 sutures, you can actually fix the meniscus back to its position, and this meniscus heal 90% of the times. So this is a meniscus preserving surgery. What other injuries can occur is a tendon tear by direct front blow over the knee joint. You can get the patellar tendon injury or even a quadriceps tendon injury. The treatment again is for partial tears. You have to take rest and plasters, and in complete tears, you need a surgical treatment. Patellar bursitis again is a very frequent problem occurring into the runners, and there is inflamed bursitis. Most of the times, conservative treatment is helpful. However, if there is hematoma or infection, then you may have to remove the bursa surgically. Jumper's knee occurs in games like basketball or volleyball, and the treatment involves again rest and medicines and physiotherapy. And if they are not better, then tendon strapping and sometimes platelet-rich plasma or PRP injection, or you can call it as a stem cell injection, can be given along with the physiotherapy. Runner's knee is another symptom that are occurring in the those who are running for long distance. It can be anterior knee pain, and it is usually treated conservatively, and sometimes surgery will be required. So in treatment summary, conservative treatment is preferred is rest, immobilization, ice packing, compression, and sometimes anti-inflammatory drugs and physiotherapy. Surgically, fracture should be fixed, dislocation should be relocated and fixed, recurrent patellar dislocation deformity correction should be done, and ACL, PCL tears should be arthroscopically reconstructed. Whether you treat the patient conservatively or surgically, post-treatment physiotherapy and rehabilitation plays a very major role in the recovery to regain the full range of motion. So in conclusion, knee injuries can be prevented, but if they occur, early diagnosis and appropriate treatment along with the accelerated physiotherapy and rehabilitation should be done properly. Current modalities of treatment like arthroscopy and biologics have vastly improved the results, allowing the patients to play their pre-injury game as early as possible. Thank you very much.
Thank you, sir. Since we all wish to have lunch in time, we will have question and answer session during lunch. So please be on dais. We would like to felicitate you. Requesting our chairperson to felicitate sir. Thank you, sir. You made the spine look very interesting in a very short period of time. Thank you, sir. May I request our Honorary President, Dr. Abaji Shirke, to felicitate our chairperson. Thank you, sir. Moving on to the next session.
We start with the 7th session of the conference. We have 2 speakers in this session. I would like to request the chairpersons of this session, Dr. Sheetal Patil, who is Executive Committee member, the past president of GP Association. He is a reputed homeopathic consultant and has active participation in natural calamities through the White Army. Dr. Kapil Shinde, chairperson. He is an executive committee member of KMA, and he is a consulting orthopedic surgeon in the city of Kolhapur. May I request the first speaker, Dr. Suraj Pawar, to come on stage?
Good afternoon, everyone. I would like to call upon Dr. Suraj Pawar, sir, who will be sharing his experience with us regarding setting up the Rural Cancer Care Center. Sir has completed his MBBS and MS surgery from prestigious St. GS Medical College and KM Hospital, Mumbai. He did his specialization in surgical oncology at Tata Memorial Hospital. Also, he did his fellowship in thoracic oncology from the prestigious Memorial Sloan's Kettering Cancer Center, New York, USA. He started Kolhapur Cancer Center, a state-of-the-art cancer center with all advanced cancer treatment facilities under one roof, and is a chief surgical oncologist and managing director at Kolhapur Cancer Center. He is also the founder chairman of NGO Chhatrapati Shahu Cancer Research Foundation, a charitable trust that works for the benefit of the economically challenged cancer patients. Welcome, sir.
Yeah, thanks for the kind introduction. Can we have the first slide, please? Yeah, so this is just sharing my experience of last maybe 15, 20 years of how the process, the journey which we have gone through setting up Kolhapur Cancer Center. Now, technically speaking, Kolhapur Cancer Center lies outside the municipal limits of KMC. And we have 90% of the patients coming from a rural backdrop. So you can call it as a rural cancer hospital, although I would not like to call it as a rural cancer center. I'd like to call it as a Kolhapur Cancer Center. But yeah, what was the story? You know, look at this statement made by Mr. Gandhi. India is not Europe's way. India is not Calcutta and Bombay. India lives in her 700,000 villages. So that's the basic crux of our nation, you know, where the majority of the people are living in the villages. And cancer is the second leading cause of death. Nearly 7 lakh people die of cancer every year in India. And as per the latest reports, 1 in every 10 Indians carries the risk of getting cancer before the age of 75 years. I'm sure you must have realized how rapidly the incidence is increasing. This is a Globocon study again predicting that the rise in the cancer is going to continue. I'm sure, you know, each one of you sitting here must be knowing, having a relative or a distant relative or a friend who is suffering from cancer, because the incidence, the actual incidence is also rising, number one. And number two, the detection rate is also rising because people are getting more aware. And with programs of awareness and screening, the detection rate of cancer is also very high. Now, India is a non-priority nation as far as cancer is concerned. Look at this. Cancer is a non-priority in low-income countries. And India is definitely one of them. Not just cancer, but overall health, the expenses on the health by the Indian government is very, very less compared to most of the other even developing countries. Now, the key points here are the rising costs of the treatment, lack of early detection, which is again a major issue with cancer, and scarcity of centers. This is a huge problem because the number of specialists, the number of centers that are required by the country are far less than what is really needed. Now, if you look at this literature from Lancet, as per the GDP, India spends 1.3% of the GDP on health and 4.6% as the percentage of the budget. Now compare this with all other countries, these are all the BRIC countries, Brazil, Russia, China, South Africa. We are the lowest as far as considering expenditure on health, leave aside cancer. Now this is the comparison of key healthcare resources in India vis-a-vis WHO recommendation. So we have 0.65 doctors per 1,000 population, where the recommendation is 1. We have 1.3 nurse per 1,000 population, where the recommendation is 2.5. And similarly, the hospitals, the number of hospitals that are recommended for our country are much less as compared to what is recommended by the WHO. Now, in cancer, early detection is of maximum importance. That's because the two benefits are, one is it can lead to possible cure. And number two, is the organ preservation is feasible if the patient is detected in an early stage and we can give a better quality of life. So screening of the patients is important. Screening improves early detection of cancers by 1.5 to 2.5 times. Late detection adds to the cost of the treatment, and cost of late stage cancers is 1.5 to 2 times higher than the cost of the treatment of early stage cancer. So it makes a lot of sense in trying to detect or catch the cancer in early stage. Now, these are the all important components of cancer control. Starts from prevention, which is the most important thing. Screening. Now, screening of all cancers is not possible. So the government has come up with guidelines, non-communicable diseases that are declared. And in these non-communicable list of diseases, there are 3 cancers: oral cancer, breast cancer, and cancer of the cervix. Because these are the incidence of these cancers very high. And number 2 is these cancers can be screened. They can be easily detected. We have a mobile screening van at Kolhapur Cancer Center, which goes to small towns, cities, the interiors and villages. And we do screening of the oral cavity. We do mammography. We do pap smear. So these are the 3 cancers which can be screened. Then, of course, early diagnosis, treatment, there are various modalities, which I am not going to get into details, but I'll briefly touch on the treatment modalities. Survivorship, and in the end, palliative or end-of-life care. So all these components are important for a comprehensive cancer center. And I'm very proud to say that we have all these components at Kolhapur Cancer Center, including the specialists, highly qualified specialists who are heading these various units. So the problem is the scarcity of centers, acute shortage of trained oncologists. As I've already mentioned, look at this data. The number of oncologists in India is just less than around 1,000. And the number of oncologists required by 2020, we are already 2021. So this is the requirement of the oncologists in the country. And this is what the actual facts are. Similarly, deficit in specialists. If you look at Maharashtra, if you just concentrate here, we are almost 1,500 specialists short just in the state of Maharashtra. So look about what the situation might be in the country. Current number of centers in India, cancer centers, are around 200, whereas the requirement is somewhere around 450 to 500. So such a huge gap, and most of the centers are basically based in cosmopolitan, metropolitan cities, and the patient has to travel far distances to go to the centers for treatment. So 7 in every 100 runs the risk of dying before the 75th birthday, and 80% of the cancers require radiation therapy. Now, this is a very, very critical point that one should note, because if you take away radiation, what is left is just a plain simple nursing home, which anybody can create. Surgical facility, chemotherapy ward, chemotherapy facility, it's fine. But what makes a cancer hospital a comprehensive cancer hospital is the radiation therapy facility. And nobody likes to put the radiation therapy. You know, we were the first ones to start the radiation therapy, a very high-end linear accelerator, triple energy linear accelerator with image-guided radiation therapy, which was the best at that time. And such that kind of a machine was not available even in Pune. Between Mumbai and Bangalore, ours was the only high-level machine at that point. And I was wondering that all these years, why Kolhapur didn't have a radiation machine? Forget about linear accelerator, not even cobalt. I used to hear stories that some XYZ senior oncologist was trying to put a cobalt in some XYZ hospital, but it didn't work out. So I was wondering, and I used to feel very embarrassed to the extent of being feeling ashamed that I used to perform surgeries and then refer patients outside to Pune or Mumbai or Bangalore this side for linear accelerator, or for cobalt, the patient has to be sent to Mirrors or Karad. And I used to wonder why radiation has not been put here in such a big city. You know the reason? Because it was a hugely loss-making venture. So let's not talk about anything else. It eventually boils down to the fact that at that point in time, it was a hugely loss-making venture. The investment versus the ROI, the return of interest. You know, you cannot rule it out. You cannot totally say that I'm not going to think about the ROI. Otherwise, everything will go haywire. So that was the reason. But This being a critical facility, and I was every day, every night, I was spending sleepless nights thinking that why my patients had to travel far distances, and the radiation therapy goes on for 1 month, 6 weeks, and as it is, poor patients, they're traveling, suffering. So as I said, 80% of the patients need radiation therapy, either pre-operative or post-operative, and the demand and supply of radiation machines is in acute shortage across the globe. I'm not going into the details, but more than 50% of the patients requiring radiation therapy in low and middle income countries do not have access to radiation therapy. And the situation is dramatic in low income countries where 90% of the patients do not have access to proper radiation therapy. Now look at the deficit here. In India, percentage of patients access to RT is just around 36%. And the availability of, this is a teleradiation therapy unit, we are minus 899, so almost 900 units less, and so on and so forth. Radiation technologies, radiation oncologies, a huge problem facing our country. So the scarcity of centers in the tier 2, tier 3 cities, rural cancer centers, of course, were non-existent. And this is what, there's a need for rural cancer hospital. You know, we found that the regional cancer hospitals are few and inadequate. They are overloaded with work. Patients come with late presentations. There's a wastage of resources, and hence there's a need for comprehensive cancer centers at subsidized cost in rural settings. So there is a vast gap between the urban rich and the rural poor in India. Basic need of food, water, and shelter, these are of prime importance for people who are, you know, staying in the rural areas. Forget about health and that to cancer. For these people, cancer is like equal to cancel. They don't even want to think about treatment because of the cost factors involved and the inconvenience, basically. Healthcare and civic amenities take a second place. Inaccessibility to metropolitan cities, financial constraints, these are all the major problems. So these are the basic requirements that they're struggling to fulfill, our poor population staying in the country. Food, water, you know, this is a situation, most of the places in interiors of India, there's an acute shortage of water, good schools, that's a big problem. And transportation, again, is a big problem. You know, to get the patient every day for radiation therapy to center in the major city, that's a big problem. So there are moments in our lives when we find ourselves at crossroads. The choices we make in those moments can define the rest of our days. So when I finished my training at Tata Hospital, I also had some kind of a similarity with Dr. Bhupali sir, because we belong to the same institute, say GS Medical College and KM Hospital. But after that, I studied in Tata Hospital and did my fellowship in thoracic surgery at Sloan Kettering, USA. And then I came back. So I was wondering what to do, because there were so many opportunities. I could have settled in big cities, abroad, or what to do at this point in time. So there was a dilemma, big city versus a small town. The advantages of being in a big city, or you're used to being in a big city because you have stayed in Mumbai for some 15, 20 years and experienced the metropolitan life, the advantages of being there. You go abroad, you earn in dollars. You know, a lot of my friends, my colleagues who are already immediately after finishing the studies, they went and settled outside, either in US or Canada, and started earning in dollars, where we were struggling here, owning swanky cars there. Or to come down to smaller tier 2, tier 3 cities, to our roots, where the lifestyle is completely different. This is the kind of the population of the cities or tier 3 cities where one would like to practice, earn in rupees instead of dollars, and this kind of a rural backdrop. This is kind of the transport which I personally have used very frequently. In the initial stage of my life, I was staying in Sangli with my parents, and I used to do up and down from Sangli to Kolhapur every day in this Lal Dabba ST bus, you know, which used to say, Hath Dakhwa, Gadi Thambwa. But I used to be very proud in traveling the ST bus, because my dad was, he served in ST for almost 35 years, and he retired as a general manager of MSRTC. So it's like safe and accident-free bus service, MSRTC. I'm definitely not a brand ambassador, but I have experienced, and I love traveling this Lal Dabba ST bus, because after that initial jittery thing, you get sounds and vibrations from everywhere. And then after a certain time, you get so used to it that you fall asleep. Most of the times it used to happen with me. But those were the initial days. Eventually, when I left Tata, then I decided to come back to my roots. We have to get used to the idea that at the most important crossroads in our lives, there are no signboards. It has to be your intuition, your personal decision. And this is how my story started. It started here, right at the footpath opposite Tata Memorial Hospital, which was my alma mater. It's a great institute, but me and Dr. Reshma, we were dating at that time. So she used to come sometimes, once in a month, we used to meet. And this is the picture which is still the same. Even today, if you go to Tata Hospital, you still see the similar picture there. And this is what used to hurt us. These are the patients who are on the waiting list for treatment at the Tata Memorial Hospital. And one rainy day, when Dr. Reshma and myself, we were standing at the bus stop, we saw a patient from our area with a rice tube, and his wife was, she had made a small chula, and she was making a rice water to be fed through the rice tube. And this patient, when he came to my OPD after a few months of waiting, by the time he came, the disease had gone beyond treatment. So this was the situation, and this was when we decided that nothing doing. We are going back to our roots. We are going back to our place where the facility is not available. Though the burden of cancer involves the entire nation, but the rural and underprivileged population represent majority of the patient. That is the sad story. So setting up of Kolhapur Cancer Center, we chose here. Basically, I am from Sangli, and after deciding to leave Tata Memorial Hospital, I was supposed to join Siddhivinayak Cancer Hospital in Miraz. That was the entire plan, and I had shifted there. But somehow I was refused a job at that hospital for reasons best known to the management. So eventually I was planning to go back to Tata because my bosses wanted me to come back and continue as a consultant. But I would like to thank Dr. Niranjan Shah and the entire Lotus group here. Dr. Shirkesar was also part of that initially. They pulled me to Kolhapur, and they saw to it that they just didn't pull me, but that I stayed back, because a lot of initial days it was almost like a shock coming from Mumbai to Kolhapur, and sort of so much of a difference in the work culture and the work atmosphere. But we stuck here. And why Kolhapur? Because we felt the need of the Western Maharashtra population was there for the cancer facility. And we felt the right of poor patients to get standard treatment was there. Just being poor doesn't mean that the patients should get any kind of substandard treatment. So with the population of around 35 lakhs, the entire district, no comprehensive facility available here. This was the facility proposed. Surgical oncology, medical oncology, radiation therapy. We got the best of the machine at that time. Intensity modulated radiation therapy, image guided with VMAT technology, brachytherapy. This is again a big story. Do you know, even today, apart from Kolhapur Cancer Center, there is no brachytherapy center around in Southwest Maharashtra. There's one brachy, I think in Karad, which is old-time Cobalt. But other than Kolhapur Cancer Center, there is no brachytherapy around. Can anybody guess why? It's a simple guess. Cost, yeah, it's not cost effective. But we got it, we got it on day one itself, because the patients need it. Sometimes you have to, can't always keep on thinking about the cost, because if you don't have brachytherapy, the radiation therapy cannot complete, especially in cancer of the cervix. The external beam radiation therapy has to be completed and coupled with internal beam, that is brachytherapy. Only then you'll get the best possible results. But the problem with brachytherapy is it's hugely loss-making. Even today, we are bearing a huge loss because the brachytherapy, it has a limited half-life. The iridium wires, radioactive wires that go inside the uterus, they have limited half-life. And it's a hugely loss-making venture, but we are sticking to it because the patient treatment quality should not be compromised. Then we have an oncopath dedicated oncopath lab. We have a histopathology department. We have a frozen section for the first time again this area. We have immunohistochemistry facilities. Dr. Sarunke sir will understand what I'm talking about. Radiology, we have these facilities, pharmacy, other. These were all planned in the first stage and we already achieved it. Second stage, what we had planned, I'll come to it later on subsequently. But these were the basic requirements, at least half an acre of land. Eventually, we bought 5 acres, which is outside the city. But the total budget that came to was 50 crores at that time. And with no financial backing. So there were options we had was whether to get into the joint venture, something like get people together and get into profit sharing, make people invest, either doctors or non-doctors, non-medicals or businessmen. Other option was a group investment amongst doctors only. And the third option was whether to go solo. And fortunately, we went with this option. Why fortunately, I'm telling you, because I'll tell you in the subsequent part, because otherwise, if it had gone into any of these, it would have been a big disaster. Now, of course, it's become an institute and now it's a different ball game. So this was the land and site development cost, infrastructure, machinery, equipment cost was the heaviest, and the total project cost was 50 crores. The implementation was supposed to occur in 11 months once we started. This was an estimated revenue, including chemo, radiation, surgery. These were the projections. This was supposed to be the revenue. This was the proposed expenses. And then this was supposed to be the proposed profit. Everything looked very, very fine on paper. But when it actually started, it was absolutely the other way around, upside down. So the beginning, to get the land itself, I was struggling for 2.5 years to get a proper land, because to get a land in the city with proper parking facilities, and if somebody else, some neighbor objects, there are examples across the country that the land has been bought in the city and they've applied for radiation. The radiation permission has been approved by the ARB, but some neighbor has put a complaint in the court and the case is stuck over there. So we didn't want this to happen. So luckily we bought a land which was just on the outskirts of Kolhapur. ती जागा जेव्हा आम्ही घेतली तेव्हा लोक म्हणायचे, म्हणजे लोक मला वेड्यातच काढायचे की अरे तिकडे बघ आता काय, अरे त्याच्या बाजूला दुसरं एक हॉस्पिटल होतं. आय डोंट वॉन्ट टू टेक नेम्स, पण तेव्हा एक हायवेवरती अथायू हॉस्पिटल होतं बहुतेक, आत्ताचं अथायू, पण तेव्हाचं नाव वेगळं होतं. ते जे बंद पडलं होतं, ते म्हणजे एवढ्या लांब तू जाणार, ते हॉस्पिटल बंद पडलंय, तुझं पण हॉस्पिटल बंद पडणार, विचार कर. आणि त्यावेळेस फ्रॉम कोल्हापूर सेंटर टू गो टू दॅट प्लेस, शाहूनाका, there was a single lane road with thousands of potholes in that, and it would take at least 45 minutes to reach from ST stand to Shaunaka. But as soon as we bought this land, the road construction started and all these things happened. IRB came in and now it's almost like a highway. So we were very lucky. Loan issues. For 3 years, we were struggling. Not a single bank was willing to give loan because my CA had prepared on paper the project report, and not a single banker was willing to give loan because we were saying this project is not viable. So how can we give you loan? So for 2.5 years, we were struggling. Me and my dad were going, some bankers gave some hope, some didn't. So in the end, we were almost on the verge of giving up when my dear friend, Dr. Sandeep Patil, he took me to Kolhapur Cooperative Urban Bank. So that was where we eventually went. But before that, there were a lot of warning from colleagues and friends about whether to start such a big venture, such a huge investment. They were telling me, you are a surgeon, why don't you concentrate on surgery? Why you're getting into venture of starting a cancer hospital, which is none of your business. आणि काही लोक प्रेमाने म्हणा किंवा काही वेगवेगळ्या मार्गाने सांगायचे. One of my friends from Karad, who was a senior surgeon, he sent an indirect note to another friend की अरे ते सूरजला सांगते ह्याच्यात पडू नको फंदामध्ये, नाहीतर तो रस्त्यावरती येणार. And he was the chairman of a bank in Karad where I had applied for the loan. So these were the kind of feedbacks. And around the same time, one unfortunate thing happened was there was a sudden death of Dr. Neetu Manke. He was in the process of creating that huge cardiac center, and He had a sudden MI. The cause we don't know, but people will try to correlate that, look, he went into such a big project, such a promising project, and with all the stress. So you learn from what has happened and you back out, you don't get into such things. So these warnings from friends, sometimes they were genuine, sometimes they were not. You need to overcome the tug of people against you as you reach for high goals. So we approached nationalized banks, cooperative banks, all of them refused. Eventually we went to Kolhapur Urban Cooperative Bank. And that was my last chance. I thought if these people refuse, then I am not going to put the cancer hospital. I'll concentrate only on my surgery and let's see what happens. So what happened here with this bank is there were 10 board of director members sitting across to take a decision on whether to grant a loan for this cancer project. So me and my dad went there, and for your information, Kolhapur Cooperative Bank is started by Chhatrapati Shahu Maharaj 100 years back with a very social intent. And I brought up all these things in front of the board of directors. I pleaded like as if this was the last day of my life. And I just tried to tell everybody that this is a social project, there's a need. There are a lot of poor patients in this area who have to travel far and wide and go for treatment. They're suffering and we should help them out. So please grant me a loan. And to my biggest surprise, and I was very happy that they granted me some loan, through which I could buy the land and then start the process. And then I realized, sitting there with the board of directors, why they granted the loan to me? My calculation was that, what my guess is that they granted loan because all of them were typical Kolhapuri people. They didn't think too much about the finances. They just got carried away emotionally with the kind of the project and the appeal that I made. So you have to work with multinational companies to buy the machines. You have a lot of problems with this civil work. We are now trained to interact with builders, contractors, electricians at every stage. It's a big struggle. Red tapeism, getting permissions from Atomic Energy Regulatory Board. Then there are some issues which have to be settled under the table, where we are not trained in doing all these kind of things. And then this was the piece of land. It's a 5-acre land, which you all know now. It's just across Shahunaka. Slowly the construction started, the building started taking shape. And this is how, and while this whole thing was going on track, we had an experience with an Indo-American company. This guy who was nominated as a director, he was an Indian, but he came to me for representing one American company that was selling remanufactured radiation therapy machines, refurbished, and it came at half the cost. So I was very happy. I said, oh, you can save that type of money, huge amount of money, and I can pass the benefit to my patients. So he showed me a paper with all the permissions written, and I, like a fool, I believed in him, and I transferred a huge amount of money into his account, in the account of that company, the company which was based in US. And then when I went to ARB to check up why things are not moving forward, then I realized that there was the other side to that page, which had all the preconditions. And this company had not fulfilled any of those preconditions. So I lost whatever loan that was given, partly, most of it I had lost. And why I'm saying here, lucky now we were solo, we were doing it everything on our own. Because if we would have done this project in a group, I was sure that people would have blamed me. They would have said, "Isne to paisa khaya isme." But here I was only to blame myself and nobody else. So though whatever money was there in the bank, it was gone. So half the truth is worse than a complete lie, which I realized because that person told me only half the truth. And sometimes it's very difficult to believe when people convince you so much. So we were back to bank balance zero. What to do? Stall the project or go ahead and complete it? So we went back again to Chhatrapati Shahu Cooperative Bank, our friendly bank. Again, we explained the whole story. Again, we pleaded in front of them. So again, they bailed us out with giving some additional loan and we could go ahead. So there were budgetary constraints. There were construction hurdles, bunkers. The construction of the bunker, it's a very special thing. The bunker, it is called as a bunker. It has 8 feet walls of pure concrete, including the ceiling. So there was no architect in this region who knew how to construct it. My architect Samir Joshi and I used to sit with the guideline book from AERB together, and we used to work it out, and that's how we built this bunker. It's a huge thing. So if there's, and jokingly we say that if there's some war going on, when the war starts and there's bombing, you can be safe inside this bunker and nothing is going to happen. So this is inside of the bunker. Lot of labor issues that we had to deal with. And when again things were going smooth, suddenly one fine day, a political party issued a fatwa that all the North Indians who are in Maharashtra should leave Maharashtra immediately. Now, this was not in our plan of action. We had not anticipated it. And they left. And there were no Maharashtrian laborers who were willing to work. So for 3 months, all these people from North India, they left because of the threat issued by a political party. Which party? I'm sure you all can guess easily. But these are the unexpected problems that came our way. For 3 months, the work was stalled and the bank installments had to be paid. So dealing with contractors, builders, electricians, for the first time I realized that there are so many festivals in India. Every festival, people take holidays and they're off. I never knew there were so many of them. You can really be surprised if you count how many official festivals and official holidays are there. Apart from there, the people take sickness leaves, and then sometimes there are delays due to no reason at all. Lack of professionalism. In tier 3 cities, this is a big issue. You have to deal with people who have a complete lack of professionalism. And if you start shouting at them or treating them hard, they leave you. They're not bothered. They're not bothered of that they'll lose their work or job. They just disappear. So it is a very tricky situation. Then critical approvals are there, hospital approvals, Bombay Nursing Act, fire safety, approach road, biomedical waste. This approach road again was a big issue. We had to build from the highway to the location. There was no road at all. So we had to acquire that land and build a road ourselves, which the government was supposed to build. Now dealing with the Atomic Energy Regulatory Board. I think there was a lecture by one ARB, I missed somehow, unfortunately I missed it. So they have very strict laws. The time for approval taken for just approval for the machine is around 3 months. Plan approval of the site, there are a lot of technical things, machine approval, quality analysis, and Atomic Energy Regulatory Board is supposed to be in the whole world in this field. Even the American board or the other people, European board, they are milder and they have rules which are much easier to handle than Atomic Energy Regulatory Board of India. So we had to go through all this entire process. So the finalizing machine was again, it was like swimming in untested waters because you never know what is the actual cost of that machine. Whatever figure they tell, you have no idea how much this machine, the higher end machine that we had bought at that time. No technical know-how, potential exploitation at every level. But whatever deal we got, we thought was the best for us. And at the end of it, when everything, the money was over, we realized that we had to pay a heavy 12% customs duty. So we thought that it's a social work. It's a radiation machine. We're treating patients here. It's related to health. We're creating a facility. And that the government should at least waive off or reduce the customs duty. But there's absolutely no chance, whatever you do, whether you do charity, whether you're doing free work, the customs duty of 12% turned out to be huge. Other taxes, installation delays, there were transport delays, weather problems. When the machine actually arrived in the campus, suddenly, there was a huge hailstorm. असे एवढे मोठे मोठे गारा पडायला लागल्या सगळ्या सडनली आकाशातून. So that was again not anticipated. We were stuck there because if a little bit of water enters into the machine, the whole thing goes wrong. Electrical problems, deadlines which were never met. So many obstacles that we had to really struggle at every step. So obstacles are those frightful things you see when you take your eyes off the goal. So the installation took 1 month, commissioning, approval, treatment, all of technical delays. The buildings started taking shape exteriorly. The machine comes in small parts which are assembled here inside the bunker. And this is how the machine is getting ready. And this is the triple energy linear accelerator radiation therapy machine, the first ever in Southwest Maharashtra between Mumbai and Bangalore. And now we are in the process of getting a second one, which is even higher than this, which will again be a very top line radiation machine, which will have a gated facility, something like you can connect it to, suppose there's a tumor in the lung moves with respiration. So the radiation will miss the target, but it can be gated. The gated technology can, with a software, very high-end software, we can attach that radiation to the tumor and the radiation will move as per the respiration of the patient. That is just one of the facilities. But the next machine which we are getting very soon, in the next 3 to 4 months, the second linear accelerator would be functional, and that will be the highest level machine in this whole region. So that's again coming back the whole story. The building started taking shape from everywhere. The roads had to be made, curving, and then the cars started coming in, some patients. The greenery started growing. And this is how the interior of the hospital. Most of you have seen all these things with either your patients or as visitors. And this is the radiation therapy machine, the image guided radiation therapy with intensity modulated. And then the patient started flowing slowly, very, very slowly, because there's always a waiting period. Final look of the building. So Anna, this is fine. You created a construction, you created a structure there. But what about the people, the personnel? So you have to get the best manpower, and to get that hospital with a rural backdrop is very difficult. People want to settle in big cities and cosmopolitan cities, but to get them to a tier 3 city, it's very difficult. You have to pay them well, of course. And the best part we did, I think, during this whole process, I was advised that why don't you put cobalt radiation machine instead of putting such a higher end, very costly machine. Put a simple cobalt, which will cut down on the cost. But we went for the highest technology, and that was a big advantage because we could get the best manpower, because they were excited in working on that technology. Because in Pune, this kind of higher end technology was not available. So for the professional, it is not, money is one part, but to be able to have that kind of a job satisfaction and to get that excitement working on a higher end technology was far superior. We saw to it that low cost treatment is not low quality. We maintain the highest quality for radiation. For example, this was a cancer of the vocal cord, and 1 year post radiation therapy, the whole thing disappeared. That was only because we had this very high end radiation therapy machine. We have the best possible surgery setup, chemotherapy facility, and the quality of patient is always maintained. Now, just some examples, some firsts we have done in this area. Bone tumors usually affected by young patients. We used to do either amputations above knee, below knee, or amputation forequarter, hindquarter, painful. But now what we are doing is we are doing limb preservation surgeries with this kind of implants. We are giving neoadjuvant chemotherapy, shrinking the tumor, and then putting the implants so that the patient's limb is preserved and the patient can walk. Now, these are the young patients who, if they can preserve the limb and they can walk. This is a small video, but I am skipping it because of shortage of time. Big surgeries in small cities. When I left Tata Hospital, my bosses used to tell me that do small surgeries first. Don't go for esophagectomy straight away. Don't go for liver. The patient dies, your whole career would be over. But that is one thing I didn't listen to them. This was a case almost 20 years back. I done it at Lotus Hospital. Shirke sir was there. We had done an extended right hepatectomy in a 65-year-old man. You can see the whole tumor. This is only 30% left lobe of tumor remaining. The huge right tumor. You can see the date 5, 10, 2000. That's 20 years back. And this was the patient post-op at that time, 65 years old. Initially he came, but then he lost to follow-up. And after 20 years, he came back to me again. You look at the scar here. The same patient, he came back because in those 20 years, at the end of 20 years, he had developed a second cancer. And that cancer had nothing to do with the liver. He had cancer of the penis. We again treated him and he became well. So I'll skip some of the slides because of shortage of time and come back to some of the surgeries, surgical advances that we have done, especially in minimally invasive esophagectomy. We have developed a new technique at Kolhapur Cancer Center. So being in a tier 3 city does not mean that you can't do something at a bigger level or not invent anything. So these are the two standard positions for the minimally invasive esophagectomy, but they had their problems. So we thought that, with our center, the shortage of highly trained hands and the procedure used to take 3 to 4 assistants. So cultivation of mind should be the ultimate aim of human existence. And I also feel that necessity is the mother of invention. So in the year 2006, we devised this technique called as a power technique, our own technique. We had a combination of the lateral and the prone position. And in the dorsolateral, the semi-prone position, we performed this technique first time in the year 2007. And this technique was then, the video of this technique was presented at the World Congress in 2007 at Washington. And this was rated as one of the best videos. And this has been accredited by the American Board of Surgeons as a teaching video in their video library. So members of American Board of Surgeons, they see this video online, they get CME credit points. So this is what we've developed in a tier 3 city, a cancer hospital, the rural backdrop. I am cutting short this video. So these are the small scars, you can hardly see. The advantages of the power technique we developed here. Earlier, the blood loss used to be around 2.3 liters. Now it's less than 100 ml. Duration of surgery, 8 to 9 hours, came down to 2.5 hours. And these are the other advantages that took place. So I was invited to give a talk on this technique at the Memorial Sloan Kettering Cancer Center, New York, USA. This is with the audience. This is Dr. Manjit Bains, who was my mentor there when I had worked there. And this is the certificate that they sent, that it just mentions that the thoracoscopy, you made a complicated procedure look easy and what all things. So this was subsequently presented in the World Congress, as I mentioned, as is selected as the best video in that Congress. So we showed that it was easy and it was simple, feasible. But what about the viability? So we had to run around, do the marketing, branding, CMEs like this, camps, awareness. Initial phase, there were huge outgoings, less income. The EMIs had to be fulfilled. And we were stuck at one point. But I always believed that when you want something, all the universe conspires to help you to achieve it. This is by Paulo Coelho. But I think the more famous Hindi dialogue by Shah Rukh Khan, which is that movie, Agar kuch chahte ho dil se to puri kainat, something. So that is more famous than the original Paulo Coelho's statement. So when we were stuck, suddenly, out of the blue, we got this Rajiv Gandhi Arogya Yojana and all these government schemes. They came as a blessing. Because when the patient flow was less, suddenly these schemes started and the patients started flooding in the hospital. And I was wondering all this time, we were lucky actually that it all happened together. The machine started, the hospital started, and the schemes came in. And the most biggest beneficiary were the patients in this area. So I was wondering, where were all these years, where were these patients before the schemes came in, before the free schemes came in, what were they doing? Were they underwater? Were they hiding in the jungles? Where were they gone? Because we started the hospital for almost a year and the patient numbers were less. And suddenly when the schemes came in, they all started rushing in. But then we realized that these patients, they would rather prefer to die at their home with cancer rather than get treatment because it used to be very costly. So the most truthful way, just 2 minutes, I'll finish. The truthful way to serve God is to serve the poorest man. So this is a statement by Mahatma Gandhi. First they ignore you, then they laugh at you, then they fight you, then you win. So we went through 4 stages. When people say, oh no, it's not going to be possible, this project is impossible. Then some people started saying that it started, but it will surely very soon shut down because it's not viable. There were people to oppose, make adverse remarks, refer patients elsewhere in spite of the patient being in the city. All sorts of things. And quite a few of us have gone through all these things. And the last phase now is we have visitors from all over the country to kind of come and study this module of how this cancer hospital is working. We have all these NEBH, we have cancer registry, population-based, We are a teaching institute with all these fellowships under the MUHS. We have a charitable trust with a mobile cancer unit, which goes and does cancer screening and a lot of other camps. We are enlisted as one of the free treating cancer hospitals. Miracles happen only if you believe. So rural cancer care, low-cost cancer care is the myth or a reality. It is definitely a reality. We have shown that how it is possible. And to succeed, I heard in one TED talk, to succeed, it doesn't require IQ or EQ, that is emotional quotient, or SQ, social quotient, skill, talent, hard work. Nothing is necessary. What is necessary to succeed is what is called as the grit. And the grit means passion and perseverance. This was a TED talk which I happened to hear somewhere by Angela Lee Duckworth. So it's a teamwork eventually. No matter how you far set your foot on the moon, no matter one day we'll reach the Mars, but the final destination is 6 feet under right here on this earth. So we have the next dream project under our trust, which is the Sanjvat Sevashram. That is an ashram, which is meant for the end stage life care or a hospice to avoid suffering, pain, wounds, and sleeplessness of these patients and give them a very positive and a healthy ending and life with dignity. This is what is our next motto. So the next phase facilities, PET scan is already coming. Bone marrow transplant is done. We already have a state-of-art bone marrow transplant. And robotic surgery, as we all know, we have this robotic surgery. This is the bone marrow transplant unit with a very higher end facilities, HEPA filter, laminar flow. We have a 100% success rate of bone marrow transplant, which is very difficult to achieve. Recently, we started our robotic surgery at the hands of my father. Unfortunately, he passed away recently, just 15 days back. But robotic surgery, again, we were the first T3 city in the entire country to have a robo in the city. So this is a very state-of-art system which we have at Kolhapur Cancer Center. And this, I'll go to the next slide. This video is one of the most advanced kind of videos, robos, where you have to, the surgeon sits on the console and then he operates there from the console. So these are how the positioning. These are robotic arms. And here's the surgeon. You're looking at the screen, which is, the image is 40 times bigger, and it's a 3-dimensional image. So you feel as if you're actually sitting inside the human organ, and it's an open kind of system where you can see whatever the movements which are transferred by the robo into these arms, and whatever actions that the surgeon performs, they are transmitted through this robo into the human body. And the tip of the instruments are very fine. They rotate and flex. They're so flexible. They can move in any direction, in any degrees. And you can see here, this is such a small 5mm tip with greater precision and control. And you can do very, very fine surgeries which are bloodless. And that's the biggest advantage of robots. So hospital to institute has been the journey. We started with all these people, now slowly growing. And today we have a staff of 300 plus, which is serving the cancer patients in this region. And in the last 8 years or so, we have treated over 30,000 patients. 80% of them, that is 24,000 patients, we have been able to treat free. The whole intention of coming here and starting this hospital was, I think the whole purpose was served. If you look at these figures, that we could treat 24,000 patients totally free of cost. So this model, how to repeat it, we have connected to the national grid, national cancer grid, and the similar thought process with similar kind of experience that we have, we'll be wanting to share it with others in the rest of the country. And my friends, and this is my last slide, my friends always keep on asking, how is it possible? You had no funds, the total lack of experience of setting up a hospital, non-viability of project, lack of manpower. So how was it possible? So I always tell them the story of the bumblebee. You know the story of the bumblebee? The bumblebee, Bongamashi, it has a big body mass and it has very thin wings. So by the principles of aerodynamics, the bumblebee cannot fly. Even if it flutters the wings 1 lakh times in a second, with a huge body mass, the bumblebee cannot fly. At the most, the bumblebee can crawl or walk, but the bumblebee still flies. You know why? If you apply all the principles of aerodynamics, the bumblebee cannot fly, but still the bumblebee flies. You know why? Because the bumblebee doesn't know the principles of aerodynamics. So sometimes ignorance sometimes is bliss. You want to do something, you focus, you do, and put your heart and soul into it. I personally believe that पूरी कायनात आपको मदद करने में तैयार हो जाती है. So there's a mural we have in the center of our hospital which says, "Celebrate life regardless." Thank you very much.
Suraj, it was a very exhilarating journey that you took us along in the last 20 years of your life here. Suraj, you had made your mark 20 years ago as a surgeon, and there are many people who looked upon to you for motivation. But over the last 20 years, what you have done is that from a scratch, from no funds, you have helped, or rather you have built an institution. And I think this is not only a personal gain for you, I think the nation has also benefited, and you have helped in the building of the nation. Thank you very much, Suraj.
Thanks, Arun. Thank you very much.
Now, may I request our chairpersons to felicitate Dr. Suraj Pawar.
Thank you, sir. We have second speaker for the same session, Dr. Vivek Kulkarni. I would like to invite Dr. Vivek Kulkarni on the dais for his lecture. Welcome, sir. Dr. Vivek Kulkarni is a consultant surgeon, Department of General Surgery, Yashwantrao Chavan Medical College and Hospital, Pune. Special interest, he has interest in bariatric surgery, laparoscopic surgery, oncosurgery, breast surgery. Medical education and technology workshops he has conducted. Medical education and technology for medical professionals at Padmasri D.Y. Patil Medical College, Hospital and Research Center, Pimpri, Pune.
There's an important announcement that we will be breaking for lunch after this session for half an hour. And then we'll have the last session at 3 o'clock and the valedictory function. So please stay with us throughout the program. We will be breaking after this lecture for half an hour for lunch.
Hello? Hello? Hello. Good afternoon, everybody. I guess after the last talk, it makes my talk more difficult because after listening to such a fantastic presentation, I don't have words how to begin my speech, but it was a really an inspiring talk by Dr. Pawar. Myself, I'm Dr. Vivek. I come from Pune, and I started this center called as BMI Center. That's a Center for Bariatric and Metabolic Surgery. It's one of the very few centers of Pune which is accredited by IEF, that is International Excellence Federation accredited center. And we are functioning since past 5 years.
and we are doing good number of bariatric surgeries and also laparoscopic surgeries. So today my talk is about the weight regain after bariatric surgery. So the important question is, why did I choose this topic? See, I had come to discuss this with Dr. Sai Prasad, who is one of the organizing committee members of this conference. So after a few minutes, the first question which he was asking me was, ह्याच्यानंतर तरी परत वजन वाढतंय ना? So that is one of the most common questions a bariatric surgeon comes across when you are interacting with another surgeon. So here, it's very easy to talk about weight regain after bariatric surgery. But today we are just going to have a look on what are the important factors which we are looking at when we look at weight regain after bariatric surgery. It happens with a good number of subset of patients. Today we'll have a brief overview on why it happens and whether bariatric surgery is useful or is it failing. These are few of the questions which are coming up. And so far, see, if we have a look, there are a number of meta-analysis. There are a lot of studies that have been done which say bariatric surgery is considered to be the most effective treatment modalities for morbid obesity. See, if we look at this slide, see, excess body weight loss, that is EDBWL, it decreases from 66% at 1 to 2 years to 58% at 10 years. See, even if we look at the later figure, we are looking at an excess body weight loss of 50% at the end of 10 years. So once the patient undergoes bariatric surgery, at the end of 10 years also, he has got some amount of weight loss that is good enough to achieve a good quality of life. See, how many percentage of patients regain this weight? It's about 10 to 20% of these patients who are having weight regain. So what is the impact of this weight recidivism on quality of life? See, first, there is recurrence of weight-related comorbidities. And second, it has got economic repercussions in managing obesity and comorbidities. See, causative factors, if we divide the causative factors, it is basically divided into two things. One is patient-related factors, that is the patient's mental health and behavior. And second is surgery-related factors, that is anatomical alterations and complications. See, coming to patient-related factors, see, what happens is there is no compliance of nutritional. See, patients undergo bariatric surgery, they come from far off places to our center, they undergo bariatric surgery and they go back. So for first month, they have a very good follow-up. They call you regularly, they take care of themselves, everything. Slowly, they start, neglecting this post-operative care. And slowly, I've seen that patients forget that they have undergone bariatric surgery. And they go into this normal sort of routine where they don't follow up with you. Then the dietary habits, what happens to the dietary habits? There are some certain changes which happens after bariatric surgery. Some patient becomes what is called as grazers. See, bariatric surgery decreases the capacity to eat, but it does not stop you from eating. So that hunger sensation, mild hunger sensation, cravings, they keep coming back to you. And these patients keep eating smaller amount of foods. And these soft calories, they end up adding big and they make it, they start causing some part of weight regain. See, here we see the Swedish obesity study that says daily calorie intake, it increases from 15 calories per day, 15 kilocalories at 6 months to about 2000. So on an average, it's about 5000 kilocalories. It increases over a period of 5 to 10 years. See, patient who had weight regain after Roux-en-Y gastric bypass, 60% of these patients, they don't maintain follow-up. That is one of the biggest factors of weight regain. The adherence to the recommended post-operative diet. People always adhere to this diet for a few days and then they forget. So if they adhere it at least for the first 20 weeks, it is seen that even if they adhere it for the first 20 weeks, that is about 6 months, they have a very good weight loss even at the end of week 92. That's a very long period. See, poor diet quality, inappropriate food choices, lack of nutritional counseling. These are considered as the key factors that determine weight regain after the surgery. So what is necessary? What can be done here is the comprehensive weight management programs. These systems are all in place in European countries, but we don't have any sort of comprehensive weight management programs in India. So this is one of the things where we are lacking, and most of the patients undergo bariatric surgery and they don't have a follow-up in their own place. So if these kind of centers are developed all over India, then maybe the results will be more fruitful. And what these centers should do, they should focus on active monitoring and reinforcement. So active monitoring is very important, wherein a dietitian's call, every week there are 2 calls given by a dietitian, wherein they talk at least 20 minutes to the patient and they convey their message. If this kind of active monitoring is done, then the results will be definitely much better. And next factor, if we see, it is a hormonal or metabolic imbalance. See, there are a lot of hormones that change after bariatric surgery. Few of the key hormones that regulate weight loss in bariatric surgery. One is ghrelin, most widely studied hormone. Next is peptide YY. Okay. So ghrelin decreases after sleeve gastrectomy, and slowly and steadily over a period of 5 years, there is some amount of increase in the ghrelin levels. So this depends on how well the first surgery was done. So while doing a sleeve gastrectomy, if we resect the fundus to a very, very great extent accurately, the post-op ghrelin levels remain low for a longer period of time. So this helps maintenance of weight loss. If the first surgery is not accurately done, maybe we have a chance that ghrelin levels increase a little faster and cause some amount of weight regain. See, there are some surgeries wherein we do a bypass surgery. So when we do a bypass surgery, the food does not stay in the stomach pouch for a longer period of time. So it moves a little faster from the pouch towards the intestine. This causes a sudden increase in insulin levels. These sharp insulin rise levels cause some sort of hunger in these patients. So here, this hunger feeling keeps on motivating these patients to keep eating regularly, and they keep on becoming these grazers. So here it is very important to educate the patient on how to eat and what to eat. So these things, if educated properly, can help decrease the number of times a patient feels hungry. So this is also a very important factor. Next, most important and most neglected factor is the mental health of the patient. Preoperatively, each and every patient, we advise them to undergo a psychological evaluation. So a very important psychiatric evaluation is done, and patient is diagnosed with some or the other condition and is put on certain medicines. But later on, after the surgery, the patient never really gets back to a psychiatrist or a psychologist, and they never undergo formal counseling. So here, these patients after surgery develop some sort of symptoms which come with the surgery. So most common is the ADHD. See, if we see attention deficit hyperactive disorder, it's associated with at least 30% people after surgery. So if this is treated accurately, most of the patients who are looking at weight regain may have a weight loss at this particular moment. The frequency of grazing, even if a person is eating twice a week, if he is having grazing symptoms, he ends up having weight regain over a period of few years. See, there are post-operative metabolic disturbances that have been demonstrated, and these are one of the causes for weight regain after bariatric surgery. And also the sharp drops in glucose levels. These are seen with especially bypass patients. They can be one of the causating factors. If we see binge eaters increase their BMI by 5.3 compared to 2.4. So we are looking at a BMI of at least 3%, 3 kilogram per meter square between binge eaters and non-binge eaters. Some patients develop depression, they are addicted to alcohol, drug use, food urges, all these kind of symptoms or addictions which develop post-operatively are also one of the causative factors. So impulsive behavioral traits are associated with weight regain. Patients with psychiatric symptoms, even if there is a single psychiatric symptom, the patients tend to develop weight regain. So even if there is a single psychiatric symptom, it is very important to analyze it and you get it evaluated by a psychiatrist and start appropriate treatment. That can definitely stop this weight regain after bariatric surgery. So what is the treatment? That is cognitive behavioral therapy. This is the most important treatment modality for most of the psychiatric problems after bariatric surgery if a patient is having any of this. Majority of these people who are undergoing surgery, they have some sort of depression. Before surgery, they express it. After surgery, they do have some sort of depression, but they don't express it and they don't get evaluated. So that is one of the very important risk factors where patient starts regaining weight. Physical inactivity, once the patient's BMI drops lower and lower and patient becomes fit enough to move around, he starts feeling that he's healthy and he doesn't require any sort of exercise to maintain his body weight. So this sort of feeling which people have after bariatric surgery once they have lost weight, this is one of the most common factors where they don't feel that they need exercise to lose weight. So that really affects the amount of weight regain that happens after surgery. See, 47, that is roughly 50% of these patients become more active after the surgery, but they don't do enough activities to maintain this weight loss. So coming to pharmacotherapy, what other people can do, what the physicians can do, how they can play a role in maintaining this weight loss after surgery. See, pharmacotherapy, this is one of the largest study. It's done by Stanford. It's a review of 319 patients wherein they have tried more than 14 different medicines. Most common, most helpful medicine was topiramate. So up to 10 to 50 milligram, that was the dosage which they have used. And they have found that topiramate post-operatively, if used in treating these patients, can definitely add to a good amount of weight loss. And also these days, there is a lot of study that's happening on liraglutide and semaglutide. These are the few molecules which are coming up and they are having very good results of weight loss after the surgery. So these are some of the common medicines which are used after surgery, which are associated with weight loss. One is paroxetine. It is most common cause of drug-related weight increase after surgery. And next is, especially when the patient is diabetic and has certain level of higher sugar levels, it should be managed with metformin and GLP-1 analogs rather than insulin, because that can help to maintain the weight loss to a greater extent. And also, if there are high antihypertensive medicines, if they're required, beta blockers should be avoided and these medicines can be used, which can help to promote weight loss. So now coming to surgery-specific factors. See what wrong things can happen with a surgery which can cause weight regain after surgery. See, if you see Roux-en-Y gastric bypass, it is considered as the gold standard for bariatric surgery in treating type 2 diabetes associated with morbid obesity or morbid obesity associated with comorbidities, other comorbidities. So here what happens, we create a stomach pouch and we attach that pouch to the intestine. Slowly and steadily with time, the stomach pouch dilates. So this is most common thing that happens after Roux-en-Y gastric bypass surgery, which is one of the causative factors of weight regain after bariatric surgery. See, stromal dilatation is the most common cause of weight regain. Enlargement of gastric pouch decreases the net restrictive effect of bariatric surgery, of this bypass surgery, and patients start eating more food to feel satiated with the same surgery. So this happens with patients after say 2 to 3 years of surgery, and they slowly start eating more and have weight regain. So what should be done here? See, it is about reduction of GJ size. It's a reduction of gastrojejunostomy size that can really help treat this patient. How to do this? One is endoscopic suturing, next is stapling, next is plication. There are many ways to do it, but endoscopic suturing definitely can help. Without undergoing a surgery, patient can lose then nothing like it. Next common complication associated with gastric bypass is gastrogastric fistula. If there's a fistula formation after this bariatric surgery, patient's main diversion of the meals doesn't happen, and with this gastrogastric fistula, patient easily start regaining weight. In fact, that is one of the main presenting symptoms that patient is not losing weight even after bariatric surgery. Then definitely they should be evaluated. Sleeve gastrectomy, today it is one of the most commonly performed surgeries is sleeve gastrectomy. But the problem with sleeve gastrectomy is it dilates with time, and there is some sort of weight regain that happens with time. So why does a sleeve stretch? It's a very big question. Nobody can answer this question. It's a matter of research, but it definitely dilates with time. So how to identify, do upper GI studies, contrast studies. These are the studies that can help diagnose the sleeve dilatation. Next, we come to revisional surgeries. So what happens if the patient has already regained weight? Then what is the solution? So all this previous pharmacotherapy and everything, they should be done and tried once the patient starts slightly regaining the weight. But once the patient has already regained the weight, then what are the options? Then the option comes to revisional surgery. So revisional surgery, there are different revisions. It all depends on what is the primary surgery and what are the symptoms associated with the patient. So if there's a failed gastric band, we can convert to a Roux-en-Y gastric bypass. Most of the revision surgeries are converting one form of surgery to other. That is, if the initial surgery is a restrictive surgery, converted it to a restrictive plus malabsorptive surgery. So that is how most of the revisions are performed. If we have a failed vertical sleeve gastrectomy, there are two options. One is to re-sleeve the patient or to convert it into a Roux-en-Y gastric bypass. So Roux-en-Y gastric bypass, if it fails, then the real question arises on next what to be done. See, few things which can be done. One is banding the gastric pouch, and next is distalization. Third is conversion to another procedure like mini gastric bypass. So banding the procedures comes with its own risk of band-related complication. Distalization, definitely a workable option, but comes with some sort of more malabsorptive symptoms. So patient has to be definitely monitored very closely. Liberal amount of supplements need to be given to these patients. See, here we can see if the gastric pouch and the candy cane dilates, how to treat it. This is the line which can be used for correction of the surgery, and a simple stapler can be fired across, which can decrease both the pouch size, also the intestinal size. See, this is the concept of distalization, wherein one limb, that is elementary or biliopancreatic limb, can be enlarged and the common channel can be decreased. So decreasing or increasing the elementary or biliopancreatic limb comes with its own consequences. If you increase the biliopancreatic limb, it comes with its own set of malabsorptive symptoms. And if we increase the elementary limb, it comes with, always associated with little bit of chances of weight regain. So in summary, if we see what is the etiology, the etiology is very complex, it's multifactorial. We cannot single-handedly pinpoint what is the cause of weight regain after bariatric surgery. See, approach in managing weight recidivism, it requires a multi-dynamic. It's a multiple people associated multimodality approach. It's not a single person's approach which can really help these patients. See, we have to concentrate on all different patterns that can really help these patients. One is dietary, there is psychological, there is physical. All these factors need to be taken care, and then only we can see good results. See, in patients with weight regain following bariatric surgery, diet, one of the most important factors, it plays like 25% of these people can be treated with a very good diet in itself. Next is physical activity, motivational issues. These are the problems which have to be dealt with. It's not just about doing a second surgery, it's about managing the first surgery in a better way. So these patients who are coming to bariatric surgery centers, they present with a lot of mental health issues. And most of the times these are neglected. So first and foremost, appoint a good psychiatrist in your center, evaluate the patient completely. If there are any sort of psychiatric illnesses, associated with these patients, then they have to be treated pre-operatively as well as post-operatively. Then only we can get a good result out of it. Patients undergoing psychological, dietary, and active counseling. These are the most common things that have to be done. Last comes the surgery. Then we have to find faults in the surgery. If there is anything that was wrong in the first surgery that can cause weight regain. So that we can do by doing upper GI studies, contrast studies. This can give a detailed information about if there is anything wrong in the first surgery. Then we can go in for a correction of that particular part, which can really help the patients to lose the weight. Then concluding, see, bariatric surgery, it's the most common and most effective approach for morbid obesity. Weight recidivism, yes, it is common. It is affecting at least 10 to 20% of the patients after surgery. So how to deal with it? A lot of ways to deal with it. It's not directly jumping onto the second surgery. First, you evaluate the patient. Do a good pre-operative, post-operative counseling that includes the dietary, psychological, physical activities. You have to cover each and everything. Then go for pharmacotherapy. Then start with secondary surgery. That is the revisional surgeries. So underlying etiologies, they are definitely complex, and it is not easy to pinpoint which of the factors are playing the role in weight recidivism. And this is one of the scopes which where people definitely should take interest, that is called as weight recidivism clinic. Weight recidivism clinic are the clinics where patients after surgery can approach if they're having weight related issues again, where complete evaluation can be done and a dedicated center should be developed. So this can really help people who are coming after surgery with some sort of complications. So that should be the end of my talk. Thank you.
Thank you, sir. You have finished 10 minutes before time. So we have time for question answers.
Yeah, definitely. If there's any questions, we'll take it.
Excuse me, sir.
Yeah.
Are there any specific age limitations for bariatric? Supposing a hefty, chubby 10 years boy wants to undergo
the age limitations, as per American Society of ASMBS criteria, it is 18 to 65. 18 years of age is the minimum age, and 65 years of age is the maximum age. But on the upper side, you can definitely stretch. You can definitely operate a 70-year-old man, but not a kid who is below 18 years. Below 18 years, the bony growth is not yet complete. So most of the times it's contraindicated. The only there are some indications wherein the pediatric population can undergo bariatric surgery. Some example is like leptin deficiency syndrome. So there is a syndrome called leptin deficiency. If this leptin is deficient in that particular child, the child doesn't feel satisfied after eating food. So he keeps on feeling hungry and hungry. So even after you have fed him 2 chapatis or 2 rotis, he eats for 20 minutes, he is full, and again he starts feeling hungry. So this is like a hormonal issue. Here, the child's like 4 or 5 years of child reaches a weight of 45-50 kgs. And that can impose a lot of cardiovascular risks to the patient. In these settings, definitely surgery is indicated, not otherwise.
Thank you.
Thank you.
Thank you, sir.
Thank you.
If there are no further questions, I request our chairpersons to felicitate Dr. Vivek Kulkarni. I request our President Dr. Shirke sir and Honorary Secretary Dr. Mrs. Pillai to felicitate our chairpersons. चेअरपर्सन फेलिस्टेट करताय ना ते सगळं इसी नंबरला एक एक कळत सांगायचं
Thank you, everybody, for being with us. That gives us around 8 minutes more to have our lunch than whatever has been declared, half an hour. So we have 8 more minutes. So let's have a nice lunch and gather back again after 38 minutes in this hall again for the next session.
We will be starting sharp at 3 p.m.
किती किचकिच करतात दोघं.
आणि समर्थपत्तीच होते प्रत्येक वेळी आणि केलं. सकाळी एकदा बघत असेल
असेल.
बंद करू नका काय झालं विंडो आणि जी Hello, good afternoon, friends. The lunch time is going to over now. I request all the delegates to come in the hall for the last session. The last session will begin soon. Hello, delegates. Soon we are commencing with the last session. Those who have finished their lunch are requested to come in the hall. काय एक ऑनलाईन आहे डॉक्टर खाडेलकर आणि औरंगाबाद
लास्ट झाला तो पण
नाही कुठे नाही वेट गेन नाही आता शेवट चालला हे होतो ना वेट गेन आफ्टर ब्रेक करायचं दोनच आहे एकच शेवट सेशन आहे एकच आहे ती बसली अनाउन्स करा लोकांना बोलवा काम झाले ना अडकलो तुला
ऑनलाईनच कनेक्ट होणार आहे हो सर ऑनलाईनच कनेक्ट होणार
पहिला ऑनलाईन अनाउन्स कर
लगेच चालू करू
अनाउन्स करायचं नाही लोक येतील ऑलरेडी
Welcome back, everyone. I request all the delegates who are outside to kindly come inside. We will be starting with the session soon. So welcome back, everyone. I know post-lunch it is a little difficult to concentrate, but I'm glad we have people around here. I now request our chairpersons, Dr. Uday Ghate, Dr. Uday Ghate, to kindly come onto the dais. He is a renowned neurosurgeon with 14 years experience in UK. At present, working at the Apex Hospital. Has special interest in brain tumor surgery, pediatric neurosurgery, and complex spine surgery. I now request our second chairperson, Dr. Rajendra Vaitsa, to kindly come onto the dais. He is a senior most executive committee member, senior family physician, and secretary with NIMA Kolhapur. Our first speaker for this session is Dr. Satish Khadilkar, who is with us online.
Hello. Good afternoon, everybody. We will move to the next session, which is on neurology. Our first speaker is Dr. Satish Khadilkar, who is going to give his talk on online. Dr. Khadilkar is currently working as a dean at Bombay Hospital, Mumbai. He is a professor and head Department of Neurology, Bombay Hospital Institute of Medical Sciences. He is ex-professor and head Department of Neurology, Grand Medical College and Judge Hospital, Mumbai. He is a consultant neurologist, Bombay Hospital and Medical Sciences Institute at Mumbai. He was awarded with the Best Teacher Award at Grand Medical College in year 2006 and 2014. I think Dr. Khadilkar doesn't need more introduction because he comes from Sangli and he has done his basic graduation from Government Medical College. So I welcome Dr. Khadilkar for his talk. Dr. Khadilkar, please.
Thank you. Thank you very much for the kind introduction. I think I have been logged into two places. Event Sure is also logged me, and I have also logged. So
Hello.
can we cut
Audio,
out
please.
one?
Audio.
Can we cut out one? Can we? I seem to have logged in two places. So can we cut out this Event Sure Planners login? Hello. Hello. Are you able to hear me?
Yes, we can.
Yeah. There is an echo because I have been logged in two ways. So can they please, or shall I leave and join back?
You can continue, sir.
No, there is a lot of echo that I'm hearing.
Yes.
And that's because I see two logins for me.
1 second, sir. We can.
So if the IT people can take away one of the logins, the echo will go away.
IT, please.
Okay, just wait for a second. I will leave and then join again.
Okay, sir.
Yeah, I think that does it. So is the sound clearer?
No, still there is echo, sir.
No, I think again the same thing has happened. The Event Sure planners also now have logged me in. Is there any IT person listening to this? See, automatically I got logged in. Event Sure and myself. I don't know what is the best option.
Hold on for a second, sir.
Yeah.
Hello. Sir, can you please remove your headphone? That is being suggested by IT people.
Yeah.
Okay.
My headphone.
And if possible, you could take your laptop pin off as well. Laptop pin.
Hello. Actually, you want me to? Okay. Is that better?
Sir, you can remove the headphone and the pin from the laptop as well, please. There's no audio. Can you hear, sir?
Hello. हॅलो. आणि हे तुमचं जे लॉग इन आहे ना ते मला इव्हेंट शुअर प्लॅनर मध्ये पण दिसत आहे. त्याच्यामुळे तो इको येतोय माझ्या मते, कारण दोन ठिकाणी लॉग इन दाखवते ना. मी एकदाच लॉग इन केलंय, मोबाईलवर मी नाही. Huh? हा हा पण त्याच्यावरती आता आता ऐकू येतोय का? हॅलो, आता येत नाही ना? ठीक आहे, ओके. So good afternoon, everyone. And firstly, I would like to compliment Dr. Abaji Shirke, Dr. Aurangabadkar, and the organizing team for arranging this beautiful symposium. And I'm told that it's hybrid, and some speakers have been there and some have spoken online. So compliments to everyone for being able to do this in these difficult times. Now, I will start sharing my screen. Is that okay? Is my screen visible? Hello? Hello, is my screen visible?
Yes, sir.
And am I audible? Is my screen visible, please? Is my screen visible? Am I audible? Then I can start.
Yes, sir, you can start your screen.
Hello?
Visible.
Hello? Hello? हाँ, ठीक है, okay. Right. So the topic I have taken for today is pitfalls in clinical neurology. And even though I have termed it pitfalls in clinical neurology, those are pitfalls that will be applicable to all branches of medicine. So you could say pitfalls in clinical medicine. And I'm going to go case-wise, and I'll show you 7 cases, each one having a message. So the first case is an 18-year-old girl from Uttar Pradesh. She had a 3-year history of unresponsive spells 4 to 5 times a day, which had started after her marriage. In these events, she would fall, she would become unresponsive for a few minutes and rapidly return to normal. So, a young girl, after marriage, the problem started. Many times a day it was happening. Many years it was happening. So, I started examining her. Pulse was 78, regular BP was 110/80, clinical neurology was normal. She came to me with a CT brain and EEG, which was normal. And the husband said, please admit her. Please admit her. And I'm not sure what is happening. Actually, in my mind, I was not sure what is happening, and I thought admission is not required. But because the husband insisted, I admitted. She got 2 events in the ward on the first day, and as so often happens, by the time the nurse went to see her, she had recovered. In the meantime, we processed an MRI and an EEG, which was normal. Whenever you have unresponsive event for which you do not have a neurological explanation, you ask your cardiology colleagues to see. So we made a cardiology consult just before discharge, thinking that this is something non-organic. And while the cardiologist had gone to see her, an attack came while he was at her bedside. So he could observe an attack. And to cut a long story short, what she actually had was dorsa de pontis. As you can see, this was a rhythm in between, and this is what happened to her during the event. So, what is the lesson that I learned from this case? As I started listening to the history, young girl, multiple events, starting after marriage, background of a rural setting, I very quickly made up my mind that this will probably be non-organic. And then I just admitted because the husband wanted me to admit, and I investigated, thinking that everything will be normal, but she actually had such a difficult cardiac condition, and she could have died in any one of those attacks. So I think one of the prejudice in clinical medicine is making up your mind too quickly. As the patient starts telling history, after you practice for 10 years, 15 years, you've seen patterns, your mind slots it into a pattern. And you're so quick about it that sometimes you don't even process the whole data that is being presented to you. Just for the young colleagues who are newly in medicine, the syncope, migraine, and transient ischemic attacks. So here it was a cardiogenic syncope. Syncope, incidentally, is far more common in community than epilepsy. It's about 10 times more common. So I think this is a very, very interesting statement. Intelligence is a slave to beliefs. Written by Arthur Conan, who wrote the Sherlock Holmes character. So what does it say? That once you have made up your mind and you believe that X is the diagnosis, you use all your intelligence to back that diagnosis. Even though you may know that whatever diagnosis you have made may or may not be correct. So you have to use your intelligence intelligently. And in neurology, there are some rules called Fisher and Kaplan and Fisher rules. One of the rules says that once you make a diagnosis, use all your intelligence to prove it wrong before you accept it. So here I made up my mind quickly. I had a belief and I thought that must be it. So this is a very common clinical pitfall. Now, case 2 is an 18-year-old boy who is a member of a dance troupe. He was with friends, slept at 1 a.m. at his house, probably under marijuana effect. At 6 a.m., he was found unconscious and had a left hand. There was a severe brain swelling requiring decompression. And I think those of you who are used to seeing MRI scans, you see how large the infarct is and how angry the infarct is. It sort of pressed things, it's over a very large area, and it's a terrible looking scan. So this patient was admitted, he was comatose for 11 days, gradually regained his sensorium. Of course, his flap had to be removed. Decompression surgery had to be done, as you can see here. And as time went by, the boy had dense flaccid hemiplegia. And whatever you saw angry in the first scan had turned to liquid. A lot of his brain had actually liquefied. So half of the brain, or more than half, was actually gone. Then in between, he developed hypernatremia. The treatment led to another brain swelling. He was again in deep coma for water retention in the dead brain area. You can see the flap now coming out, which was so sunken at that time. So at the end of 3 months, this boy, after having gone through all these torturous things, he was barely understanding anything. He was on Ryle's tube, he was on urinary catheter, he had a total hemiplegia, and he had a bed sore. So at that point in time, I started thinking that we're not going to gain much by continuing to do efforts. And I spoke to the mother. You know how mother's reactions are. She said, "Doctor, at any cost, I'm not letting go. I think this boy is going to become better." So mother refused to believe that the son cannot be revived. And her reason was she thought that she gets dreams that he will recover. So I also didn't think that he will recover. But we embarked on a process of rehabilitation and took expert help. And again, to cut a long story short, 3 months later, the boy was able to walk, meaningfully interact, and speak. So here is a boy who is living on only half the brain, terrible clinical condition. The consultant and everybody saying, look, probably it won't work. Mother saying, let's continue for a while longer. And the boy gradually making meaningful recovery. So the lesson 2 from this case is that in chronic diseases, we often let go of the situations that look adverse. Our mind decides, okay, this I don't think is going to improve. So, okay, you take a round every day, but you know that in your mind that it's not going to improve. But this case teaches us that some such people on whom you have given up will improve, either naturally or willfully or with medical efforts. And this is how actually doctors make their reputation. So never let go. 1 out of 10 cases that look hopeless will improve under your care. And I think those patients, you owe that to them, to continue to work on them, whatever the situation. That's an interesting quote at the bottom of the slide. A doctor's reputation is made by the number of important men who die under his care. He is big, so they have nowhere else to go. Right, the case 3. This is a 59-year-old tax consultant who was diabetic, hypertensive, and hypothyroid. He developed giddiness spells for 3 days. They were brief. Things were going round and round. He had nausea, vomiting, and some limb tingling. Now, giddiness is one symptom where patients interpret them so freely, starting from weakness to sensory changes to imbalance, everything becomes giddiness, chakkar. So you have to actually analyze what a chakkar is. And here there were brief rotation spells with nausea, vomiting, and tingling of the limbs. So he saw the family doctor. Family doctor said, "Tumko vertigo ho gaya hai. Take Kmacon, you will be all right." He didn't get better. Went back to the doctor. The doctor said, "Look, you may have spondylosis." That's another very common thing in clinical practice, that people who have vertigo are told that they will have spondylosis. So most neurologists believe that spondylosis can't give rise to brief rotatory spells. So he did an X-ray, and as you know, after the age of 35, 40, all X-rays will show spondylosis. So it showed spondylosis, and I said, "Look, I told you this is spondylosis. Start using a collar." So from taking Kmacon, the man started now using cervical collar. He was still giddy. And he said, "Okay, if you're not getting better, you see a ENT doctor." The ENT doctor saw him, cleaned the ear, did the audiometry, changed the medicines, but the man was not better. Now, during 1 or 2 of his events, the eyesight also started giving him trouble. He was seeing double. But, he was being seen by one doctor, second doctor, third doctor. This bit of history, either he didn't tell anyone or no one took cognizance of that history. Then the family doctor said, "Look, ENT also is not able to help you. See a neurologist." That is the common story of patients with vertigo. Family doctor, orthopedic person, ENT person, neurologist. And neurologists in most towns of India are very busy and he couldn't give an appointment. So in the meantime, the family thought, let us try homeopathy because the neurologist appointment is coming. And before the neurologist could see him, he had to be admitted. He became comatose. He became quadriplegic. And as you see the top pictures, he had a basilar artery occlusion and he had large infarcts in the brainstem and then subsequently in the occipital region. So this case is one very interesting case, and I've been using this in many of my presentations. See, at one end, we are told that common things are common. India is a poor country. Please don't get patients investigated more than necessary. Try and do without tests as much as possible. And 90% of the vertigos will go away, whether you treat them with whatever you want to treat them or you don't want to treat them. Naturally also they'll go away. because they link with comparatively simpler reasons of the inner ear. But there will be that one patient who has a stroke, which kills him, like you have seen in this patient. So while common things are common and uncommon things are uncommon, as good doctors, we are supposed to pick out the common things as well as not miss the uncommon things. And that is something that requires a lot of understanding of the process of medicine. And in this case, we have to understand the red flags. Also, I think practicing for many years now, I've also developed this feeling that just like you should know and you should be taught what is most common, you should be taught and you should know what is the most dangerous disease causing that symptom. Now, for example, if somebody comes to me with vertigo, and I analyze the vertigo between central and peripheral vertigo and looks like peripheral vertigo, and we sort of do the various tests that you can do by the bedside and they favor peripheral vertigo, I still would be happier to get an MR angio to look at the various vessels. I do not want to miss that 1%. Now, somebody will argue and say, for that 1%, you're going to do 99 MRIs that are not going to show anything. So you have to decide. Are you prepared to take 99 normal MRIs and save one fellow from death? Or are you going to straighten your collar and say, look, I don't do tests? So I think here all of us will be different. But I think somewhere to the general practitioners, it must be taught, like what is the most common disease symptom or what is the common disease giving that symptom? And in the same breath, which is the most dangerous disease giving that symptom, which can really harm and reduce the quality of life. Flags in vertigo, persistent vertigo. Vertigo accompanied with other neurological symptoms like diplopia, dysarthria, ataxia. That is neurological vertigo. And neurological vertigo spells trouble. There will be vascular, demyelinating, neoplastic, something or the other that will need evaluation and treatment. Also, I think we have to be aware of various phenomena which are labeled as vertigo, because if you don't analyze them, you will not be able to treat them. Example I've given here is postural hypotension. Time and again, you must have seen diabetic individuals who come to you and say, I have an imbalance problem. I can't walk very well. I can't stand very well. And what they actually have is a severe neuropathy with sensory inputs from the feet being affected, and also the diabetic autonomic neuropathy with postural fall. So red flags in vertigo, we should all know it's a very common symptom. So in the third case, I have elucidated the clinician's dilemma. Good clinicians ask for few tests, but they cannot miss the uncommon diagnosis. Case 4, I was looking after a child who had frequent falls, difficulty in running and rising from the ground since the age of 5 years. His CK was 19,000, EMG was myopathic, and there was a deletion in the XP21 gene at 45 to 52. So the child had Duchenne muscular dystrophy. The child also had café-au-lait spots. So patient was under follow-up. The mother remarried, had a child from the second marriage, and the child had Down syndrome. So all the attention of the family went to the second child, and the first child keeping the mouth open. An ENT surgeon was consulted. He gave various treatments and finally said, look, tonsils need to be removed. So the family saw me for preoperative fitness. Because the boy had café-au-lait spots and he was going to undergo general anesthesia, I thought it would be better to ask for an MRI scan. The next thing was, I got a call from the mother that the child has been diagnosed on MRI as with a dangerous type of encephalitis and is admitted to local hospital, and he was being given dexamethasone and acyclovir. So I phoned the treating physician and said, how's the child? So the pediatrician said, the child is all right, but the MRI is terrible, doctor. I think we have got him in at the right time. So I asked for the MRI, and this is what the MRI showed. Now, this MRI actually shows the classic changes of FASS that you see in neurofibromatosis. So the child had two diseases, Duchenne muscular dystrophy and neurofibromatosis. And the neurofibromatosis produced these MRI changes, which were interpreted by the radiologist as encephalitis with basal ganglial changes. Now, I spoke to the radiologist. The radiologist was in Chennai. The center was in Ghatkopar, where the MRI was done. I was in Marine Lines, and there was absolutely no coordination at all. The radiologist said I was given no history. That's again a tremendous problem, the correlation between various branches. And here the child almost suffered till we had to say, okay, look, get out of the hospital. This is not encephalitis. So the lesson 4 is reliance on tests and lack of coordination. When the pediatrics doctor saw the child and then saw the MRI, he should have had these thoughts. I mean, why is the child all right if the MRI is terrible? So lesson 4 in modern times, we rely too much on tests and we lack coordination, particularly between clinicians and the various tests that we order. Case 5 is very interesting. This lady with a medical background came to me and said that I've got ptosis and I've got myasthenia. You know, nowadays, sometimes people come and tell you that they have a diagnosis because they've read Google, they have seen people. So she said, I've got myasthenia, I've read, everything fits. Please test me. So I tested her. She had ptosis. AChR antibody negative, decrement negative, neostigmine test was positive. Meaning what? You gave neostigmine, the ptosis went away. So she was going on and off with the diagnosis of query myasthenia. Once she came in the casualty and said, I am in crisis. So I saw that she was very breathless and one eye ptosis like thing was there. So I didn't give her neostigmine, I gave her this and she became all right. She thanked me. But then she said, I'm very worried now that because one crisis like event has come, I want to see a senior neurologist. So she saw my teacher, Professor Noshirwadia, who was also not sure about the diagnosis, sent her to the hospital and told the registrar, do a neostigmine test, but don't give neostigmine. So the young boy did it and told the patient, look, you become better, I gave you only one. So she blew up. She came back to me and said, look, doctor, I'm going to follow up with you because you seem to understand my problem. So over a period of next few years, 2 occasions I tested her completely. She came negative. AChR antibodies were negative. Thymoma was not there. And there was this sort of a response to the neostigmine test. Then one day she and her husband appeared and said, I want thymectomy because the myasthenia is not going away. And I've identified a surgeon in Australia and I want him to get me operated. So, I mean, by the time I had understood that it's a middle class situation, why, I mean, surgery in Australia is going to cost so much? So many good people do it in India. So I was puzzled. So I spoke to the husband and said, what about finances? And he was a very doting husband. He said, look, I will do everything to get my wife cured and I'll take her to Australia. And then while talking, she said, look, I'm not afraid of surgeries. I've had 11 of them. I've had 11 of them? Why? So I went into the details and there was this umbilical hernia, then there was this incisional hernia, then there was this, there was that. So it looked as if for a lot of surgeries, there was no good reason. Was this Munchausen syndrome? So we said, please don't get the thymectomy done. We'll wait for a while. Then as luck would have it, she was hit by a taxi. and she had an acetabular fracture and she had to be operated. Every nursing home nearby refused her because it was myasthenia. She had the level of myasthenia. So we had to take her in Bombay hospital and very carefully look at everything, and it was treated. After that, the myasthenia remitted because she probably knew that how much trouble comes her way. No one admits her. So things improved. After a long time of years, I didn't hear anything from her. And then she came with diplopia and ptosis, pain in the eyeball. And to cut a long story short, the eyeball was protruding. There was a lesion in the cavernous sinus. There was a lesion in other part of the meninges, which turned out to be a lymphoma. So I've shown you a case which has taken lots of turns, and the problems have been initially in the mind, thought to be a disease, Munchausen-like possibilities, and then she actually lands up with an organic disease, which was a lymphoreticular malignancy. So the difference between brain and mind is arbitrary. We have to, every time such a patient comes with a symptom, you have to evaluate him or her fully before you make up your mind as to what is happening. Now, case 6 is a 22-year-old man who walked into my consulting room with a scissoring gait. Because he was scissoring, neurologists are taught that as soon as the patient starts coming into your room, your diagnostic acumen should start. So I said, aha, scissors gait, pyramidal dysfunction, young boy, HSP probably. So he came in, hello doctor, how are you? I said, okay, how are you? How long have you had this walking difficulty? He said, oh doctor, many years. Not only me, but my father and my uncle also walk like this. It's in my family. I said, okay, this looks like HSP. So, in medical training, there is a certain joy and sense of victory about achieving a diagnosis. Because unless you have a diagnosis, you can't have good therapy. So here, there was a rare disease, but it was coming to me very easily. He walked like that. He said that my father and they walk like this. So I actually took him by the bedside, made sure that there is a pyramidal dysfunction, checked one or two other things. And I brought him back. And I was going to start writing the antispasticity drugs. Then the boy said, doctor, I know that I have this, but I have come for my headaches. So see how the diagnostician in me was enamored by the gait and the stance and blah, 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 and was happy to reach the point of diagnosis. But the patient was here for a completely different set of symptoms. He knew that this rare disease exists in him, but he was here because something else was happening. So I think the lesson 6 is diagnostician and therapeutician. We are all bright people as we take medicine. So we think that we are young Einsteins. We are enamored by the uncommon, mysterious aspects of the disease and proud to diagnose them. But our actual job is to manage common conditions well and give relief to the distressed bodies and minds with our medicines and words. This dichotomy, being enamored by the diagnosis, vis-a-vis doing ordinary work well, is a source of errors and unhappiness to us and our patients. So lesson 6 is diagnostician and therapeutician. And the last case was a 19-year-old boy, the only child of his parents, got admitted with me having suffered severe herpes encephalitis. We worked very hard on the case. The parents were trusting. We did everything that we could do, but the boy deteriorated. And whatever I could do, the boy was not doing well. I found that I was going to his bedside 3 times a day, every time going through everything, spending 40, 50 minutes every time. And then talking to the family. So the boy was not doing well, and I was so completely engrossed in what more can I do, what more can I do. In fact, my houseman, the senior registrar at that time, she said, sir, what's wrong with you? Why are you asking again and again about what you can do? We've done everything. Now, if he doesn't do well, he doesn't do well. I said, look, you won't understand. Kept on looking at the whole scenario again and again. the boy got worse and worse. And I kept rerunning the sequence of my therapy plans over in my mind and tried to search again and again whether I could have done anything better. The boy died. I felt miserable. In fact, the family was seeing what we were doing. They were very comfortable. They actually thanked me for all that was done. But I wasn't comfortable. I kept on thinking, he is the only son, they're taking the body home. What will the parents do? How will they live? So I was practically leading their life rather than my life. So I think the lesson 7 is boundaries of medicine. While you have to be involved to be able to do your job well, you cannot go to a point where you are not living your life, you're living their life, as happened to me in this particular case. So I think even though we all feel for our patients, we want to do our best for our patients, I think we have to all learn the spiritual teachings of detached attachment. You're attached to what you should do. You should be detached to the final outcome. So in some ways, it is like karmanye vadikaraste mam phaleshu kadachana. You want to do your best. You have a right to what you can do. You have no right over what happens later. So I leave you, I've shown you 7 cases which give you various hints as to where are the pitfalls and what can one do. So I'll leave you with this picture. The disciple asking the guru, proper for a monk to use an email? Or the guru says, as long as there are no attachments. Ladies and gentlemen, thank you very much. Let me again show you the picture of Professor S.V. Sotur, who was my teacher in MD medicine, and a lot of you know him. He's a tremendous clinic in that area. And I must very proudly say that wherever in the world I went, after learning MD medicine from Professor Sotur, I never felt the deficiency. Such was his greatness and dedication. And what I put by the side is a hammer that he gave me when I got neurology. And very interestingly, that hammer has still stayed with me, even though I've changed hospitals, I've changed countries, I've changed everything, but the hammer has stayed with me. So my respects to my teacher, Professor S.V. Sotur. Thank you very much for the attention. Thank you very much for asking me to be here. It's a very nice experience when friends call you. Thank you, Dr. Abaji. Thank you, everyone. And I'll leave you at that. If there are any questions that you want me to take, I'm quite open to taking questions. Thank you very much.
Sir, it was a very nice and very clear lecture. Are we going to take any questions or any questions from audience?
I'm somehow not able to hear any sounds. I don't know why.
Mike. Hello.
I'm actually unable to hear any one of you.
So there is a question.
I don't know what is the problem. Are the IT people there? I can't hear any sound.
Good done, sir. Sir, I have a question regarding case number 2. The case has a huge impact. He has a frank hemiplegia and the bed sores. Patient looks to be in a critical condition. Mother has a tremendous hope for recovery. Your medicine and everything helps and the patient recovered and start walking. So it is you say the credit goes to the medical treatment and the nature. But can you believe, sir, in some miracles, willpower, strength of the mothers, that would have helped him to have such a miracle results to happen. Can you believe in such things, sir? Supernatural power. something different that helps in such a situation. Science may not believe, we may not believe such sorts of recovery in such a form.
Audience sound का येत नहीं है वाला.
Am I audible, sir?
Okay.
Am I audible, sir?
Okay.
I'm not audible, sir. Okay, sir. Okay, sir.
I think we should go ahead with the next session.
Hello.
Hello.
Good afternoon. We come to the last speaker of this conference.
Okay.
Dr. Kaustubh Aurangabadkar. His topic will be recent advances in stroke care. He is Dean Neurology, Director, Department of Neurology, Diamond Super Specialty Hospital, Kolhapur. His qualifications, he did his MBBS from Nashik Medical College. He is DNB from NBA, New Delhi. DM Neurology from All India Institute of Medical Science, New Delhi. He has many awards. The important ones are ML Soni Award for Best Outgoing Postgraduate in Neurology at AIMS, co-author. Cranial Neuropathies. API Textbook of Medicine, 7th edition, 2007. I request Dr. Kaustubh to proceed with this speech. Thank you.
म्हणून सगळ्यांनी सांगितलं.
Good afternoon, everyone. I think it's a very lengthy day. And now, since I'm the last speaker, I'm going to use this opportunity to speak a little more. I hope I'm not going to burden you. First of all, let me thank the organizers for giving me this opportunity to have some words on recent advances in acute stroke treatment. I am going to restrict to only ischemic stroke, and my wisdom allows me to cover only first 24 hours in the management of acute stroke. So when actually I decided to join neurology, a friend of mine asked me, "Bhaiya, ye neurology mein kuch hai kya? Are there any more drugs in neurology than your Dexona, Mannitol and Neurobion?" I was a little puzzled whether I should be really pursuing neurology or no. But then I realized that since my degree in neurology has probably seen the maximum changes in its understanding, management, and we are definitely becoming little frenzy about everything. Seeing development of a lot of new subspecialties like epilepsy surgeries and strokes and headaches and muscular disorders and immunological disorders and whatnot. But the trouble in our country and especially in cities like Kolhapur is how are we going to make it easily available, affordable, and more than that, how is it going to be accessible to everyone? Now, this is a favorite slide of mine. I'm taking an example of a person who has had a large anterior circulation stroke in the supratentorial area. And it is a surprise to see what is happening. Now, if you actually talk of a stroke, you are losing 7,140 kilometers of myelinated fibers in one single stroke. And if it is a large stroke, then probably your age is accelerated by 36 years, not 1 or 2. It is 36 years. And if you actually talk of per second ongoing ischemia, you become old by 8.7 hours. Such is the magnitude of a large anterior circulation stroke. Losing 7,140 kilometers is like reaching to maybe US from Mumbai. And losing a single second is you are getting old by 8.7 hours. Actual change in the management of acute stroke started way back in 1995. This was a landmark paper which appeared in New England Journal of Medicine. And this is when the NINDS trial of acute stroke came out with a TPA in first 3 hours. So only thing which I want to say here is that first 3 hours and 1995. And now what has happened in 2020? It took one full Vanvas and another year of Ajñatvas, 1995 to 2008, 13 years for extension of window by 1.5 hours. 13 years it took for the science to extend the window of acute stroke. Same drug, same molecule, same company. You imagine how many people were deprived of getting the proper treatment for the sake of 1.5 hours, 90 minutes. What could have happened if those people were given appropriate drugs in 1995? Nobody knows this. Unfortunately, what has not changed in last 25 years? These are the things which remain same. We still don't seem to be thrombolizing our patients. The majority of patients who receive these drugs have a DTN time of more than 60 minutes. What is DTN time? Is door to needle time. We take 60 minutes to administer an injection which may take a minute. We do a lot of efforts to overcome these delays, and probably lesser the time to administer this drug, better is going to be the recovery. The fact is that in India, only about 3% of the acute stroke patients receive IV thrombolysis. Only 3% of patients. And in those who receive this thrombolysis, the delay even after coming to hospital is more than 60 minutes. 2/3 of patients, the delay is more than 60 minutes. Why? Let's see what are the reasons. Patients don't come in your time. Maybe the drugs are not available at your place. There is an in-hospital delay for whatever reasons. This is not available and that is not available. And we are not coordinating our efforts with our colleagues to fasten this time of doing various sorts of fancy investigation. And sometimes we don't even find a CT scan machine available in the near vicinity. You call the center and then the ambulance driver will come and then your ward boy will come and then the stretcher would be mobilized, so on and so forth. The only thing which I would like to insist upon here is the improvement of pre and in-hospital procedures can increase the number of patients who receive this appropriate treatment in appropriate time. This is the company statistics. In India, we have this habit of talking about things what happen in US and what happens in UK, this and that. We get about 15 lakh strokes per year, every year. And it means that we have about 4,000 strokes in India per day. Surprisingly, in 2019, the number of thrombolysis which were done increased by 30%. Share market also did not give this much of result. But from 13,500, the number of thrombolysis increased, say, by 5,000 in 2019. Despite of this, less than 1,000 interventional procedures were done. So we are able to do more thrombolysis, but the number of mechanical things or the intravascular things still are less than 5%. Let's see what are the reasons and what can we do about it. I think this would be the best way to tell people that these are the symptoms of stroke. You have to make these kind of awareness programs on rickshaw or on bus, or whatever. This is being floridly done in places like, of course, this is a Maharashtra bus, but this has been a pioneer thing which is going on in states like Karnataka and in Delhi. People basically do not understand the symptoms of stroke. They need to understand what is a stroke and what needs to be done for it. And even though a patient comes to the hospital in a given time, the hospital itself has its own unique set of drawbacks. And overcoming these so-called drawbacks or mental hurdles is the only thing which will make the hospital what is so-called as a stroke-ready hospital. Whatever I have said, these are all evidence-based things. And so far, whatever is being said, like promoting the programs in public, making your hospital ready, establishing stroke units, is a class 1A proven therapy for improvement in the stroke outcomes. And this is terrible. A poor ambulance is stuck up in this bad traffic, and we are talking about getting old every second by 8.7 hours. It is very important that the message spreads across. In this respect, an important short communication was published in renowned journals. It's a European journal, and it just compared the effects of emergency medical service transport on acute stroke system. So they compared people who are coming via ambulance, and they compared people who are reaching by their own vehicles for acute stroke. So if your ambulance is bringing you to hospital, there is a 5 times more chance that you would be thrombolized in a time and you would do well. As compared with self-transport, emergency medical transport was independently associated with a better chance of getting thrombolized. So by whatever means, जो भी आएगा उसको thrombolize ठोकना चाहिए in an appropriate time. There are people who are doing thrombolysis in the door of the hospital itself, and for that, what they are doing, they have improved their pre-notification systems. They evaluate, stabilize, and quickly transport. And there are places who are doing these kind of aggressive therapies in the CT scan machine itself. And even if you come in time, people keep struggling. Kahan hai aapka emergency room? So these are the directions of reaching the center. Shouldn't be happening. You should have your slots right at your door. People should be ready to receive these patients. Otherwise, they will be carried by 4 people on their head. And this is a slide which I like the most. It's not one person's job. It is not that the treating neurologist is going to welcome the patient in the door. No, it's going to be the team. It's going to be the team, and it's going to be the team which will definitely improve the feature of stroke thrombolysis. अब बंदा तो आ गया आपके दरवाजे पे, आप क्या करोगे? We've read so many articles. CT is better than MR. MR is better than CT. What if it is a tumor? What if it is an encephalitis? क्या करोगे? Puzzled. Should I do a MR? Should I do a CT? Should I do a CT? Or should I do a MR angio? No confusion. CT is always preferred to an MRI. Even if you do a wrong thrombolysis in a wrong diagnosis, it's probably not going to be harmful, provided your intentions are good. CT and MR angio has to be done if your NIHSS is more than 6. And intervention is not going to be possible without having a clear vascular imaging. Now, this is also an important topic which I am going to discuss in next few slides. How am I going to treat a patient who wakes up with stroke? There is a tremendous increase in the understanding of these strokes who wake up and develop stroke, and in those who actually they don't know when the exact time of stroke has happened. Very often we consider that when the patient was last seen normal, we consider it as the time of development of stroke. If you sleep at 10 o'clock and at 6 o'clock, if you know that your patient has developed a stroke, you are puzzled whether this patient is to be thrombolized or no. So there are developments in this aspect also. And the icing on the cake is that now people are thrombolizing even after 24 hours. How are they doing it, and can we do it? Before I proceed further, the most important thing is that we should rule out a bleed or a subarachnoid hemorrhage. So a CT would very confidently tell us you can see these kind of subtle imaging abnormalities which would certainly evolve. This is what is called as sulcal effacement. A physician needs to be familiar with these CT findings. Sometimes you will see the hypodensity in the basal ganglia, which could be a evolving stroke. And there are several other signs like this insular ribbon sign and thrombosed MCA sign. This is a dot MCA sign. And this is what an MR would look after a few hours. And you see such an evolving hypodensity in a CT scan. Thrombosed basilar to demonstrate a few more. So when symptoms are yet not resolved, brain imaging still is the 1A indication prior to initiating therapy. It gives you adequate information. The revised criteria say that if you are planning a thrombolysis, consider CT, CT, and CT. If you are having a large stroke, proceed with a vascular imaging. So those who are not having any evidence of bleed, when you are clinically sure that it is an ischemic stroke, patient is more than 18 years, you should consider thrombolysis if the patient is less than 4.5 hours. Now I have stretched you from 3 hours to 4.5 hours. Exclusion of thrombolysis, all of you are familiar with this. There are a couple of new developments in exclusion of thrombolysis. We are worried if the patient is on oral anticoagulation. So all those who are on anticoagulation need not be deprived from given IV thrombolysis. You can have a quick PT, and if the INR is less than 1.7, you can still consider doing in thrombolysis. If your patient is hypoglycemic, don't thrombolize. If you have an active bleeding platelet count of less than 1 lakh, are we really sure that our lab comes so early? You want to send the blood and that mama is not available, Maushi is not available, your technician comes after 15 minutes. So I think we should do it without wasting time unless you are clinically seriously suspecting that the patient is going to have low platelets, etc. Now, there are several questions which are asked, and I think this is a real advance in management of stroke. Jitna jaldi hai, utna de dene ka. There is no question about this. Should I be doing it in elderly? We had a patient who was 97 years old, lady, and she was fine. We insisted on that thrombolysis should be done. She benefited. Larger stroke, thrombolize. It is going to benefit. Atrial fibrillation, give thrombolysis. Heart failure, give thrombolysis. So you ask anything, thrombolysis is beneficial. Just be careful in patients, those who are on newer anticoagulants, because there is insufficient evidence what is to be done in these kind of patients. And rarely you are going to face this music of having a brain hemorrhage post thrombolysis. So a written, documented, nowadays video consent also is worth taken before you actually consider thrombolysis. The patient may bleed because of thrombolysis. The risk of major bleed is not more than 1%. Now this is a new kid on the block. This is tenecteplase. It is more specific clot binder. It has probably a greater efficacy in large vessel occlusions. It is to be given as an IV bolus. You don't have to waste 1 hour like actylase. And there are trials who have shown the benefits. The cost is very less, 1/3 of the cost of actylase. And it is approved for use in India 2016. Till 2019, we had about 5,000 cases. The data needs to be analyzed. The dose is 0.2 to 0.4 milligram. So the guidelines said that it can be administered in a dose of 0.4 milligram. It is to be considered as alternative to alteplase. It did not prove superior, but also it was non-inferior. So maybe as equal. It is to be used in a dose of 0.4 milligram when there is a large vessel occlusion. A slightly lesser dose can be considered in patients who are planned for mechanical thrombolytics. Lot of things have happened after 2015. The big thing was mechanical thrombectomy with stent retrievers for large vessel occlusions, especially for intracranial ICS and first segment of MCA. People are trying to do it in posterior circulation, and this thing has definitely changed the magnitude of thrombolysis, what's called as Dawn trial. They actually estimated the core of infarct with large deficits and penumbra imaging. So up to 6 hours. Now I've gone beyond 4 or 5 hours, and now I am in 6 hours. So 1, 2, 3, 4, 5, 6, 7 trials, and they showed very significant results. The most important thing is that look at the number needed to treat. You actually need to treat 90 patients if you are using aspirin. The number comes down to 60 if you use clopidogrel. The number for actylase is 13, and look at the number 4. This is for one improvement. So Why did this trial succeed? They all used new devices and they used very advanced imaging protocols. They significantly helped to confirm the presence of an occlusion, and they also helped to assess parenchyma and penumbra. Those are the examples of few newer stents and retrievers. The fashionable one is this penumbra, an expensive one. This is what is solitaire, and this is what is mercy. And if you actually look at the clot burden, and if you actually look at the devastation which it causes, such a little amount of blood, and then it screws your happiness. This is with the stent-guided clot retrievation. So who is to be considered for mechanical thrombectomy? This is class 1A indication that patient should have a low modified Ranskin scale. There has to be a large vessel occlusion. Patient should be more than 18 and these kind of scores. And most importantly, the treatment should be initiated within 6 hours of symptom onset. That your intervention man has to be available at your disposal within first 6 hours. Same holds true for the direct aspiration thrombectomy. It is non-inferior to the stent retrievers. Same criteria. The benefits are not certain in the M2 segments of MCA and MCA third segment. I'm talking of intracranial vessels. So proven beyond doubt in the neck vessels, proven beyond doubt in the first MCAs. And the same holds true for vertebral arteries and posterior cerebral arteries. Now this is where the things are really moving fast. Now let's take example of this case. This is a blocked MCA. You can easily see that this is blocked. There are good distal collaterals. And patient has a low score. He is just paretic, maybe just not able to use his grip and has a settled dysarthria. So after CT angiography, patient has to be directly taken for DSA. It's a blocked MCA. You are fortunately seeing some meningeal collaterals. So blood is reaching this area via here and there. And this is the impact of an intra-arterial thrombolysis in the M1 segment of MCA. Complete opening of the MCA. You're not seeing any ACA, you're not seeing MCA. Beautifully demonstrated in this. And a very tiny infarct, patient improving completely. Patient thrombolized, I think, in 6 hours of the onset of symptoms. So these are the steps which are necessary. CT scan negative, give IV TPA, do a CT angiography, demonstrate that there is a block, also demonstrate that there is a low perfusion, but no infarct. So brain tissue is still viable. Directly take the patient to the lab, do a DSA, get out of the clot, and improve his vessels. Excellent outcomes. If done in 60 minutes, patient is likely to be as normal as possible. I hope you are a little more patient. I won't take more than 5 or 7 minutes. But this is an important thing. It can happen with any of us. What is to be done in those who wake up with stroke? 6 o'clock, somebody tries to wake up an older man. He's not moving one of the sides. 2 वाजता रात्री उठले होते, maybe he went for a loo and came back. So we don't know when stroke happened, whether it was at 2 o'clock in the night or whether it was 2:30 or whether it was 5:59. The patients did not receive any thrombolytic therapy. They look at the number of population, they constitute almost 25% of total strokes. Interesting. In these patients, a recent trial showed that if you are able to demonstrate a diffusion and flare mismatch, these sequences do not take more than 5 minutes. These are the patients who should be aggressively thrombolized. Last trial in 2018, I think around 90 patients showed a very significant improvement in the outcome of these patients at a slightly larger risk of having intracranial hemorrhage than a second line medical treatment. And what do I mean by diffusion flare mismatch? Don't want to go into the technicalities of these MRI sequences. This looks white. This is a diffusion weighted image. This is a flare image. There is no corresponding abnormality seen on the flare image. So this area of the brain is still salvageable, not more than 5 minutes sequences. On the contrary, if you see here, there is a diffusion abnormality, here there is a flare abnormality. So diffusion and flare match, diffusion and flare mismatch. So those who are diffusion and flare mismatch, whether they are awake strokes or whether they are strokes in a patient who doesn't know when exactly the stroke happened, these are the patients who are to be considered for thrombolysis. They should be considered for IV thrombolysis if the infarct volume is not more and there are no major changes on flare. So refining the therapeutic window for acute reperfusion therapy, the golden dictum is that early time, poor collaterals, the outcome is going to be poor. The patient is going to progress fast. Even if you are late, but there are good collaterals, try and do thrombolysis. Now my train has moved from 6 hours to 9 hours. This is 2019. This time window is sophisticatedly being increased because with newer techniques, you are able to demonstrate that some of the brain could still be salvaged. And how is that possible? Now look at, again, a blocked MCA. This is a cerebral blood flow image. Compare it to the opposite side. Ye laal hai, ye neela hai. Simple. So whatever is blue, the perfusion is impaired, but what you have done is that you have calculated the CBV, cerebral blood volume. Here you have demonstrated that this is a perfusion mismatch, but the cerebral blood volume is still preserved. So it means that the brain tissue is still not infarcted. It's a very ideal candidate for a DSA, blocked MCA, poorly perfused ACA. This is how the things have been done. Patient has received an intraarterial thrombolysis, very tiny infarct. Now you have to look at this infarct and you have to look at this possible amount of infarction which could have happened in the brain if the procedure wouldn't have been done in time. So this is the beauty of advances in imaging, and this is what is called as vascular imaging of the brain. So what is to be done in those who are in between 4.5 to 9 hours? You have a CT or MR perfusion core and penumbra mismatch, and for whom mechanical thrombectomy is not planned, we should seriously consider IV thrombolysis. And if you're still without advanced imaging, then probably there is no point in doing thrombolysis. So to extend this window period from 4.5 to 9 hours, you have to, by means of advanced vascular imaging, show that the brain tissue is salvageable. Now my train has moved up from 6 hours to 24 hours. And first 13 years, the train moved by only 1.5 hours. It was probably moving at a very passenger speed. And last 4 hours, we have moved from 4.5 hours to 24 hours. Is it not fascinating? And that is why the stroke specialty is developing so fast. I'm not going into the depth of Dawn trial, but this is what is the take-home message. That if you have a large clinical stroke and the score is more than 10, meaning that there is a large vessel occlusion, but your MRI is showing a very small infarct, less than 20 cc. They calculate it by various measures. And even if your patient is more than 80 years old, you should consider a mechanical thrombectomy. Less than 80, up to 30 cc core, still consider mechanical thrombectomy. And even if the patient has a large stroke, still consider mechanical thrombectomy, but the guideline is that not more than 50 cc of infarct volume. 206 patients. We have done only 2 in Kolhapur. 206 patients done in 6 months, multicentric trial. And the moral of the 2 more minutes, madam. 6 to 16 hours of last known normal time, a large vessel occlusion, 1A indication that mechanical thrombectomy is indicated. 1A indication, proven, helpful, no harm. 16 to 24 hours, the anterior circulation MT is reasonable. So it is still worth considering it beyond 16 hours. One of the patients, fortunately, the intervention man was around had come in the window period, blocked right MCA, very minor stroke, walked in patient, no infarct on CT, directly taken for DSA. This is a microcatheter angio. 2 milligram of Actylase intraarterial, vessel is still not open. 5 milligrams of Actylase, and you can see some improvement in the blood flow. And this is after maximum 8 milligram of Actylase. This is what is the maximum permissible dose. You can easily see the complete opening of the MC. Patient walked home. This was our first patient. We did about 2 years ago. And another patient which we did was a mechanical thrombolysis, posterior circulation stroke, tiny pontine infarct, probably deteriorating, blocked top of the basilar. This is what is the normal anatomy. Here you are seeing a normal blood flow. These are all posterior cerebrals. Here you are seeing the blocked basilar. Microcatheter inserted, some opening, and this is what is the clot removed after a stent retriever. The best development in my opinion is formation of these so-called WhatsApp stroke groups. Most of the neurologists and physicians are member of these groups. They discuss about 5 to 7 scans per day. The difficult thrombolysis cases are discussed in no time. Many physicians in remote areas have been given access with stroke experts all over the country. And this is not my case. This case happened about 200 kilometers in the interior from Pune. She's an 8 months pregnant lady presented with acute ischemic stroke. She was successfully thrombolized and she delivered after full recovery, normally, successfully, the twins. I think this is what is the magic of development of technology. This is what is the development of appropriate accesses. And this is what I see in another 5 years. I would have never imagined that beyond, let's say, last 10 years, I would be walking with WhatsApp and accessing this scan and giving advices. But this is probably already started in countries like Sweden and Netherlands. This is what is the mobile stroke unit. Things are done here and here itself. And they say that we are able to discharge patients in, say, 48 hours. I think I'll not take more time. I have many things to discuss, but this is where I will stop. We have been aggressively doing the stroke management at our hospital. I have done about 320 thrombolysis in last maybe 15 years. Would say that 2 to 3% patients have not done well, but most of them are walking. My youngest patient is 19 years and my oldest is 97 years. So I thank you again all for your patient hearing. I hope it was throwing some more light. I have dragged my train beyond 3 hours to 24 hours. And I'm sure in another 5 to 10 years, we would be having mobile stroke units in even our country. Thank you very much again.
Thank you, sir, for enlightening us. I request our chairpersons to kindly felicitate Dr. Kaustu. I also request our dignitaries and the delegates to kindly remain seated as we will be having the valedictory function now and we want all of you all to be present. Please remain seated. Thank you. I now request our President and Secretary, Dr. Abasaheb Shirke and Honorable Dr. Geeta Pillai, to kindly felicitate our chairpersons. Please remain seated. Thank you for patient listening. Now I request our organizing secretary, Dr. Shailesh Kore, to kindly come onto the dais. I request our president and secretary also to remain onto the dais, please. I also call upon our chairman of Kmacon, Dr. Sai Prasad, onto the dais, and our co-chairman of Kmacon, Dr. A.B. Patel, to kindly come onto the dais. I now hand over the mic to Dr. Shailesh Kore for the valedictory function.
महेश सरांना दे. गुड इव्हनिंग एव्हरीवन. शेवटी समारोपाची वेळ आलेली आहे. आपण थोडक्यात आवरायचे जास्तीत जास्त प्रयत्न करणार म्हणून मी स्वतःच उभारलोय की आपण बऱ्याच लोकांना आभार मानायचे आहे. कार्यक्रम यशस्वी करण्यामध्ये एक एक असं मोजायला पण येईना असं एवढ्या संख्येने आपले हितचिंतक आपले सहकार्याने फार मदत केलेला आहे. तर कोण चुकू पण नाही. चुकून जर कोणाचं नाव राहिलं तर सुरुवातीलाच मी क्षमा मागतोय. सर्वात सुरुवातीला आता आपण आदरणीय मान्यवर आपले आदरणीय अध्यक्ष महोदय, आपले ऑनररी सेक्रेटरी गीता, आमचे ऑर्गनायझिंग चेअरमन डॉक्टर साई प्रसाद आणि को ऑर्गनायझिंग चेअरमन डॉक्टर ए बी पाटील सरांना विनंती करतो की तुम्ही बरेच आपले पारितोषिक वाटायचे आहेत, बरेच मोमेंटोज आठवणी आपल्याला द्यायचे आहेत. त्यासाठी जरा स्टॅमिना थोडा 1-15 मिनिट फक्त जरा ठेवा. सर्वप्रथम आपण आता वेळ न घालवता प्राइज डिस्ट्रीब्युशन करतोय. 3 कॉम्पिटिशन्स आपण घेतलेत. त्यामध्ये फर्स्ट केस प्रेझेंटेशन. केस प्रेझेंटेशनचं सर्वप्रथम सर्व पार्टिसिपेंट्स कारण सगळ्या वेगळ्या स्पेशालिटीजचे होत आहे, सगळ्या वेगळ्या फॅकल्टी स्पेशालिटीचे होत आहे. पण आणि पीजीस प्लस आमचे होतकरू तरुण अगदी मान्यवर तज्ज्ञ सुद्धा त्यांनी सुद्धा सहभाग घेतलेला होता. अटीतटीचा सामना जरूर झाला सगळ्यांमध्ये, पण शेवटी पार्टिसिपेशन ह्यातच तुम्ही विजय मिळवला. म्हणून तुम्हाला जरी अवॉर्ड मिळाला नाही तर तुम्ही काय मनाला काय लावून घेऊ नका, कारण आम्ही केएमएने आदरणीय अध्यक्ष महोदयने आपल्याला पार्टिसिपेट केल्यामुळे आपला तो आदर ते देणारच आहे. सर्वप्रथम पेपर प्रेझेंटेशनची नावं मी घोषणा करतो. कोण जर नसतील तर त्यांच्या वतीने कोणतरी त्यांचं प्रतिनिधी यावं, त्यांच्यापर्यंत आपण पोच करायचा प्रयत्न आपण व्यवस्था करू. सर्वप्रथम केस पेपर प्रेझेंटेशन. द फर्स्ट प्राइज गोज टू डॉक्टर अनिकेत पाटील फॉर his topic on ophthalmology, his research study. So I'd request Aniket to please come on the stage. I'd request our Honorable President to please felicitate him. Second prize goes to Dr. Pritam Napa. I would request him also to please come near the dais on this side. इकडून तिथून ठीक आहे इकडून. To Pritam Napa, he is also from Aster Aadhar Hospital. Last minute entry, but he is directly has taken the second position. It's very good. Congratulations. And third prize, renowned oncosurgeon Dr. Nikhil Goloni. I'd request someone from on his behalf to please come and receive his award. Anyone can come from poster presentation. Dr. Maheshwar Shitole, am I right? Yes, he is coming to receive on his behalf. Think you give everybody, please give a big hand to all our participants. Now I would like to call out Dr. Parshuram Koli, doing PhD in anatomy, for his participation. I request our honorable dignitaries on the dais to please felicitate him. Parshuram, please come on the stage. Next, Dr. Amruta Thomke, madam. Dr. Amruta Thomke also is from D.Y. Patil Pathology Department. I think Ravi Shinde sir's student. I would request sir only to come. He is her guide. Please, you accept it on her behalf. Participate. Last but not the least, again, Dr. Sagar Kurunkar, oncosurgeon from Apple. His participation. Yeah, Mahesh. Next, we move on to the poster presentation. Took place from 12 to 1:30. Before that, I would like to thank Dr. Amol Kodalikar sir and Dr. Vinay Wagh sir for right in morning at 7:30. Both of them had arrived. We had a very Sorry. I forgot Dr. Prajakta for a paper presentation, participation to the tough competition between Aniket and Prajakta. Participation. Paper presentation. Poster presentation competition, first prize, Dr. Naina Rajan. She's student of Paritekar madam from CPR. Rajashi Shahu Chhatrapati Medical College. Second prize goes to Dr. Siddharth Agrawal from Wins Hospital, student of Dr. Santosh Prabhu sir. And third prize goes to Dr. Mahesh Shitole from Apple Hospital. अजून एक 10 मिनिट राहिले तर जरा टाळ्या वाजवून जरा स्वतःला एनर्जी मध्ये स्वतःमध्ये जरा निर्माण करा. I'd request Dr. Pritam Napa to come for his come and receive his participation certificate. He participated also in the poster competition. Very creditable. And Dr. Sri Krishna Kumtankar, he also participated in the poster competition. And Dr. Parshuram Koli, he also participated in both competitions. He's also from CPR. He's Wasim Kazi, Dr. Wasim Kazi's student, Dr. Bansade and Dr. Wasim Kazi's student. सगळ्यांनी झाडं जपून ठेवा. झाडं फार महत्वाची आहेत. आपली आठवण म्हणून आपल्याला सर्वांना देण्यात येते. यानंतर आता क्विज कॉम्पिटिशन क्विज कॉम्पिटिशनचं विनर जो डॉक्टर साईप्रसाद सरांनी निवडलेला आहे, जे जो बंपर ड्रॉ होता, डॉक्टर मनाली मिठारी. To Manali Mitari. Give a big hand for Mitari sir himself is accepting.
Correct answer, but we again with a part.
I would request Dr. Shekhar Gotne sir and Dr. Prasad Halkarnikar sir, please do the honors for flash. Sanjay Gotne sir and Dr. Prasad Halkarnikar. Okay, then we are distributing the Dr. Vinay Wag sir has been selected for the best academic article in our KMA Flash for the year 2020-2021. The big hand for Dr. Vinay Wag sir. And non-academic article, I think sir has left. Dr. Arun Dumale will receive it on behalf of Dr. Raj Holkar sir. He has been felicitated for his non-academic article. On behalf of Dr. Raj Holkar sir, Dr. Arun Dumale sir is receiving it for the best non-academic article. I request the honorable dignitaries on the dais to please have a seat. On behalf of the organizing committee, to start with, we would like to, as a moment of thanks on behalf of our organizing committee. First of all, I would request the organizing chairman, Dr. Sai Prasad sir, to please give a moment of thanks to Dr. Abasaheb Shirke, our honorable president, KMA, and Dr. A.B. Patil sir to please give a memento to Dr. Geeta Pillai on behalf of the organizing committee. He झाडं जपून ठेवा सर, ते सोडून जाऊ नका, घरी लावा. Dr. Sai Prasad will give to Dr. Abasaheb Shirke sir and Dr. A.B. Patil sir give to Dr. Geeta Pillai. गीता एकत्र फोटो घ्या. डॉक्टर शीतल देसाई सर फार व्यस्त कार्यक्रम आहे त्यांचा. व्यस्त कार्यक्रमामुळे ते बाहेर गेलेले आहेत. त्यांना मी स्वतः त्यांना नंतर देईन. आता आभाराकडे वळूया. आभाराकडे मी न चुकता पटपट नाव घ्यायचा प्रयत्न करेन, पण मनपूर्वक आपल्या सर्वांचा आभार मी मानतो. सर्वप्रथम आमच्या आदरणीय ऍडवायझरी डॉक्टर PM चौगले सर, डॉक्टर रवी शिंदे सर, आपलं मार्गदर्शन मौल्यवान होता. आम्हाला संधी दिल्यामुळे, आम्हाला ऑर्गनायझिंग कमिटीवर विश्वास ठेवल्यामुळे आपल्या दोघांचे मनपूर्वक आभार सर दोघांना. त्यानंतर आपले संघटनेचे उपाध्यक्ष डॉक्टर आशा जाधव मॅडम आणि माझे इमिजिएट पास्ट प्रेसिडेंट डॉक्टर संदीप साळुके सर, आपल्या दोघांचं सुद्धा मनापासून आभार आमच्या सगळ्या ऑर्गनायझिंग कमिटीतर्फे. विसरू शकत नाही. काल पण नाव घेतलेलं, आज नाव घ्यायलाच पाहिजे, कारण त्यांनीच मला पुढे यायला संधी दिली. माझे ऑर्गनायझिंग चेअरमन डॉक्टर साई प्रसाद सर आणि को ऑर्गनायझिंग चेअरमन डॉक्टर A.B. पाटील सर, या दोघांना आमच्या पूर्ण ऑर्गनायझिंग कमिटी सगळे ज्याने भाग घेतला, आपल्या सर्वांच्या वतीने, आपल्यासारखे ऑर्गनायझिंग चेअरमन आणि को चेअरमन असलं तर कुठलाही मोठा कार्यक्रम आपण घेऊ शकतो, हे आज सिद्ध केलंय. आपले नेतृत्व असंच राहू दे आणि पुढं आपण पण यावं. सर्व सहकारी ज्येष्ठ आदरणीय EC मेंबर्स, सहयोगी एक्झिक्युटिव्ह काउन्सिल मेंबर्स काही आहेत काही नाही आहेत, पण सर्वांना आमच्या ऑर्गनायझिंग कमिटीतर्फे माझ्यातर्फे आपला विशेष आभार. आपण सगळ्या स्तरावर सगळ्याच कमिटी, जरी आपली एक कमिटी असली तर आपण सगळ्या स्तरावर हा कार्यक्रम यशस्वी ठरला असं मी म्हणू शकतो, कॉन्फिडेंटली म्हणू शकतो. कारण प्रत्येकाचा हातभार लागलेला आहे आणि प्रत्येक ईसी मेंबरने फार धडपड केलेली आहे, फार मेहनत केलेली आहे. अगदी शेवटचा आता की ह्या क्षणापर्यंत प्रत्येक ईसी मेंबर धडपडतोय. तर आपल्या सर्व ईसी मेंबरचं सगळ्यांचं मनपूर्वक आभार. या कार्यक्रमाचं सूत्रसंचालन आपले ईसी मेंबर्सने जरी केला, पण शेवटी सूत्रसंचालन सगळ्यांना जमेल असं नसतो. ते खास शैली असायला लागतो, त्याचं वैशिष्ट्य असतात. ते नेतृत्व केलेलं आहे डॉक्टर अमर आडके सर, त्यानंतर डॉक्टर नीता नरके मॅडम, डॉक्टर रुपाली दळवी मॅडम आणि डॉक्टर अरुण देशमुख सर. या सर्वांचे चौघांचेही आपला विशेष आभार मानतो मी. त्यानंतर आपण ऑफिसचे आपले ज्येष्ठ पदाधिकारी, भोपाळी सरांनी व्यवस्थित म्हटलं मगाशी, आपले परमनंट अध्यक्ष एकच आहेत, हे आनंद चव्हाण अध्यक्ष असले ते, पण ते कटाक्षाने बारीक नजर ठेवून प्रत्येक पावलावर कुठलाही मोठा कार्यक्रम असला तर मार्गदर्शन करून आपल्याला मदत करतात, मार्ग दाखवतात. तर आनंदा चव्हाण आणि अभिजित राजपूत या दोघांचं आम्ही एक छोटासा मोमेंट देऊन त्यांचा आभार मानायचं मी विनंती करतो अध्यक्ष महोदयांना. आनंदा चव्हाण आणि अभिजित राजपूत प्लीज स्टेजवर या. बोलतो ह्याच्यानंतर शेवटी येते ते दोघांचे एकत्र मला कॉडलेच सरांना मी देणार होतोच म्हणजे सगळ्यांना, पण आपले एमओसी चव्हाणे, आपण सर्वजण आडके सर, अरुण देशमुख सर, नीता नरके मॅडम आणि रुपाली मॅडम, आपल्याला चौघांनाही विनंती करतो, आपल्याला मोमेंटो घेण्यासाठी आपल्याला झाड हे आता नवीन आपली सुरुवात झालेली आहे, नवीन ओळख झालेली आहे, नवीन आपल्याला भरपूर इथं KMA साठी किंवा संघटनेसाठी डॉक्टरच्या परिवारासाठी करायचंय. तर आपल्याला चौघांनाही विनंती करतो एकत्र तुम्ही स्टेजवर या. आपल्या सर्वांना आपण 2 दिवस किल्ला फार मोठा लढवलेला आहे, त्यासाठी आपलं विशेष आभार आणि अभिनंदन. सर्व 4ही मान्यवरांना मी विनंती करतो की त्यांनी प्रत्येकांना एक झाडं देऊन त्यांचं स्वागत आणि आभार मानावं. आणि सर्वांना आपल्या घरी घेऊन जायचंय आणि आठवण म्हणून ठेवायचंय. द्या की प्रत्येकाने एक द्यावं असं विनंती करतो. एका वेळेला सगळ्यांनी द्या. यानंतर कार्यक्रम असं सहजासहजी पार पडत नाही. सगळ्या मान्यवर फॅकल्टी ज्यांच्यामुळे शोभा वाढते, ज्यांच्यामुळं आपण असे कार्यक्रम राबवू शकतो, जे पुढे येतात आणि ज्ञान आपल्या समोर त्यांचं कार्य सुद्धा आपल्या समोर शेअर करतात, त्या सर्व फॅकल्टींचा सुद्धा मनपूर्वक आभार मानतो. जवळजवळ सगळे आता बहुतेक परत गेलेले आहेत, काही ऑनलाईन आलेले आहेत, पण प्रत्येक 16च्या 16 फॅकल्टीना आपल्या सर्व ऑर्गनायझिंग कमिटीच्या वतीने मी मनपूर्वक आभार मानतो. सगळ्या चेअरपर्सन्स, जे सेशनचे चेअरपर्सन्स, सगळे आपले EC मेंबर्स, काय ठराविक आपले बाहेरचे सुद्धा आपले KMAचे लाईफ मेंबर्स सुद्धा सगळ्यांनी सहभाग घेतला. कुणी कुठलंही केलं नाही, सगळ्यांनी मनापासून केलं. सगळ्यांनी मनापासून अध्यक्ष येऊन सांगून गेले जातात ते जसं असते. अध्यक्ष महोदय सगळं लिहिलेलं आहे सिरियल, आम्ही एक सिरियल ठरवलेला आहे त्या सिरियल नुसार घ्यावं लागतो. तर सगळ्या चेअरपर्सन्स जे सगळ्यांनी जे 8 सेशन जे चेअर केले त्या सर्वांचं सुद्धा मनपूर्वक आभार. असंच आपलं सहकार्य प्रत्येक आपल्या अशा सेशनमध्ये अशा शैक्षणिक कार्यक्रमामध्ये आपलं सहभाग असावा. सर्व ज्युरी मेंबर्स परत एकदा मी ज्यांनी पोस्टर कॉम्पिटिशन आणि केस पेपर कॉम्पिटिशन मध्ये ज्युरी म्हणून राहिले डॉक्टर केळोकर सर, डॉक्टर वसंत देशमुख सर, डॉक्टर अमोल कोडोलीकर सर आणि डॉक्टर विनय वाघ सर, या चौघांचे मनपूर्वक विशेष आभार. MMC ऑब्झर्वर्स तर खास आहेतच, विशेष आहेतच, आणि हा कार्यक्रम फार विशेष पद्धतीने राबवला गेलेला, त्यांच्या उपस्थितीत त्यांच्या आशीर्वादाने फार चांगल्या पद्धतीने आता संपन्न होत आहे. त्यामध्ये आपले आदरणीय मार्गदर्शक आणि ऍडवायझरीचे चेअरमन डॉक्टर PM चौगले सर, MMC ऑब्झर्वर म्हणून लाभले सर, आपला मनपूर्वक आभार आपल्या सर्व ऑर्गनायझिंग कमिटीच्या वतीने. त्यानंतर डॉक्टर संदीप कदम सर, मला वाटते ते थांबले होते शेवटचं सेशन पर्यंत, त्यांचं सुद्धा आपण विशेष आभार मानतो ऑर्गनायझिंग कमिटीच्या वतीने. याबरोबर आपल्या कार्यक्रमात बरेचसे आपल्या हॉस्पिटलचे आपले ओनर्स, NGOs, ट्रेड कंपनीजने सहभाग घेतला. त्यांचा आम्ही एक छोटासा कार्यक्रम, आम्ही एक सेशन चालू असताना आम्ही त्यांचा विशेष आभार मानलेला आहे. तरी आपल्या समोर नावं 100% घेऊ इच्छितो त्या कंपनीजची. एम्ब्लोझॉन लाईफ सायन्सेस, मेडिलिंग डिस्ट्रीब्युटर्स, ओमकार डिस्ट्रीब्युटर्स, मॅनिकाइंड, अबॉट GI प्रायमा, अबॉट GI मॅक्झिमा, झायडस, रिमॅक्स इन्व्हेस्टमेंट्स, ॲस्मिरा, कोरोना रेमेडीज, मायक्रो लॅब, ज्या हॉस्पिटल्सनी पुढाकार घेतला आणि आपल्याला भरपूर ह्या कार्यक्रमास फार मोठी मदत केली आणि त्यांची लाभली. न्यूक्लियस इमेजिंग सेंटर जे काल पेट स्कॅनचं लॉन्च होतं त्याने आपल्याला फार मोठ्या प्रमाणे सहकार्य केलं. आज सकाळी आपले आदरणीय माझे गाईड आहेत डॉक्टर अविनाश सोनवणे सर, जे मुंबईहून लाईव्ह होते, ॲटॉमिक एनर्जी रेग्युलेटरीचे सेक्रेटरी, त्यांच्याकडनं आपल्याला आदर लाभलेला आहे. ऑर्थोच्या ग्रुपमधनं नॉर्थ स्टार हॉस्पिटल, ऑन्को ग्रुपमधनं कोल्हापूर कॅन्सर सेंटर, श्रुतेगा डायग्नोस्टिक्स लॅबोरेटरी, बॅरियाट्रिक ग्रुपमधलं डॉक्टर विवेक कुलकर्णी सर, कार्डिओलॉजी ग्रुपमधनं डॉक्टर युवराज पवार, एंडोक्राईन ग्रुपमधनं डॉक्टर दोशी सर आणि फॅमिली, रिमॅटॉलॉजी ग्रुपमधनं कुणाल पाटील आणि डॉक्टर वासिम काझी, गॅस्ट्रो ग्रुपमधनं अमित मायदेव सर, डॉक्टर दीपक पाटील, ह्युंडाई ऑटोमोबाईल्स मधनं शीतल देसाई सरांचा मोठा वाटा आहे, त्यात मोठा सहभाग. की राजन गुन्हे सर, ते स्वतः आले होते काल, त्याने आपल्याला फार मोठा सहभाग, त्यांचा विशेष आभार. विन्स हॉस्पिटल, डॉक्टर संतोष प्रभू, डॉक्टर सुजाता प्रभू मॅडम, या दोघांचे विशेष आभार मानू इच्छितो. आपल्या आदरणीय आणि आपल्या लाडक्या सेक्रेटरी डॉक्टर गीता पिल्ले मॅडम, जानकी हॉस्पिटल तर्फे आपला सहभाग लाभला. न्यूरो ग्रुपमधनं आणि आपल्या आदरणीय ऑर्गनायझिंग चेअरमन आमचे ज्येष्ठ सहकारी डॉक्टर साई प्रसाद, त्यांच्या डायमंड हॉस्पिटलच्या वतीने, आणि 100% माझा सहभाग होता, म्हणजे वारणेचा सुद्धा सहभाग होता. तर असं सर्वांचा NGOsचा मी विशेष आभार सर्वांच्या वतीने मानू इच्छितो. यानंतर परत आपल्या आदरणीय मान्यवरांना विनंती करतो की आपले ज्याने आपल्याला फार मोठा हातभार लावला, शेवटी इव्हेंट मॅनेजर आपल्याला सगळ्यांना वाटत नाही पण गरज पडतो, 100% गरज पडतो. त्यातला तयारीतला पाहिजे, अनुभवी पाहिजे. 100% 2 महिने भरपूर महेशला सहन करायला लागला, इव्हेंट शेअर प्लॅनर्सला, कारण माझ्यासारखं ऑडिटर, माझ्यासारखं ऑर्गनायझिंग सेक्रेटरी, मागच्या माग पाठ सोडणारा न सोडणारा, ते इव्हेंट शेअर प्लॅनरचा त्यांचा सुद्धा एक छोटा मोमेंटो देऊन त्यांचा महेश दामनकर आणि त्यांच्या टीमला विनंती करू त्यांनी स्टेजवर यावं आणि मान्यवरांना विनंती करू की त्यांनी त्यांचं फेलिसिटेट करावं आणि मोमेंटो द्यावं आणि आभार मानावं आपल्या वतीने. इव्हेंट शेअर प्लॅनरची टीम सर्वांनी जोरात टाळ्या वाजवावं, कारण त्यांनी हा दिमाग चांगला सोहळा जो दिसायला सुद्धा आहे लाईव्ह आणि ऑनलाईन, हे ह्यांच्याशिवाय शक्य झालं नाही. त्यांच्यासाठी जोरात टाळ्या आपण वाजूया. हे ब्रँडिंग जे आपलं केलेलं आहे, डिझाईन सगळे केलेलं आहे, जे डिझायनिंग केलेलं आहे सचिन वारणोळकर, इव्हेंट शेअरचाच भाग आहे पण त्यांनी स्वतःहून तो स्वतःचा त्याचा तो स्वतः डिझायनर आहे आणि तो ब्रँडिंग करतोय. सचिन वारणोळकरांचं सुद्धा खास त्याचं स्वतः व्हाईट विंग्स म्हणून त्याचं स्वतःच कंपनी त्याने आपली ब्रँडिंग केलेलं आहे. अगदी व्यवस्थित चांगल्या पद्धतीने त्यांनी केलेलं आहे. तर महेश त्यांच्या वतीने स्वीकारेल. 2 सर्टिफिकेट आहे. एक तुम्ही द्या, एक त्यांना. त्यानंतर आपले जे ऑडिओ व्हिडिओ जे आपलं आता बहुतेक बरेच महिन्यापासून बाबासाहेब सरांनी आपला नवीन एक प्रयोग आपला केला आणि तो यशस्वी ठरला असं म्हणायला हरकत नाही. फार चांगल्या रीतीने हे ऑडिओ ग्रुप जे पुढे आले आणि आपल्याला चांगल्या रीतीने सहकार्य केलं, चांगलं आपलं प्रेझेंटेशन पूर्ण महाराष्ट्र बाहेर सुद्धा जे झालेलं आहे, आपलं प्रदर्शित झालेलं आहे, इकडं सुद्धा जे आहे ते साई फोटो स्टुडिओ, साई फोटो अँड व्हिडिओ, विश्वास कोरे आणि त्यांची टीम, त्यांना मी विनंती करतो की त्यांनी वर यावं आणि मान्यवरांना विनंती करतो त्यांनी त्यांचं आभार मानावा. हे विश्वास बरोबर हे निलेश आणि विक्रांत हे दोघांचं सुद्धा, ज्यांनी स्टेज सांभाळ, मॉनिटर सांभाळे, त्यांचं सुद्धा आहे का अजून 2 घेणे. निलेश आणि विक्रांत पटकन मला वाटतं स्टेजवर यावं. एक सर्टिफिकेट आणि मोमेंटो, त्यांचं विशेष आभार आपण ते देऊन आपण मानतो. यानंतर योगीराज टीम इथंच थांबावं असं वाटतं. योगीराज साऊंड सिस्टीमच्या वतीने रमेश सुतार, त्यांची टीम, तुम्ही पण या एका वेळेला, तुमची एकत्र टीम, सगळ्यांनी एकत्र काम केलंय. तुमचं स्वतः सर्वांनी ह्या ठिकाणी सगळ्यांनी एका वेळेलाच राहावं. या रमेश सर, रमेश इकडे. अजून आहे पुढं. अजून संपवलेलं नाही, अजून संपलंय. त्यानंतर स्टॅमिना फार जोरात असलेले आपले फोटोग्राफर यशवंत पारकी आणि त्यांची चिरंजीवानी सुद्धा फार मोठा सहभाग प्रत्येक वेळेला असतो. या वेळेला त्यांना बरोबर जरा त्यांना बांधून ठेवायला लागला आम्हाला, पण तरी त्यांनी सुद्धा फार मोठं योगदान दिलं. यशवंत पारकींचा त्यांचा खास आभार माना, त्यांना सर्टिफिकेट आणि आपल्या मोमेंटो देऊन त्यांचा सत्कार करा मी विनंती करतो. पारकी साहेब स्टेजवर असताना वायचळ काका मीडिया पब्लिसिटीची जबाबदारी आपण फार मोठी सांभाळली. तर आपण स्पीड न्यूजची प्रतिनिधी म्हणूनच आम्ही धरतो. स्पीड न्यूजची प्रतिनिधी, केएमएचे जरी प्रतिनिधी असाल तर मीडियामध्ये आपलं स्पीड न्यूज म्हणूनच ओळख आहे. तर स्पीड न्यूजच्या वतीने आपला सुद्धा आम्ही आभार आणि सत्कार करतोय. नाही देख मी करतो. चला कुंड्या कोणी इथे सोडून जायचे नाहीत, घरी घेऊन जायचे सगळे. नंतर अभिजित, आनंदा, आपल्या संदीप भाले, सुनील भाले आणि आपला संतोष ऑफिसचे आपले 4 चौघांनी एका वेळेला स्टेजवर उपलब्ध आहेत. इथं अध्यक्ष महोदय आपले आनंदा आणि अभिजित या, तुम्ही त्यांना कृपा करून त्यांना द्या. चौघांचे सर्टिफिकेट्स आहेत, जोडीने सर्टिफिकेट तुमचे आनंद आणि अभिजितचे दिलेले आहेत. बाले स्टेजवर या, लोक पळत या. बालेना अजून ट्रेनिंगची भरपूर गरज आहे, पण शिकतील ते लवकर. हे आपले केएमए ऑफिसचे आधारस्तंभ म्हणायला पाहिजेत, रखवालदार म्हणायला पाहिजेत, त्यांचा विशेष आभार. त्यानंतर सगळ्यात महत्वाचं हॉटेल सयाजी, ज्यांच्या आपण असं भव्य दिव्य असं सोहळा असं करू शकतो, कार्यक्रम असं आयोजित करतो, त्यांचं पण फार मोठं वलवन सहकारी. आणि आपल्याला अगदी ज्या पद्धतीने करायचं होतं आर्थिकदृष्ट्या कुठल्याही सगळ्या दृष्टिकोनातनं आपल्याला ज्यांनी सहकार्य केलं, त्यांचे बँक्वेट मॅनेजर, पहिला चीफ मॅनेजर रक्षित साहेब, त्यांचे रोहन पारकी फ्रंट मॅनेजर, अपर्णा साळुखे जिने फार आपल्याला मदत केली, आणि मिस्टर तुषार त्यांचे बँक्वेट मॅनेजर, त्यांनी आमच्या KMA कडनं एक आठवण म्हणून मोमेंटो म्हणून आपलं स्वीकारावं. आदिनाथ मे त्यांचे बँक्वेट आपलं जेवण जे सर्व करत होते ते बरेच वर्षापासून असतात, त्यांचं ते मॅनेज करतात. आपला विशेष आभार सयाजी हॉटेलचं. आणि पुढच्या वेळेला लक्षात ठेवा, असंच ह्याच पद्धतीने सहकार्य असू द्या. 5 मिनिट संपते, 2 मिनिट. सगळ्यात महत्वाचं, आपण जे वर्ल्ड वाईड आपण गाजावीचं आपण गातोय की 400-500 लोक बाहेर बघतायत, वस्तुस्थितीने 312 का 320 लोक आज लॉग इन झालेले आहेत आपले. म्हणजे प्रत्यक्षात जो 750 ते 650 पर्यंत आपले प्रत्यक्ष आकडे वाढून वगैरे काय सांगत नाही, फिजिकल प्लस हे आकडे आपले जवळजवळ 650-700 पर्यंत झालेले आहेत. पण ज्याने आपल्याला घडवलंय, आणि शीतल देसाई सरांचं खरोखर त्यांना सल्यूट करायला पाहिजे. त्याने आपल्याला शेवटच्या घटकेला त्याने आपल्याला गाठून दिले. हे राहुल चौबे, त्यांना विशेष ते मुंबईत आहेत, पण त्यांना आपण फक्त लिंक पाठवला. 24ला आपण मध्यरात्री आपण ते लावलेला, म्हणजे आपण लिंक शेअर केला. आणि आजपर्यंत आपल्याला सांगायला हरकत नाही की 325 का 326 आपले रजिस्ट्रेशन ऑनलाईन झालेले आहे फक्त 3 दिवसात. म्हणजे KMAचा प्रोग्राम, म्हणजे KMA तसं पूर्ण, आणि सगळ्या IMA ब्रांचेस महाराष्ट्रातल्या सगळेमध्ये सर्क्युलेट झालेले आहे. बरेच ऑर्थो, फिजिओलॉजी बरेच ग्रुप्स वरनं सर्क्युलेट झाले अजूनपर्यंत. आज सुद्धा आता दुपारपर्यंत लोकांना, कारण 4 क्रेडिट आवर्स पाहिजे होतं. काल पण सांगितलं सर, मानाचा मुजरा, म्हणजे MMCचं खास विशेष अभिनंदन आणि आभार मानायला पाहिजे. का? कारण आपण एकमेव अशी कोल्हापूर मेडिकल असोसिएशन, जी डॉक्टरची फ्रॅटर्निटीची फिजिकल गॅदरिंग जी झालेली आहे, एकमेव गॅदरिंग अशी झाली, आणि महाराष्ट्र मेडिकल काउन्सिलने कोल्हापूरलाच निवडलं आणि कोल्हापूरलाच दिलं. त्यामुळे आपल्या सर्वांचं कोल्हापूर मेडिकल असोसिएशनचं हे गर्वाची गोष्ट आहे. तर कोल्हापूर मेडिकल असोसिएशनसाठी फार मोठं, सर्वांनी जरा टाळ्याने मोठ्या प्रमाणे वाजवा. आपले सोविनियर ज्यांनी काढलंय, डिझायनर आणि आपले प्रिंटिंग काढलेलं आहे, त्यांना विसरून चालणार नाही. वेळेत डिझायनिंग, मला वाटते शेवटचे 3 दिवसात आपलं सगळं तयार झाला, वेळेवर आपल्याला दिला. आपला डिझायनर आहे जो फ्लॅशचा करतो, सचिन मुळे, तो आलेला नाही, त्याला बोलायचं मी माझ्याकडनं राहिलं. आणि श्रीपाद ऑफसेटची श्री RD पाटील साहेब आणि त्यांचे चिरंजीव कोणाल पाटील साहेब, त्यांना आम्ही मोमेंटो आम्ही स्वतः पोच करू. त्या दोघांचं सुद्धा मनपूर्वक आभार मी आपल्या सर्वांच्या वतीने करू इच्छितो. आणि कोण या क्राऊडमध्ये आपल्या ज्यांनी सहकार्य केलं नाही, काल केलं की सर? तामनकर सरांनी फार सुंदररित्या, पवित्ररित्या आपल्या कार्यक्रमाची सुरुवात केली पसायदान म्हणणं. हे आपण सगळे गुंतलेलो होतो. एक आपल्याला मला वाटते 5 मिनिट कसा गेला, आपल्या इतका सुंदररित्या गेला, आपलं डोकं शांत होऊन आपण कार्यक्रम सुरू केला, म्हणून शांतपणे अजूनपर्यंत आपलं राहिलेलं आहे. तामनकर सरांचा विशेष आभार आपण मनापासून मानू. त्यांच्याकडे सुद्धा आपण मोमेंटो सुद्धा त्यांना पण मला वाटते AB पाटील सरांच्या वतीने आम्ही पाठवून देतो. त्यानंतर कोण म्हणला? आणि दिनेश आणि त्यांची टीम, काल जे आलेले टीम, मी गीताने आणि शीतल पाटील, दोघे नेते मंडळी आपले जे आहेत, तरुण नेते मंडळी, त्यांनी फार सुंदररित्या, म्हणजे ऑर्केस्ट्रा बघावं तर असली ऑर्केस्ट्रा बघावं, गाणे ऐकावं तर अशा लोकांकडनं गाणे ऐकावं, म्हणजे अगदी मेस्परायझिंग वातावरण झालेलं. इथं गर्दी फुल भरलेली. मला वाटते आपला कुठला EC मेंबर, कुठले ऍडवायझरी, कुठले माजी अध्यक्ष, कुठले ज्येष्ठ सदस्य नाचले नाहीत. जे गाणं म्हणायच्या ऐवजी, कारण गाण्याला बंदी होती, पण जे नाचायला बंदी नव्हती, पण सगळ्यांनी जे डान्स केला आणि एन्जॉय केलं, तर ते खास श्रेय त्या ऑर्केस्ट्राला जातो. त्यांचा सुद्धा आपण विशेष आभार आपल्या सर्वांच्या वतीने मांडू. त्यानंतर ह्याच्या व्यतिरिक्त जर अजून कोण माझ्याकडनं जर राहिला असेल तर त्या सर्वांचं मी ज्याने आपल्याला मार्गदर्शन केलं, मार्ग दाखवला, आपल्याला प्रोत्साहन दिलं. नाही अजून आहे सर, एक मिनिट, माझं संपत आहे की झाले की बँकेट सर. झोपलायस काय तू? आई काय नाही बोल. आनंदा अध्यक्ष म्हटले मी, आम्ही अध्यक्ष वेगळ्या भावनेने म्हणतो. थोडं प्रोटोकॉल तिथं पण आपण पाळू. शेवटी माझं आता आभार प्रदर्शन संपत असताना मी शेवटी जे उभा राहिलो, गेला वर्ष माझ्यासाठी फार कठीण होता, पण मला हे संधी दिली आबासाहेब सरांनी. मला बाहेर यायला फार मोठे एक वाव मिळाला. या जगात पुन्हा आणि परत चांगल्या रुळावर मी येऊ शकलो. माझ्या आदरणीय वडिलांना मी विसरू शकत नाही. ते मला सोडून गेले, ह्या आपल्या सर्वांना सोडून गेले ऑगस्ट महिन्यात. त्यातनं मी बाहेर आलेलो नव्हतं, फार मोठ्या धक्क्यात होतो. पण ह्या कॉन्फरन्सच्या निमित्ताने आपल्या सर्वांच्या मार्गदर्शनाने, प्रोत्साहनाने मी पुढे येऊन हा कार्यक्रम राबवू शकलो. त्यांचं सुद्धा मी मनपूर्वक आभार मानते की त्याने मला डॉक्टर केलं, शिकवलं आणि आपल्यासारख्या लोकांमध्ये वावरायला मला संधी दिली. त्यांचा सुद्धा मी मनपूर्वक आभार मानतो. माझे मिसेस आणि माझे 2 मुली जे मला सहन करतात, 2 दिवस आलेले नाही, घरी आलेले नाही, 2 महिने ह्याच्यात राबवत होतो, लक्ष देऊ शकलो नाही. कामं सगळं काय, वारणेला अजून मी गेलेलो नाही, पण मी 2 महिने पूर्ण वेळ KMA ला मी जे म्हटलं, एकदा शब्द दिला तर पूर्णपणे जेवढा आपल्याला जमव तेवढा आपण प्रयत्न करू. तर माझ्या मिसेस रुपाली आणि माझ्या मुली साक्षी आणि राशी दोघांचे मी मनपूर्वक आभार मानतो आपल्या सर्वांच्या वतीने. आणि कोण नजर चुकीने जर राहिला असेल माझ्याकडनं आभार मानायचं, तरी सुद्धा सर्वांचं परत एकदा अगदी सर्वांचं मनपूर्वक धन्यवाद करतो. असाच आशीर्वाद असू द्या, असेच सहभाग असू द्या, असंच आपल्या थीमनुसार मार्चिंग टुगेदर टू बिल्ड अ हेल्थियर वर्ल्ड सगळे डॉक्टर आपले परिवार एकत्र आणू आणि हा असेच कार्यक्रम असेच चांगले घोडदौड चांगले राहू दे डॉक्टरांसाठी. जय हिंद, जय महाराष्ट्र.
थँक्यू शैलेश. Kmacon ऑर्गनायझिंग कमिटीने एक सुंदर खेळमेळीच्या वातावरणात एक अत्यंत सुंदर कॉन्फरन्स आयोजित केली. त्याबद्दल मी आमचे प्रेसिडेंट डॉक्टर आबासाहेब शिर्के सरांना विनंती करते की त्यांचे आपण सन्मान करूया. डॉक्टर साई प्रसाद सर, ऑर्गनायझिंग चेअरमन. सायंटिफिक सेशन्स खूप छान झाले. को चेअरमन डॉक्टर AB पाटील सर. Advisories, please. Organizing Secretary Dr. Shailesh Kore. आणि आमचे सर्वांचे आधारस्तंभ डॉक्टर आबासाहेब शिर्के यांचे पण मी आभार मानते. कार्यक्रम समाप्त झाल्याचे मी घोषणा करते. धन्यवाद.